That will be part of what we reflect on and what we learn from. But there is much more on offer. We'll be talking about climate change and health, developments in immunotherapy, the role of schools in child and adolescent health, and as always, we'll have the expert-led WISH reports. In total, there are more than 300 speakers in 50 diverse elements, from debates and panels to workshops. Before we join the proceedings in Doha, here's a glimpse of what you can expect to experience over the days to come via this online platform. Well, wherever you are in the world, we hope that you make the most of the wealth of content on offer at WISH, which is this year under the theme, One World, Our Health. As ever, WISH is far beyond a conversation within healthcare. It's also about the best possible ideas and innovations, wherever they come from. Do please use the hashtag #VirtualWish2020 to help them travel even further. And now, as WISH is an initiative of Qatar Foundation, let's cross to Doha and the gathering at the Qatar National Convention Center.
Your Highness, Sheikh Hamouza bint Nasser, Chairperson of Qatar Foundation, Your Royal Highnesses, Your Excellencies, dear guests, good afternoon and warm welcome from Doha to WISH 2020. I am Hamad Al-Hijji, a graduate of Weill Cornell Medicine in Qatar, which is a member of Qatar Foundation, and it will be my privilege to guide you through our program today. As we experience the effects and aftermath of living through global pandemic, it has never been more vital for us to come together and harness the power of dialogue and innovation to overcome challenges that is made in the global healthcare. It is only fitting then that we are united this year by WISH under the banner, One World, Our Health. Since its very beginning, WISH has played a unique role in the global healthcare community. In our previous biennial summit, we brought together over 2,200 delegates, including researchers, policymakers, entrepreneurs, and medical practitioners from 116 countries to share evidence-based ideas and best practices. Now, at a time when healthcare is at the center of the world's attention, we are expanding our community even further. Through our first ever virtual summit, we are enabling a much larger audience to be part of the conversation. Whether you are joining us online or in person, this is truly a global gathering. The one thing we all share in common, however, is a belief that we can use this platform to work together and build a healthier world. And now I would like to invite Professor the Lord Darzi of Denham, the Executive Chair of WISH, to share his opening remarks and set the stage for what's to come.
Your Highness, Your Royal Highnesses, Your Excellencies, distinguished guests, ladies and gentlemen, Assalamu alaikum. Welcome to WISH 2020. I'm delighted so many of you are joining this virtual conference organized by WISH. These are extraordinary times. We meet in the middle of the greatest health challenge in more than a century. The virus have stopped WISH participants from meeting in person in Doha, but your presence online here today proves that nothing can keep us apart. 2 years ago, there was a real doubt about whether WISH 2018 would go ahead, as many of you may recall. Qatar had been under an illegal siege from land, air, and sea blockade imposed by its four neighbors, a blockade which regrettably has remained in place ever since. Despite the blockade, Qatar remained open to the world, and the most successful conference went ahead. Today, the world is under siege from SARS-CoV-2, the virus that has claimed more than 1 million lives, wreaked terrible suffering, and created a global crisis. But that has not stopped WISH, and I'm sure it will not be long before we meet again together in Doha. That's because our mission at WISH is to bring people together, to develop, promote, and disseminate innovations that can transform our world. The leaders of health reform and creators of innovation have come together once again to share ideas, celebrate successes, and shape our collective future. This community exists thanks to the energy and vision of Her Highness Sheikh Moza bint Nasser, the chairperson of Qatar Foundation, and the unwavering support of Her Excellency Sheikh Hind bint Hamad Al Thani, Chief Executive of Qatar Foundation. They have our lasting thanks. In less than a year, COVID-19 has spread from China to almost every place on Earth. There have now been nearly 50 million cases, and more than 1 million people have died. It has been a bigger hit to the world economy than the financial crises of 2008. And its social costs have been enormous, from poverty to loneliness. Everyday life has been disrupted everywhere. It has been painful for people across this planet. Yet, we have also seen the best of humankind. Healthcare workers have responded with extraordinary dedication and professionalism. They have put their own lives at risk to help their patients. And many have sadly paid the ultimate price. We pay tribute to every healthcare worker at the front line in this global pandemic. Here in Qatar, the whole health system rapidly mobilized and acted decisively with active case finding, testing, and contact tracing. This is a testament to the outstanding leadership of Her Excellency Dr. Hanan Al-Kuwari, Minister of Public Health, who leads the government's health response to COVID. Although Qatar had a high infection rate, it has achieved one of the lowest case fatalities rates anywhere in the world. That is the result of high-quality care delivered by Hamad Medical Corporation and Sidra Medicine. I also wish to acknowledge the tremendous contribution by Primary Healthcare Corporation under the leadership of Dr. Mariam Abdul Malik in building the capacity of managing COVID patients in the community. In so many ways, the pandemic has revealed the best of us. Scientists around the world have come together in unique collaboration to defeat the virus. Internationally renowned researchers have joined forces with governments and global pharmaceutical and biotech companies. Together, they have decoded the virus genome, discovered effective tests and treatments, and developed potential vaccines, all in a record time. The stunning news from Pfizer that their vaccine is 90% effective gives hope that the end of the pandemic may be in sight. It shows what humankind can do. Health systems, too, responded with extraordinary speed, expanding intensive care, redeploying staff, and ramping up infection control. Family doctors are providing consultations by telephones, video links. Hospitals are running clinics remotely using a range of digital tools. We have discovered that we can deliver a lot of healthcare in a very different way. It has shown us what is possible when we put our minds to it. And it has taught us that there can be no security in life without health security. Just as other times of crises, the world has come together to say, never again. We must be as determined once more. That's why I believe it's time to build a global pathogen shield to protect us from novel disease. A new global capability to rapidly develop diagnostics, therapies, and vaccines. The only way to do that is through a greater international collaboration, which is exactly what WISH is all about. The prospects of global cooperation in the fight against COVID have dramatically increased with the election of Joe Biden as the next president of the United States. President-elect Biden is passionate about science and about healthcare. And I know this personally from his interest in cancer research. And he has already announced a new COVID task force. But COVID is not the only health threat. This year, we again welcome some of the most exciting, original thinkers who will speak about health challenges we face. In the coming days, we'll explore an enormous breadth of topics. I wish to take a moment to thank Sultana Afdal and the Global WISH team in developing this exciting program and its excellent content. We will discuss the impact of climate crises on health, from the particular challenges of dry cities to increasing threat from communicable diseases in a world affected by global heating. We will explore how to protect our health systems from cyber attacks, to how the world can safely enjoy sporting events, such as the Olympics in Japan next year, or the World Cup here in Qatar in 2022. We will be discussing how to care for millions of children suffering toxic stress as a result of the conditions in which they live. We will explore how to deploy and disseminate innovations from immunotherapies for cancer to digital mental health. I know at the front of your minds will be how to overcome COVID. As the virus has spread, it has reminded us of our human fragility. But, as with all crises, it has reminded us too of our common humanity. It has demonstrated the power of science and the cardinal importance of research. It has shown us that to defeat the virus, we must work together. And working together at the frontiers of innovation is what WISH is always about. I hope you have a fantastic few days, and I look forward to when we can all meet together in this wonderful city of Doha. Thank you. It is now my privilege to introduce Her Highness Sheikha Moza. Your Highness, you are known as the icon and the driving force of progress, reform in both health and education in Qatar. Your personal contribution, your command of the detail of policy, your advocacy on behalf of the people of Qatar for better health and care is well known in this region and around the world. You are the driving force behind WISH. As well as being the chair of the world-famous Qatar Foundation, you chair Sidra Medical and Research Center, a groundbreaking hospital, research and educational institution. In actual fact, it is celebrating its 2nd anniversary of opening. Your globally significant contributions to education has been recognized at the highest levels. As the UN Special Envoy, an Alliance of Civilization Ambassador, and a member of the Steering Committee of Global Education First Initiative. The Education Above All Foundation, which you established in 2012, has enabled more than 10 million children in developing countries to access education, an achievement that will have an impact for decades to come. Your voice has been prominent in current crises as part of Rise for All, a global advocacy initiative that calls for solidarity and urgent action in response to the socio-economic impact of COVID-19. Your Highness, we thank you for your enduring commitment to WISH and for enabling this virtual conference to take place in these extraordinary times. Your Royal Highnesses, Your Excellencies, distinguished guests, ladies and gentlemen, please join me in welcoming Her Highness Sheikha Moza bint Nasser for the official opening of WISH.
Thank you. السلام عليكم. أرحب بكم مجددا في وش بعد أن اضطرتنا الظروف الصحية الاستثنائية إلى عقده عن بعد. وقد أثبتت جائحة كورونا أن صحة جميع القطاعات اقتصادية وتعليمية واجتماعية وغيرها تتأثر بأحوال القطاع الصحي وكان لنا بالطبع أن ننتظر جائحة لنولي قطاع الطب أهميته المركزية في البنية التحتية للتنمية الشاملة. قد شهدت العالم كله خلال هذا العام كيف تجلت مظاهر هذه الحقيقة
become more and more apparent throughout the world this year. In this context, the importance of this summit lies in the exchange of ideas, research and discoveries, in the sharing of solutions and the promotion of successful experiences and effective policies, discussions that will drive growth in the healthcare sector. Ladies and gentlemen, just when we thought the present had surpassed the past with its technological and scientific advancements, after the COVID-19 outbreak, the world received a catastrophic and epidemiological lesson that put leaders, scientists, researchers and physicians in a difficult position as they work to discover and develop a vaccine to save humanity from the imminent threat on its health and way of life. In the midst of these trying times brought on by the pandemic, WISH is convening this year to elevate our sense of collective responsibility and unite the world as one, to work together, to share knowledge, to contain this pandemic and to minimize the damage until it is possible for scientists and researchers to restore the health and safety of people everywhere. And so, I salute healthcare workers in Qatar and globally for their tremendous efforts in fighting this pandemic, protecting lives, and tirelessly striving to create a better, healthier world. Ladies and gentlemen, it is said that during major events in history, heroes are made and the knights emerge. There's no doubt that healthcare workers are the knights of this historic moment. They are the stars our youth should emulate in their altruism, in their dedication and involvement in the health and research sectors. Lastly, challenges come in different shapes and sizes. We have faced several obstacles before that we have successfully overcome or contained. But what the world is facing today is a challenge that is completely new in kind, magnitude, and impact. A challenge that requires us to take unprecedented action in kind, magnitude, and impact in order to successfully confront the COVID-19 pandemic. I wish you every success as you face these exceptionally challenging times. Thank you so much.
Thank you, Your Highness. Building on the message of global collaboration and unity shared by Your Highness, here is a short video to celebrate the spirit of all of us coming together for building a healthier world and facing the ongoing COVID-19 pandemic with resilience, courage, and empathy. On this note, we would like to mention that we have some of our healthcare heroes present among us today. We would like to express our gratitude to you for your efforts in fighting the COVID-19 pandemic and for the sacrifices you have made to keep us all safe. Thanks to you, we continue to be resilient in the face of global challenges, and we are able to convene here today for WISH 2020. So many of our debates around healthcare get bogged down in numbers and technicalities. But ultimately, we need to remember that our humanity should be at the core of everything we do. I would like to invite you to watch the artist Thamer Ad-Dosari, who is creating a graffiti art piece for Wish 2020. Thank you, Thamer, for being with us today. Thank you, Thamer, for creating this artwork with which we now officially initiate the World Innovation Summit for Health, Wish 2020. We hope it inspires global action and collaboration to work towards a better tomorrow for everyone. And now I would like to hand over back to Michelle Hussein, who is joining us from London to lead us through the next segments. Thank you.
Thank you. And wherever you are in the world, please do familiarize yourself with the platform, especially the ways to participate in discussions, including the chat function at the side of each live session. You can use that to put your questions and comments to the moderators. If you've been part of previous Wish gatherings, you'll soon find your way around this one. Right now, you're watching the Al-Tabari Theatre live stream, which is one of the two main theatres for the summit. This is where you'll find some of the key 2020 topics through panel discussions, keynotes, and interviews throughout the week. There's a separate series of sessions in the Ibn Sina Theatre, including daily masterclass lectures, policy briefing debates, and our agoras, informal gatherings for discussions on health-related issues in the news. In the coming days, the Innovation Hub will act as the digital equivalent of the Wish exhibition space. That's where you'll find booths with Wish partners and innovators, everything from solar-powered medical devices to using recycled plastic to pay for health insurance to predicting pandemics through AI. Your questions on all the innovations will be answered on the Spotlight stage. And then there's the library, where you'll find reports and publications linked to the Wish topics, and a cinema space with short documentaries that take you to the heart of global health stories. Now, in a few minutes here in the Al-Tabari, our first panel discussion will take stock of a year of learning about COVID-19 and consider the next stage of action against the virus. But first, this look at those who have been and remain on the front line.
Last night, I fell asleep on the sofa again.
Couldn't go home. Had to replace a colleague who felt sick.
Today was exhausting. Our shifts never seem to end. And the gear we have to wear really isn't helping.
This woman's relatives cannot visit. Right now, we're all she's got.
My young brother asked me this morning, why haven't you saved the world yet?
My surgical training didn't prepare me for the things I'm doing now. But we all have to do what's needed of us. And work as part of a team.
There's always someone to cheer you up.
Someone to care.
Someone to give you hope.
We are united in our efforts.
And we'll succeed.
Together.
Together.
Together. Together.
Together.
Together.
Together.
This has been an extremely challenging year. But right across the world, we have been witness to great courage, cooperation, and compassion. If we keep working together, we will heal. One word, our health.
Your Highness Sheikh Moza bint Nasser, Your Excellency Dr. Hanan Mohammed Al-Kuwari, Minister of Public Health of Qatar, Excellencies, dear colleagues and friends, Assalamu alaikum wa rahmatullahi wa barakatuh. First of all, I would like to offer my deep thanks to Her Highness Sheikh Moza for her leadership to support for health throughout her career and as chairperson of the Qatar Foundation. The COVID-19 pandemic is an unprecedented crisis that demands an unprecedented response and unprecedented innovation. Necessity is the mother of invention, and since the earliest days of the pandemic, people all over the world have found new ways to work and connect. Innovations in science and technology are also helping us to respond to the pandemic. More than 200 vaccines are now in development, and we're starting to get the first results for some of them, an incredible achievement in less than a year. But we also must ensure that all countries enjoy the benefits of innovation. That's why WHO and our partners launched the Access to COVID-19 Tools Accelerator, an innovative approach to ensuring fair allocation of vaccines, diagnostics, and therapeutics. Even before the pandemic, the world was off track for the Sustainable Development Goals. Now we're even further behind. But COVID-19 has shown why the SDGs, with their sweeping vision for people, planet, prosperity, peace, and partnership, are so important, and why we must pursue them with even greater determination, collaboration, and innovation. The pandemic is a once-in-a-century crisis, but it's also an opportunity to harness the power of innovation for the healthier, safer, fairer, and more sustainable world we all want. I thank you. Shukran jazilan.
Thank you. And Dr. Tedros sent us that message from his home, where he is currently self-isolating. Now, our panel will bring together people playing a role in the fight against COVID from different vantage points and different parts of the world. Here's Her Excellency Dr. Hanan Al-Kuwari, Qatar's Minister of Public Health.
I'm delighted to be here today to participate in this important panel discussion. The title of this year's wish is One World, Our Health, and in that spirit, I would like to share with you Qatar's response to the COVID-19 pandemic. We have drawn on the knowledge and experience freely shared by other countries, and for that we are grateful. Now we would like to share our experience in turn. Here in Qatar, we faced a significant epidemic of COVID-19, which peaked on the 20th of May. Despite the large number of cases, our health system was never overwhelmed. Our hospitals and intensive care units remained open throughout. Every death is a tragedy, but we are thankful that our total was low in global terms. our case fatality rate is 0.15%, one of the lowest in the world. This is a tribute to the talent and commitment of our doctors and nurses and the whole healthcare workforce. It is also a testament to the high quality of our healthcare system. His Highness the Emir of the State of Qatar, Sheikh Tamim bin Hamad Al Thani, directed the Council of Ministers to take a whole government approach to the pandemic. This was led by the Supreme Committee for Crisis Management. From the outset, it was clear that our response had to be timely and coordinated across government. We developed a National Response Action Plan with clear lines of authority and the integration of our plans. It relied on science and evidence and a careful balance of health and business needs. We carefully planned and executed a phased partial lockdown and reopening of restrictions. We knew soon after the epidemic began that 14% of COVID patients would require admissions to hospital and 5% would need intensive care. We opened nearly 3,000 acute care beds and 227 ICU beds and secured extra ventilators. We made provision to treble the ICU beds to 749 if necessary. We transformed an entire general hospital into an intensive care hospital and redeployed hundreds of staff. We have treated nearly 2,000 patients with severe COVID-19 in our ICUs since the start of the pandemic, of whom nearly 90% have been discharged. To contain outbreaks, we opened 24 isolation facilities with a maximum capacity of 30,000 beds and 60 quarantine facilities with a capacity of 15,000 beds. These included hotels, guest houses, and camps. Our infectious disease team drew up treatment protocols based on the latest evidence, and new drugs were continuously added to our formulary. Today, the epidemic has stabilized in Qatar. We have not seen a second wave, but we remain alert. There have been a small number of outbreaks, mostly associated with family gatherings, which we have controlled with active surveillance and contact tracing. We have expanded our laboratory services and can now provide 20,000 tests per day, 10 times the number at the start of the epidemic. A key factor in our success is our system of universal health coverage. All costs of treatment were covered by the government, irrespective of nationality or social conditions. All patients received the same high standard of care. Our low mortality is attributable to a variety of factors, including the young age of the population, but particularly to the high quality of medical care provided equally to everyone. Throughout, we strived to keep our healthcare workforce safe and protected, and our hospital-acquired infections as close to zero as possible. For non-COVID patients, we continued to provide care remotely, taking advantage of the extensive connectedness of Qatar today. Patients received their medication by post, with over 250,000 prescriptions delivered to date. This was a gigantic effort, but we could never have controlled the epidemic without the help and support of the people of Qatar, who observed rules of mask wearing and hand hygiene and limits on public gatherings. Consequently, we never needed a full lockdown. Sharing information is vital. We worked to deliver clear messages through traditional and social media, as well as sharing data at the international level. We know we will win this battle only if everyone wins it. In solidarity, Qatar has so far helped more than 70 countries and international organizations with equipment and resources. COVID-19 is not beaten yet. Our strategy remains one of vigilance and focused action, tempered by a controlled return to normality while keeping our people safe. We await, with the rest of the world, the development of a safe and effective vaccine. In the meantime, we must rely on the public health measures with which we are all familiar. and on the dedication and professionalism of the global healthcare workforce to keep us safe. As many countries around the world experience a second wave, sharing experiences becomes even more vital. Thank you for joining us today to share your experience and your expertise.
Thank you, Your Excellency, Dr. Hanan. And now a warm welcome to Dr. Anders Tegnell, State Epidemiologist of Sweden, Professor Dame Sally Davis, former Chief Medical Officer for England and UK Special Envoy on Antimicrobial Resistance, Dr. David Nabarro, Co-Director of the Institute of Global Health Innovation at Imperial College London and WHO Special Envoy on COVID-19, Dr. Janil Putticherry, Senior Minister of State in Singapore's Ministry of Health and also in the Ministry of Communications and Information, and Her Excellency Ekaterina Tikaradze, Georgia's Minister of Health, and she also has other responsibilities within her portfolio. Thank you all for being with us. Dr. Nabarro, is it possible for you to say that we are yet globally past the peak of this virus with tens of millions of cases around the world?
Thank you, Michelle. I have to say that we are not past the peak. In fact, the numbers of new cases being reported to WHO are accelerating. And we've had 10 million new cases in less than a month, going from 40 million to 50 million. And not only are the numbers of new cases accelerating, but also, I'm afraid, the numbers of reported deaths have picked up in the last 3 weeks, 10,000 extra deaths per week. So altogether, this pandemic is still very much on the advance. And in some places, the virus is surging back into countries and communities from which it had been effectively removed.
That is a very sobering assessment. Let me turn then to the perspective from the three countries represented on the panel. First, Singapore. Dr. Janil Putticherry, Singapore was widely praised for its response to the virus from very early on. How concerned are you by what the next stage could involve?
Well, there's still quite a lot of uncertainty, and we're still working out what it is we need to do on a global basis to defeat this. In terms of the strategy to reopen our economies, get travel going, vaccinate the population that needs it. But first of all, Michelle, thank you very much for inviting us to participate in this discussion and giving some ideas of what we can learn from each other, and also perhaps an opportunity to share our strategies in Singapore. I just want to highlight three key strategies and three key initiatives which I think are useful to put on the table for discussion. In terms of our overall strategy, three key considerations. The first is a calibrated approach towards opening our border controls based on assessed risk. Not a zero risk tolerance, but an assessed, balanced approach, a calibrated approach. The second is an aggressive case-finding process. Early detection through enhanced surveillance, testing everybody with acute respiratory symptoms, and active case finding around known cases. And the third is a strategy of containment, isolating every confirmed case that we can find and their close contacts, as well as ensuring that everybody will have access to medical care. There are some initiatives that we're taking within this larger picture of a strategy. I thought I might mention three. The first returns me to the issue of a calibrated approach towards our border. We're an entrepot city dependent on global trade, flows of data, people, ideas. And so closing ourselves off to the world has really not been a serious possibility. And so we've had to take what we would say is an evidence-based approach, balancing the economic and public health considerations, but not to have a single approach to different jurisdictions. Take a tiered approach, a risk-assessed approach on the basis of what we can understand is happening in those jurisdictions, and then therefore opening up reciprocal green lanes, different travel measures, different even types of quarantine, whether it's a 14-day quarantine, a 17-day quarantine, whether it's a quarantine in a government-mandated facility or a stay-at-home process. And for some select jurisdictions, merely a swab and reporting a contact number. So that information flow is important for us to be able to take that risk-assessed approach. The second initiative I would like to highlight is the extent to which we've used technology to augment our public health contact tracing efforts. We've got Bluetooth proximity logging, as well as a national check-in system. And we feel that contact tracing, aggressive contact tracing, is a key to our public health response. The third initiative that I'd like to highlight is something that we started very early on, even in the midst of significant uncertainty, is an aggressive approach towards information dissemination and transparency. Actually, just as this was starting, I got pinged on my WhatsApp. We have a regular feed that goes out to every citizen that signs up, telling them how many cases we have, how many suspected problems we have, where these cases are located. And getting that information out has been key for our citizens to then participate in many of the strategies that we've implemented. We have a long road ahead. I look forward to the rest of the discussion and learning along with the rest of the guests here today. Thank you, Michelle.
Let me turn to the perspective from Georgia and Ekaterina Tikaradze, the Minister of Health. You have had a low number of cases relatively overall, but a sharp increase in the number since the beginning of September. Tell us first about the biggest challenge that you faced on COVID this year and the single biggest lesson you've learned.
I would like to take this opportunity and greet the honored guests and audience. I believe that it is crucial to develop communication and share experience among countries. I will briefly summarize experience of Georgia dealing with the COVID-19 pandemic. Georgia has timely and correctly assessed the risks associated with the virus and has used all mechanisms to prevent the virus from spreading within the country. The government launched the first phase of fighting the pandemic a month before the first case of virus was confirmed. An intensive communication campaign was also launched to prevent the spread of the virus and to raise awareness and social distancing. The slogan, "Stay at home," was active for this period. Support of international and donor organizations to mobilize financial and technical assistance and to mitigate the effects of the crisis should also be noticed. I would like to take this opportunity and express special thanks to all the donor organizations and international partners, financial institutions, and diplomatic missions for their efforts and support rendered to the ministry to efficiently respond to COVID-19 pandemic. Following the successful completion of the first phase of the pandemic in early summer, an important task for the government of Georgia was to maintain a positive outcome after the restrictions were eased and to prepare healthcare and social systems to deal with challenges of second wave. In particular, in order to fight the coronavirus effectively and in a coordinated manner, the Interagency Coordination Council was established as a main decision-making body on coronavirus issues. Prevention and management of coronavirus in the country is carried out according to the following scheme. Quarantine areas are allocated for suspected COVID-19 cases of coronavirus, the costs of which are fully covered by the states. Individuals with fever and respiratory symptoms are administered by family physicians and village physicians prior to confirmation of COVID-19. As for the management of coronavirus mild forms at home, so-called online clinics were developed on the basis of primary healthcare centers. In order to prevent overuse of emergency services, a central online management center staffed by medical university graduate students and residents has been set up, which together with an emergency service hotline 112 stratifies calls, redirects them and monitors the actions taken. There are also so-called COVID hotels in the country where infected patients are transported under the supervision of medical staff. Assessment of hospitals' readiness of infectious control and critical management of possible COVID-19 cases has been conducted across the country. A hospital mobilization plan has been developed. Mobilization of additional health facilities and inclusion in COVID management process is gradually ongoing. Currently, more than 6,000 beds are mobilized across the country, and more than 2,500 beds are planned to be mobilized if needed. With lifting of restrictions at the beginning of tourist season, amid increased mobility, a gradual increase in cases was predicted in regions where mobility was particularly intense. Currently, the number of new cases 839 per million. However, without any exaggeration, we can say that the model developed by the ministry and the clinical team allowed the medical staff to efficiently control the virus.
I'm going to turn now to Dr. Anders Tegnell from Sweden to get a sense of the experience there, because Dr. Tegnell, what you did in Sweden stood out in contrast certainly to your neighbouring countries and indeed to many other parts of Europe. How do you reflect then on the approach that you took in the early part of this year and now, and the lessons you've learned?
Thank you very much, and thank you for inviting me into this really fantastic panel. Several of the members said already, I think this is a very important part of it, that we can share experiences, and that's how we can, I think, get further in this. Yeah, I mean, the experience in Sweden is a little bit different from many other countries. We had a massive influx in February and March in Sweden. Like many European countries have, about 10% of the population in Sweden is traveling abroad during a couple of weeks during that time. And that meant that we have a huge influx of cases from basically all over the world, but mainly from Europe, who were infected. Our health system managed to keep the containment in place for a few weeks, but was then overwhelmed, and we had to go over into mitigation phase, where we basically try to flatten the curve, the classic pandemic concept of trying to minimize the burden on the health system and the burden on the society as a whole. We managed to do that, I think, in a way with a mixture of regulatory issues, where we focused regulatory issues on areas where we knew there was a high risk of spread of the disease, like restaurants, major big events, and so on. While in many areas, we instead moved on having a collaboration with the public, which has also been mentioned before, how important that is. And we managed to do that really well. I mean, the public has been very supportive. 80% of the public has sort of followed our advice. The trust in the agency and the way we are working things have been around 75-80% all through this pandemic. And from a peak in April, we managed to get the number of cases down during the spring and summer to very low levels, among the lowest in Europe for a while. So this approach, and we can also show that the approach in many ways were just as effective as in many other countries where they instead used legal measures to achieve basically the same things. Travel stopped in Sweden, 40% of the population worked from home. Many things came into place. And there was also a number of incentives put in place to make it possible for people to follow the advice. Then during the fall and so on, now we see, as we have seen in many European countries, a resurgence of the disease in Sweden again. We are much better prepared now. We know a lot more. Our health system that has been working very well all through this. There has always been empty ICU beds. It's never been overwhelmed. And the results from the Swedish health system has been very successful, I would say. So now everybody's much more prepared, but we do see a rapid increase of cases, a few weeks, maybe a month behind many other European countries, but it's coming also to Sweden. And now we are trying to again focus on voluntary and regulatory measures, especially in areas where we see a high level of spread of the disease. Right now, mainly in private parties, mainly in workplaces, and that's why we focus our efforts to get people to change behaviors. So in practice, I would say that Sweden has had a kind of virtual lockdown, a more precise lockdown than maybe many other countries, because it's been focused on risk areas. But in many ways, it's also been very similar to what's happening in other countries. And we don't know what's going to happen. This is going to be a long fight. And I think one of the main things we need to think about that we need sustainability, because it's not going to be over for quite some time yet. Like Dr. Navarro said, we are probably not even at the peak of this, and we're going to have to keep on fighting this together for a long time. Thank you.
Dame Sally Davies, you're a long-time friend of the WISH community, and you stepped down from your role as England's Chief Medical Officer, just in a short space of time before the pandemic set in. Before we hear from you, I'm going to take you back to something that you said at WISH in 2016, because you did share some lessons then from the flu pandemic exercise that you had been part of in the United Kingdom. So let's hear first from Sally Davies speaking at WISH back in 2016.
We've just had in the UK a 3-day exercise on flu, on a pandemic that killed a lot of people. And it became absolutely clear that we're one of the countries with great readiness that we could not cope with the excess bodies, for instance. What were we going to do? So we're now developing plans. But if we, who are supposed to be one of the most prepared countries, could, going through an exercise, find a lot of things that need improving just on the internal bit, add to it the vaccines, and then the increased global traffic that we have, and the lack of solidarity that WHO did pretty well in the 2009 pandemic, but a severe one, and that was mild, will stretch everyone. It becomes very worrying about the deaths, as Larry Summer says, and then what that will do to society as you start to get all of those deaths. We're back to anthropology. And then the economic impact.
Dame Sally, you must have reflected a lot in recent months about that exercise and what you thought of it then.
Yes, and clearly in speaking at WISH in the past, I was prescient. So thank you, Michelle, for highlighting it, and my thanks to WISH and the Qatar Foundation for bringing us together. I've been following the great progress, world leading, from Sidra Medical Center and Qatar Biomedical Research Institute. Clearly, those institutions are exemplars of Qatar's strong response. We're all here today because we care about tackling global health challenges. And we're talking about responding to COVID-19 so far. And what I want to say are two things on that and then take us forwards. The first is, it is quite clear to me that everyone on this call and almost everyone across the world is acting in good faith. And we are all learning as we go. There was an article only this week in Nature showing the role of restaurants. We did not have that evidence before. We didn't have digital as we have now before. And I think I want to raise two other problems now to put on the table. The first is, as many of you will know, I've been concerned about antimicrobial resistance. And here we are with what I call the lobster of COVID, dropped into boiling water and making a dreadful noise as it dies. But actually, as well, we've got this lobster put in cold water, heating up slowly, making no noise at all, antimicrobial resistance. And it's going to kill more people. And we know that during COVID, people are using more antibiotics, and the antimicrobial resistant bacteria look as if they're going up. So we need to attend to that silent growing pandemic as well. We must not forget. And the response to both is strengthening health systems, it's data. And we've been through the Fleming Fund from the UK Aid, helping 22 countries build their laboratories and surveillance for AMR, but that has been deployed to support COVID response too. But the other thing I think it's worth picking up at this point is, of course, science moves on. And what we need now in our response, and I think Singapore talked about it very beautifully, thank you, Minister, is that collision between data science and public health, and how we harness this and do things differently. And so I, with a number of colleagues, universities from Singapore, Imperial College, but a lot of the private sector, have convened a collaboration, the Trinity Challenge, in fact, to do this sort of work. We hope we'll learn something that'll matter now, But what we're really interested in is 3 core activities that will improve our use of data and analytics and, importantly, our understanding of human behaviour in response to health emergencies, so we're better prepared going forwards. As the Trinity Challenge, we've launched a public challenge to incentivise and reward the best thinking. We're convening work and we're doing thought leadership pieces on data. So I invite people to join the Trinity Challenge, but I also highlight the need for behavioural evidence and using the data. Thank you.
Yeah, I'm going to go back to David Nabarro in just a second, but Dame Sally, but just before that, I mean, why was it the case that the UK, given that it was having these training exercises for pandemics, and given that SARS had happened, why was the exercise focused around flu rather than a coronavirus?
It was judged by everyone who was expert in this field that we were much more likely to get a flu pandemic than anything else. We did, of course, do desktop exercises for MERS, for E. coli, for a number of things. But having watched the first SARS outbreak, which was very sad, there was a feeling from the experts that actually that was unlikely to pose a significant problem for Britain. We were wrong. I wish we had done more and different preparation as well.
David Nabarro, you outlined just how perilous the path ahead is. You know, 2021 could be another very, very difficult year, despite positive developments on the vaccine front, which I'm sure we'll come to in a moment. But is it your fear that the next phase of this will be harder, partly because the shock has worn off, partly because of public fatigue, partly also because of the imperative to get economies moving again?
Well, Michelle, thank you. Just let's look at Europe. The resurgence, as Anders Tegnell has just said, is really dramatic, and it's happening across most countries in Western, Central and Eastern Europe. Look at what's happening in the US. We've got record numbers of cases being reported and hospitals overloaded in different parts of the country. We've also got a virus picking up again in other continents, and it's our view in the WHO that it's super important that no government assumes that the job is done. No, the job is going to remain to be done. There's also no real alternative here. We have to hold the virus at bay. Simply letting the virus do what it wants to do will create major problems, probably much greater than we can actually anticipate. And so we're encouraging all countries to maintain firm defences, to bring their people on side, to interrupt transmission quickly as soon as it starts up, as we heard from Singapore and we heard from Georgia, and then to do everything possible to keep their economies going. Because if pandemic is associated all the time with lockdown, then we have really a very unfortunate future ahead of us, because we will be seesawing between surges in cases and then lockdowns, and that will have very, very bad effects. So what we have to do, as Dr. Tegnell said, is find ways to engage with public so that at all times everybody understands the steps that individually they need to take to stop this virus building up. It's going to be tough. And with people in certain countries actually almost doubting the existence of the pandemic and certainly critiquing the responses that are being taken, we have some difficult months ahead. Thank you.
We have a lot more to get through in our remaining time, so I'm going to ask everyone, please, to keep their answers as brief as possible so we can get as many thoughts from all of you in. So Dr. Janil Putticherry from Singapore, almost everywhere in the world wants to learn from what you've done on test and trace. But it strikes me that your success in that area, a big part of that comes from the kind of society Singapore is, does it not? And also the fact that you are a wealthy country with a small population. How transferable are the lessons from what you've done?
Thank you for the question, Michelle. It's important. I'm personally of the opinion that some of the lessons are certainly transferable. transferable. I think you identified a key issue, which is that resources are needed. This is not something that any jurisdiction can do without adequate resources. But really, we were able to implement these strategies because of past investments. I think far more important factor than the character of our population, which is, I think, a throwaway cultural reference to explain what is actually, I think, a fairly complex public health response. I would just give one example for that. Every part of our healthcare system was mobilized towards a pandemic response, not because it's one organization or one entity or one company. We have a private healthcare sector that flourishes. There's a fair amount of competition. We have a public sector which dominates care for the lower income and at the tertiary and research end. And yet we were able to, through a collective effort, bring all of this together, deploy PPE, strategies for protection, and test kits so that everybody with a respiratory illness was able to have a COVID-19 test. Now, I can't say we did this day one when the pandemic first struck, but it was clear that we needed to do so, and it was the investments made in our healthcare system by our forebears and our forefathers that we then leveraged on to then ramp up that capability very, very quickly. I think the key transferable message is that this virus must be addressed and tackled, not dealt with passively. And I think there are a number of societies which don't have the good fortune that we have had in terms of resources that actually have done a very creditable job by implementing very simple, fundamental strategies with that mindset. Back to you, Michelle.
Could you also address, though, how it has been called a pandemic of inequality in Singapore, in that there have been a much higher number of cases amongst the migrant worker population who are living in dorms than they have in the rest of the population. Those are the lowest earners in society. In some cases, they've ended up being kept locked down while the rest of society returns to normal.
Well, certainly we did have an outbreak within our migrant worker dorms. The reason for that, I don't believe, was an issue with their wages or inequality. There are Singaporeans who have similar issues with their salary, and lower income vulnerable Singaporeans. It is the conditions that they live in, which is akin to a cruise ship. And in a cruise ship, you do not have issues of low income. And everybody has a fairly well-appointed room, bathroom, perhaps a sea view, but it is the cramped and close quarters that have allowed the transmission within a cruise ship. And the cruise ships have had a similar rate of transmission as have our migrant worker dormitories. So the issue of the wage distribution is really not the key here. It is the living conditions, the closeness with which people have associated with them. Nevertheless, we committed to providing every single migrant worker the full range of healthcare available to every Singaporean citizen within our tertiary facilities. And we forward deployed medical posts to help them. We provided them free Wi-Fi entertainment, as well as a stipend to look after them, because they have to then look after their families. So we don't shy away from the fact that we wish the outbreak in our migrant worker dormitories didn't happen. When it happened, we deployed every asset and resource available to us to make sure we got on top of it. So far we have, but I think complacency, which was one of the key issues brought up in the earlier discussion, is a problem, and we must assume that such an incident can happen again as long as people are living in close proximity to each other. And we as an island have one of the highest population densities in the world. So it was a matter of chance, I think, where that outbreak happened. It could happen anywhere in Singapore.
Anders Tegnell, hindsight is a wonderful thing, and I'm not asking you to have hindsight, but I wonder if you, knowing everything that you know now, what decisions would you have made differently earlier this year? Because Sweden is starting to move further towards the mandatory rather than the entirely voluntary approach to social distancing that you had in the beginning.
Thanks. I mean, that's a good question. No, we're not moving more into mandatory, but we are really enforcing the advice we are given even more, because even in Sweden there has been, even if the population is really following our advice to a great extent, it has been not as good as it was this spring. We can see that people went back to working in the office more than we did before. Dame Sally talked about data. We have a lot of interesting data on where we can follow mobile phone operators and see how many people working from home. We get data from our shops to see how much people are buying things and so on. And that went up. And now when we go out and reinforce our messages, especially on local level, because working on local level is very important in Sweden, we do see a very rapid response from the population. People go back to working from home. People stop shopping. People stop traveling with public transport. So you need to do those things. You need to go back and reinforce. And now when we see a upsurge of cases again, we need to go back and try to get, once again, the population with us to do this. And I think it looks like we are doing the right thing now, because we do see a lot of those early signals telling us that people are moving back to the way they lived in the spring, when we had quite a good response on this. Of course, there are many things that we wish we could have done different. I mean, everybody heard about the long-term care facilities in Sweden who were not at all prepared for this kind of pandemic, and we had a high death toll among them in early spring. A number of things have been done since then that we wish we could have done earlier, and now the death rate in those facilities are much lower. We wish that our healthcare system would have been much better equipped, because it's a lot of things that comes into the healthcare system that comes on a daily basis. We needed bigger stores and stuff like that. So there is a number of things that I'm sure we're going to discuss a lot in Sweden, how we can be better prepared in the future. And that discussion, especially when it comes to long-term care facilities, actually already started.
Dame Sally, is there evidence that antibiotics are being prescribed too much in dealing with COVID? I mean, I imagine as a virus, they shouldn't really be used at all, but are they being used to treat some of the symptoms? And do we have evidence about whether that does amount to a very worrying overuse?
You're absolutely right. People are using antibiotics because when patients go to the primary care doctor, not particularly ill but respiratory, they're being given at the moment antibiotics when it may well be that what they've got is COVID. And almost all patients who end up on ventilators, particularly in our first wave, have been treated with antibiotics in concern, which I absolutely understand, of course, that they've got secondary infections with bacteria. But it turns out that it is a minority that have a bacteria on top of the COVID. So yes, our early evidence is that there is overuse, and we need to ensure that we can provide laboratory backup so that they're appropriately used. But it's a result of very difficult decisions in the heat of the moment in this pandemic. And what it highlights is that we may end up with a bigger problem, but we also have an empty pipeline for new antibiotics. And so we need to make sure we've got sustainable pipelines and new antibiotics coming through, so that when people are put under pressure, they don't feel they're mortgaging the future of human health.
Well, from treatments or treatments that should be avoided, let's talk about vaccines and turn to the Georgian Minister of Health. Ekaterina Tikaradze, how confident are you that in Georgia you will get some access to a vaccine in the next 3 to 6 months?
The 2021 will be a turning point in the fight against coronavirus pandemic, both in the world and in Georgia. We have constant communication with the World Health Organizations and various international partners regarding the vaccine against COVID-19. On August 31st, the ministry signed a standard letter provided by COVAX Foundation regarding its involvement in the fund. Also on September 18, an agreement was signed between the government of Georgia and the Global Vaccine Alliance, which includes information on the country's commitment and deadlines. Georgia is also involved in the WHO Solidarity Research and works closely with the US and European Centers for Disease Control and COVID Management through its clinical management team. For the first time, digital technologies will be widely introduced in healthcare as well. All this gives us hope that next year, through vaccines, modern methods of treatment, adherence to the rules of infection control by the population, it will be possible to defeat the COVID pandemic.
David Nabarro, what do you think the guiding principles for the year ahead should be? I know you don't believe in one lockdown after another, but we're in the midst of a second wave in Europe. We've got a huge number of cases in the United States. There is that feeling of strong action being needed, being required.
Thanks very much indeed. Of course, there has got to be strong action, and the most important is to bring people on side everywhere, because there's no way to hold this virus at bay without the full involvement and active participation of everybody. And that's why trying to get the right balance between instructing, regulating, or even using force to get popular action versus encouraging people through building trust and engaging them in the response. Getting that balance right is so important. We're not going to be able to deal with this through regulations. There are things that we can all do to reduce the risk that we get infected by the virus. Everyone needs to do it. Secondly, public health capacity needs to be everywhere, because unless we can interrupt transmission quickly, outbreaks build up. Thirdly, all governments have got to start singing the same tune. It's rather bizarre that we have this enormous challenge that's wrecking national and even the global economy, and yet often we see governments working at loggerheads with each other, as though it's some competition. It's not. It's one foe, and the whole world has to be able to deal with it. Otherwise, the long-term consequences will be terrible. If there's anything that can come out of events like this, it must be greater solidarity between nations. And I hope that that can happen.
And is that helped by an incoming administration in the United States? I'm particularly thinking of the WHO's own position, given the testy time that it has had with Donald Trump in the last few months.
Well, I think that anything that can happen now to get greater willingness by leaders to work together is a good thing. Let me just for a second focus on some of the new technologies that are coming on board. You've mentioned vaccines. Do you know there's 186 countries out of 193 who are participating in the COVAX facility that George has just mentioned? This is amazing. 5.1 billion have been given, including 10 million from Qatar, to try to make sure that countries will be able to have access to vaccines through sharing the resources. There are 10 candidate vaccines in phase 3 trials. There's lots of new exciting developments on rapid diagnostics. I believe there's going to be some corners turned on therapeutics. It's that collaboration between countries, between scientists and between communities that will pull us through this, not only to be strong with COVID, but also to be strong on some of the other global threats we face that we're discussing in WISH this time, including climate change.
Yes, and I'll come back to Sally Davies in just a second on that point about what else, we should take away from this fight against the virus. But before that, Anders Tegnell, perhaps one of the real issues for 2021 will be the politicization of public health. We've already seen how mask wearing in the United States has become a political statement. Is there a real danger, do you think, that that will continue? Your example in Sweden is championed by some, denigrated by others. Is all of that something that couldn't be avoided given the extent of this and the differing approaches, or is it something that we could overcome?
I really hope we could overcome, because I think, like David Nabarro said, the collaboration at international level really is so necessary during this kind of crisis. And unfortunately, we haven't really seen the kind of collaboration that we, for example, saw during the swine flu pandemic. It was a lot milder, but we could also talk to each other a lot easier. And even in Europe, where borders are supposed to be open and we're supposed to collaborate in a lot of things, there's been major difficulties in reaching agreements on how we should deal with border issues and others. And I really hope that this will be a reminder to all of us how important it is that we resolve those kind of issues, and that we really can fight this together and not see it as a kind of competition, which I think, especially in Europe, we have seen at times, and I think that has been very unfortunate.
Is it going to be tricky, Dame Sally, for public health in 2021 to operate on the whole range of fronts that it needs to? In your time as Chief Medical Officer for England, you worked very hard not only on antibiotic resistance, but on things like obesity. Is there a danger, do you think, that the infectious diseases front becomes all-encompassing?
Well, I think one of the saddest things we're seeing is that people are not getting routine health care at the moment, in part because our health services are rightly focused on COVID, but also because patients and the public are very scared that they might catch COVID if they go into the health facilities. So we're going to need to sort that out. That needs trust, that we have arranged, safe areas, and that we're really waking up those parts of our health system. And I think we can do that. But we need trust across society. And that will extend in many ways. Going back to the risk factors for adverse outcomes, of course, obesity, diabetes, and these things double the risk of mortality. And so we do need to move forward on all of that. But I suppose my ask in Britain would be that we move to mask wearing. I think we can look at Singapore and Asia and see that they culturally accept mask wearing. And I think the evidence has been there since early June that you help others, and now that you help yourself. We should have much more mask wearing across the whole world.
David Nabarro, Sally mentioned mask wearing, and I wanted to ask you about the WHO's move towards officially recommending mask wearing. It came several months into the pandemic, when in Asia it was the instant reaction.
Yeah, the debate at the time was quite straightforward. There was a global shortage of good quality surgical masks. And the one thing that WHO was determined to do was not to have a situation where all the masks in the world would be bought up by rich countries or by people who'd got resources, and there would be insufficient supply for health workers in poor countries. I think actually, as this pandemic has advanced, there's been much better data available on the ability of masks to reduce the risks, both if somebody's got COVID and is communicating with somebody else, and also if somebody hasn't got COVID and is close to somebody who has. And that now is becoming much more widespread in terms of advice. And WHO is very clear. Everybody, everywhere, should be wearing masks if there is a risk of COVID, and there should be no question about it at all.
Even outdoors, is that what you would personally recommend?
Personally, I'm now recommending even outdoors. I think that might be going too far. This is, Michelle, because I am 71. I'm in the age range, which is really high risk. I do not want to get this virus if I can avoid it. That's why I'm taking an awful lot of care. And that does include wearing masks outdoors, certainly if I'm in a situation where there are a lot of people around who are infected. I live very, very much on the border between Switzerland and France. It's one of the most infected areas in Europe, and that's added to my own circumspection, my wish to maintain physical distancing, wear a mask, practice personal hygiene, and be extraordinarily careful about being in any event where I'm with people I don't know. I think we all have to do this now.
Well, thank you all for everything that you've shared as part of this panel discussion. Dr. David Nabarro, Dr. Janil Putticherry, Her Excellency Ekaterina Tikaradze, Dr. Anders Tegnell, and Professor Dame Sally Davies. Thank you all. And as this opening ceremony concludes, don't forget that in this Al Tabari Theatre live stream, you'll be able to see a discussion on climate change and health next, and later today, one on climate change and communicable diseases. Plus, you'll be able to hear from our first keynote speaker, Dr. Tom Catena. Please do familiarise yourself with the platform, which also allows you to record sessions to watch later. Thank you, and all the best for this Virtual Wish 2020. Now, 2021 should be a year of increased focus and action on climate change, with a big international summit due this time next year. There is a growing understanding of the impact that climate change is having on human health. But health systems and health professionals are arguably not yet prominent enough as advocates for what needs to be done. The WISH Climate Change and Health Forum discussion is going to take a fresh look at some of the key issues.
Hello, everyone, and welcome to this WISH Forum discussion on climate change and health. My name is Stephen Sacker, and it is a real pleasure for me to host what I think is going to be a fascinating hour or so of discussion. As Michelle Hussein said, a forum discussion lies ahead of us where we are going to look at climate change in the context of global health challenge. It fits so neatly into the overarching WISH theme this year, which is all about one world and our health. And if we think about the global challenges that we face when it comes to future health problems and challenges, then surely nothing can be more profound, more disturbing in many ways than the impacts of climate change. Let me begin by saying I wish I could be in Doha in person, as I've been for previous WISH conferences. It's a great shame we can't all gather together, but I know lots of you are watching right around the world. Welcome to all of you. A very special thank you from me to everybody in the WISH team, and of course to the Qatar Foundation and the leadership of Her Highness Sheikha Moza, who has again driven forward this conference. I know that everybody involved is so grateful for her leadership. I'm going to introduce you to our panel. We are then going to hear the presentation of the forum report coming from Dr. David Nabarro, whom we've already heard from today. David Nabarro, who is such a key player right now in the battle against COVID-19 in his role as a special envoy at the World Health Organization. But he has an incredible background in all sorts of different public health challenges. So I'm going to introduce David's forum report in just a moment, but let us go through the entire panel. I'll introduce you to everybody. And panelists, when you hear me read out your name, just give a little wave to the camera wherever you are around the world so that people know exactly who is who. So let's start with David himself. You've heard from him already today. He's co-director of the Institute of Global Health Innovation at Imperial College in London. And thank you for the cheery wave, David. We're going to hear your presentation in just a moment. Cristiana Figueres is a familiar figure to many of you. She was the driving force in many ways behind that incredible political and diplomatic achievement of getting more than 190 countries together to agree on the Paris Agreement on climate change, and the commitment to doing what it takes to decarbonize our world to ensure that global temperatures do not rise above 2 degrees centigrade. Indeed, the aim is to get them to rise substantially less than that. Whether we achieve it is something which may crop up in this discussion. But Christiana, thank you for joining us, and welcome to you. We have Elizabeth Iro with us. Now, Elizabeth has an extraordinary story to tell. She is from the Cook Islands. She was Secretary of Health in the Cook Islands, a small group of islands which, of course, is deeply vulnerable to rising sea levels as a result of climate change, and we shall talk about that. But right now, Elizabeth is Chief Nursing Officer at the World Health Organization and brings a vast amount of experience in the field of nursing to our discussion today. I also want to welcome Paul Farmer. Paul is the co-founder, chief strategist of Partners in Health. He is a highly experienced physician and indeed anthropologist as well, so brings all sorts of different life experience and academic experience to this discussion. I want to welcome Ali Al-Dabah, who is Deputy Director General of the Qatar Fund for Development. And it's great to see you here, Ali. I wish we were all with you in Doha, but sadly that cannot be. But thank you for joining our discussion. And finally, also with a Qatar perspective, please welcome Roberto Bertolini. Now, he is a senior advisor to Qatar's health ministry. He has a whole lot of experience in international public health. He served as the WHO chief scientist in Europe for some years. So we've got a fantastic panel full of insight and experience, and I'm looking forward to quizzing them, particularly on this question of how we ought to view climate change in terms of challenge to public health over the next hour. But what we're going to do first, oh, and I should say, by the way, before we hear from David and his introduction, I should say this discussion, it's guided by me, but it is going to be very interactive. I'm standing by with my smartphone, and I'm going to be fed questions coming from you from all over the world. So do feel free to participate on the Wish platform. We want to get your insights, experience, and questions woven into our discussion over the next hour. But let us begin by hearing the thoughts of David Nabarro, who chaired the forum panel, the experts who were put together to consider this whole question of climate change and health. So let's hear David's initial thoughts now.
Good day, it's David Nabarro here, and I'm delighted to talk to you about our report, Health in the Climate Crisis. It's a guide for health leaders. I'm personally working at the moment on COVID, and I think that what I've learned through COVID is that when we do come together, we can be effective on dealing with really massive issues. And the climate crisis is a big issue. So what we've done is we've written a report that addresses the authentic and authoritative roles that health professionals can have with the public and also with policymakers. We feel that the health lens focuses attention on the issues. It demonstrates what practical action is possible. We start by looking at how health is affected by climate change. We look at the direct impact of heat on people's health, on food and water insecurity. We look at storms and floods and how they affect health. We look at how climate change is affecting communicable diseases, increasing air pollution and changing the levels of allergens in the air. We look at the social and economic instability that happens as a result of climate change. And what we do then is to dissect out the different outcomes that come from these different threats and show that these are really serious. And over the top of all this, we look at how mental ill health is exacerbated by climate change. We go on to look at how health systems are affected by so many aspects of changing climate. We dissect them out into the disease burden, the way in which climate change affects facilities, and we also talk about climate change in the economy. And then we show how this affects the quality and impact of health services, the degree of coverage of populations, and the cost of providing health care. This takes us then into analysing the co-benefits of health and climate action. Well, first of all, we show that lives and well-being, as well as the efforts to sustain the planet, can both benefit as a result of working on some very specific areas, on clean air, on efficient energy, on transport, on diet, on safe births, and on green space. And by demonstrating the synergies, we, I think, help all health leaders to be able to move forward in a constructive way. And that brings us to the climax of our report. This is an index card on what health leaders must do. There are 10 points in this index card, and you know we'd really like you to cut it out and keep it, because we think these can be helpful. Here they are. The first 5 are about you. Be the change. Build resilience in societies to the health impacts of climate change. Go for green facilities and try to make sure that they're sustainable. Reduce waste in your healthcare activity. Steer your suppliers so that they supply in ways that are sustainable. And track the footprint of your own operations and those with whom you're linked to make sure that the climate impact is as low as possible. These are things that you, as a health professional, can do. And then you've got something that can go even further. You can actually lead the change, mobilize your workforce, highlight ways in which everybody can adapt to climate impact, invest for environmental well-being, valuing the environment at all times, create coalitions of action on climate and health, and make sure the air is clean, because the impact of clean air is so huge. You, health leaders, have so much to offer. You can bring ambition into the debate. You can be audacious. You are seen as authentic, and you are often called to account. And that's why we've done this report, and that's why we hope that you can become actors for health in the climate crisis. Thank you for listening.
A really positive opening statement there from David Nabarro. And David, I thank you very much for putting that together. And you presented us there with a checklist of things that you think that health leaders can do to make a real difference, and, to use one of your quotes, be the change. But I want to begin the discussion, Christina, with you, because it strikes me that we all know you from your work trying to get this Paris Agreement together, working so hard with senior politicians, diplomats, and with corporate leaders as well. They're the kind of people we associate with driving change in this field of climate debate. How important do you think that health leaders can be? How significant can their role be?
Well, thank you. Thank you very much. Good morning, good afternoon, good evening to everyone. And I must say thank you very much to Dr. David Nabarro for that report, and to everyone else who collaborated. David is one of my totally favorite people, and I had never had the pleasure of seeing David twice on the screen at the same time. So that actually is quite a treat, because I usually have him only once on my screen. So to have 2 Davids is quite delightful. But to your question, honestly, it is surprising that we don't have more health leadership on climate change, because I have been saying for a long time, and there is mounting realization about this, that the Paris Agreement may be thought of by some people as an environmental agreement. Actually, it is a health agreement. It is an agreement for the health of humans and the health of the planet, because we have to understand that those two health universes are one and the same. They're not separate. It is only on a healthy planet that we can aspire to have a healthy humankind living on that healthy planet. And there has never been a more compelling argument for this than during the pandemic that we have been having, where it has been very clear that because we have been moving into areas and deforesting, we have actually created these zoonotic diseases, and we will be creating many more zoonotic diseases. And that's just the deforestation part of climate change. But in addition to that, the 7 million people that are dying prematurely because of air pollution are dying substantially because of the burning of fossil fuels. The same fossil fuels that are polluting our lungs and are polluting the lungs of the planet. So we have to understand that this is one and the same issue, one and the same challenge. And that is why in May of this year, organizations that represent 40 million health professionals, including the World Medical Association, the International Council of Nurses, the World Federation of Public Health Associations, and the World Organization of Family Doctors, and the American Public Health Association, 40 million health professionals, wrote to the G20 governments requesting that there be a healthy recovery from COVID-19. We have to be able to bring the recovery packages that are being capitalized and are being invested. They have to be packages that are, yes, absolutely producing jobs, but they have to produce those jobs in the areas that give us clean planet for clean society. Now, finally, let me just say, in this COVID pandemic, we have seen and have read so often that the health professionals have been on the front line of the pandemic. That is true, and we're all very, very grateful to those who continue to be on the front line of the pandemic. But if you look at this just from a little bit more perspective, the fact is that health professionals are both on the front line of the pandemic, trying to do the curative, but they're also at the back, picking up the pieces and frankly cleaning up the mess of bad decisions that were made further up the pipe. So that is where this report is absolutely critical, because what the report calls for is for health professionals to move forward, to be in the front line, not just of curing the effects, but avoiding. We all know that avoiding is better than curing. Preventative decision-making is what we need, and there is no profession that knows more about the much higher value of preventative policy than the health professionals. So we are delighted with the report, and we hope that it's going to help to build a very strong platform under health professionals to not just pick up the pieces from other policy decisions in other sectors, but actually to be leaders and influencers in deciding on policy on climate change.
Well done, well done.
Great. Thanks so much for that, Christina. I want to cross now straight to Elizabeth, because Christina gave us a great overview there of why health leadership matters so much and the very widespread implications for public health across the world of climate change. I now want to drill a bit deeper into a very specific situation, which is yours. You are, as I said, a native of the Cook Islands. I believe I'm right in saying you served for some years as Secretary of Health in the Cook Islands. So I want you to bring your experience of a small, and it has to be said, vulnerable community living with the long-term reality that is climate change and indeed rising sea level. Just tell me, Elizabeth, how, in specific terms, you see the direct connection between climate change and public health.
Thank you very much, Stephen, and thank you, David and Christiana, for those messages you just highlighted. I think for me, coming from the Pacific region, I'm very grateful that we actually have a Pacific Islands political leaders that meet quite regularly, and also a Pacific health ministers that meet on a biennial basis to discuss health issues within the Pacific. And I have to say that last year, the 50th meeting of Pacific leaders in Tuvalu reaffirmed a climate change as the single greatest threat to the livelihood, security, and the well-being of the people of the Pacific. Now, as I said, small island developing states are among the most vulnerable to climate change. Of course, all populations will be affected by climate change, but some are more vulnerable than others. And climate change really, for me, I found disproportionately affects the poorest, the most marginalized, the more vulnerable, women, children, and the elderly, and especially those living in these small island development states, not just in my country, but all these small island development states, and who are really at the front line of the climate change impacts and who are significantly exposed to the natural disasters. We have seen depopulation of some of these remote islands where the elderly and the young children remain on these islands while the parents and the adults migrate to urban cities for jobs. So further compromising the situation on these remote islands. These countries face a range of acute long-term risks, including extreme weather events such as floods, droughts, and cyclones, and increased average temperatures and rising sea levels, as you said. And many of these countries already have a high burden of climate-sensitive diseases such as dengue fever, Zika, malaria, that are made worse by climate change. With the increasing temperature potentially leading to faster mosquito breeding and viral replications, and the rainfall leading to wide availability of mosquito breeding habitats and breeding places. And this can become quite a challenge for public health personnel to ensure that this is not, the situation is not further aggravated. So there are some, in some countries, in my country specifically, there's some very, I think, useful and valuable public health measures where the whole island is actually surveyed for mosquito breeding places and therefore eliminate those. And this happens on very regular intervals during the year. So as we know, vector-borne diseases account for more than 17% of infectious diseases, causing more than 70,000 deaths annually. We have seen the rising sea level and the increasing extreme weather, such as cyclones and hurricanes, destroy our homes, our medical facilities, and other essential services. And the people have been forced to move, either to relocate to another island or relocate temporarily from the situation that's been impacted more heavily. In Tonga, we have seen that they used to play rugby that is now in seawater, and the people are planting mangroves to slow the erosion. So when people are forced to move to, because of this, we see the increased health effects of mental disorders and also to communicable diseases. Now, our islands are already with an increasing NCD non-communicable disease burden. So existing communicable diseases burden also coupled with the slow economic growth, sustainable health financing is not assured in these countries. And this is a real concern. And I think for me, strengthening the health systems and health workforce will be critical to the delivery of essential health services in our countries, and the refocus on primary healthcare models of care will be necessary. And I think in this instance, nurses and midwives are going to be, usually, and in some places, the only health personnel in these remote areas play critical roles to, preparedness and prevention and health promotion for public health interventions. They are the most trusted profession, And in this International Year of the Nurse and the Midwife, I like to say the opportunity to then amplify the critical role of nurses and midwives, and how they play in a multidisciplinary team to address climate change impact in small island development states is going to be very, very critical. I think if I can have time.
Elizabeth, I want to thank you. Okay. Yeah, no, Elizabeth, I want to thank you so much for that testimony, because it's so important to hear in real and graphic terms what is happening to your community in terms of all of those physical changes, whether it be the increased danger of malaria and communicable diseases because of climate change, whether it be the rising sea level and the fact that people are already having to move. So many different ways in which this plays out. Fierce storms, more unpredictable weather events. These things really matter, and they're visible. But I actually want to turn now, if I may, to Paul Farmer and discuss something that Elizabeth began to touch on, which is more invisible. That is the mental health aspects of what climate change is doing and how we should understand it as a health challenge. So, Paul, explain to me how you see mental health fitting into this debate.
Well, thank you very much, and thank you for having me. Before I do turn to that, I just want to compliment David and others who've worked on this report. You know, I do think, back to Christiana's point, I think there is a complexity to our understandings of how climate change affects health, a complexity that does not undermine the validity of all those causal claims. But I do think, and this is related to mental health, that nurses, physicians, and other frontline workers often feel overwhelmed with an immediate task at hand. And David and I have worked in the midst of some very frightening epidemics, including cholera in the Americas and Ebola in West Africa. And you're in the middle of all this, and yet thanks to good analysis and cogent ways of seeing the world, you know that climate change is deeply connected to what it is you're seeing. I know that we felt that way, for example, in West Africa, that this was the result of a disrupted ecosystem, which liberated a pathogen not as familiar to the human host. We thought about this in Haiti during the cholera epidemic, and I could go on and on. And so I do want to underline the importance of this syncretic analysis and thank David for reminding us that healthcare professionals have a role to play, as Christiana said as well, and as she has said many times. And we need to step up and serve in that role or lose some of the symbolic capital, David, that you mentioned. Now, to the mental health question, I would just say a lot of us believe this slogan that there is no health without mental health. And so even though I'm an infectious disease physician and focused on responding to epidemic disease, one of the things that I see in every epidemic, obviously you're going to see fear, right? And anxiety, but sometimes hysteria, sometimes, and very often a deep mistrust. Now, in every instance, from place to place and time to time, the depth of the mistrust has been built over years and decades. These things are in the making. So what can be done in the middle of a crisis like this to increase levels of trust? And as you can see right now, and this is on David's plate as well, in the middle of a novel coronavirus pandemic that's affected all of us, when new tools do come along, whether they're diagnostics or preventives like vaccines, you have to have strong community trust to move forward these interventions into society to make them have their impact. And again, the relationship of this to mental health is always central. And if I had a wish to make, I would wish that we could stop putting mental health at the very bottom of the list of all of our health interventions with massive underinvestment and start investing in stronger communities. And community health workers have a role too, just as nurses, social workers, and psychiatrists. So I think these are bound up together. And I want to thank you again, David, for bringing us together, but also bringing these diverse strands of analysis together.
Thank you very much, Paul. The experience there of an epidemiologist and an anthropologist, and we've got so much wonderful insight on this panel. I do want to remind you all that you can ask a question to any of our panelists on any of the related topics around this broad theme of climate change and health. Just use the Wish platform. I've got my smartphone here and I'm going to see all the questions. So please don't hesitate. This is an opportunity to tap into the knowledge and experience that we do have on this panel. I now want to move away, or at least in a somewhat different direction, to talk to somebody who is responsible for investing in different projects which are related to this topic right around the world. So Ali Aldabakh, we're delighted that you could join us. You're Deputy Director General of the Qatar Fund for Development, and of course that is a not inconsiderably powerful amount of investment money that you can put into projects and initiatives right around the world. I just want to get your insight into how you can use your fund to tackle some of the issues that have already been raised today. That is, thinking about the connection, long-term and immediate connection between climate change and public health, and the degree to which that is now front and center of your thinking when it comes to investment decisions.
Thank you. Thanks, Stephen, and distinguished panelists. It is indeed our honor to be part of the panel, to be part of this year's edition of WISH. We're looking forward to seeing all of you on the next season in person here in Doha, inshallah. With the world's attention on the health system, like ever before, this is discussion on the climate change and health comes at particularly critical time. The COVID-19 has given a foretaste of the shock and that climate crisis could cause. It goes without saying, the climate change has serious consequences which can already be seen, impacting the livelihoods, health, food security, water availability, and vector-borne diseases, threatening to underline years of progress in public health. Climate change is therefore likely to mean increased humanitarian load. Additionally, its impact on one humanitarian area will often have burning on others. And to make matters worse, its humanitarian consequences are expected to become more severe for the most vulnerable groups. Hence, there are key commonalities between climate change and COVID-19 that can help inform our decisions and development agencies addressing the global challenges. Firstly, COVID-19 reminds us of the cost of global shocks on economies and societies across the globe, and hence the urgent need for accelerated action in response to the climate change. We live in a highly interconnected world that impact and implication of one challenge can escalate across many different sectors and countries. Similar to public health, climate change too is a global public good with benefits or costs that extend to all countries, people, and generations. This reasoning continues to shape our approach at Qatar Fund for Development when addressing climate change, one that builds on a strong multilateral response. We are continuously exploring innovative climate financing mechanisms and partnerships that support developing countries' transition to low emissions and climate resilient development. Secondly, the effects of the climate change will almost certainly be harsher than the ones of COVID-19, cross-cutting all SDGs, and will be the worst for the most vulnerable groups. It has been clearly outlined by the United Nations that a solution to the climate crisis that does not benefit everybody will lead to the survival of the richest. The challenges posed by climate change are especially pressing for least developed countries and small island developing states, threatening to undo decades of their progress toward the achievement of SDG 2030. And with only 10 years ahead of us to deliver the commitment to achieve sustainable development goals and promise to leave no one behind. We need to ensure the support is provided to these countries. With that in mind, His Highness Sheikh Tamim bin Hamad Al Thani, the Emir of the State of Qatar, pledged in 2019 on the side of the Climate Summit to provide $100 million for the climate change adaptation and mitigation, with a special focus on addressing the devastating impact on the climate change on all LDCs and SIDs. Furthermore, having affected almost the humanity, COVID-19 has exposed the vulnerability of our health system and the fragility of our economies, and highlighted the importance of building stronger and more resilient health system and the need of the better disaster preparation. Increasing the resilience need to be one of the main guiding principles when rebuilding our societies after such a crisis. We need to ensure we are better prepared to resist future shocks and the crisis, and particularly this imminent threat to humanity, climate change. Hence, for us as a development agency, we are focusing on the need to respond on the humanitarian crisis through emergency relief to keep people alive. We are also focusing our response to economic, natural, and environmental shocks should focus on long-term recovery plans, resilience building through investment and risk management, preparedness and mitigation to build the capacity of communities to adapt on the rapid changes to the climate conditions in the way that they can absorb and quickly bounce back from such shocks, such as storms and drought when they do hit. Similarly to our response to COVID-19, our response to the climate change-related challenges is built on recovery and investment in climate adaptation. For instance, our support capitalizes on the untapped opportunities for transitioning into a greener economy and green jobs. This is in addition to our contribution to the Global Fund achieve the goal of ending the malaria pandemic by 2030. Through building community health facilities that provide malaria prevention and treatment programs, mental health, childhood vaccines, and basic health care, resulting in overall health outcomes that are stronger and more cost-effective and efficient. We need to take stock on the lessons learned from COVID-19 to shape the way we support countries most affected by climate change. Strong collaboration and solidarity is a key to ensure that those most vulnerable to the climate change are able to cope without assistance to prepare and respond. Thank you.
Ali Al-Dabaa, thank you very much indeed. Ali made several references there to COVID and a comparison in a way between the way the world is responding to the urgency of the COVID challenge and the different kind of urgency that we see and identify in the climate change challenge. I want to stay in Qatar now, but perhaps think in slightly different terms. I'm thinking now of Qatar itself, which of course is a nation and an economy, frankly, built on the riches that come with fossil fuels. It's also a nation which is obviously located in one of the hottest, driest parts of our planet. It is also a nation which has to think long-term about the implications of the potential of rising sea levels. So all sorts of different ways in which Qatar itself has to ponder what its future will be when climate change is so pressing a problem for the entire planet. It's a way of introducing Roberto Bertolini, who is now a senior advisor to the Qatar Health Ministry, having, as I said earlier, served as the WHO chief scientist in Europe for a long time. Roberto, now that your focus is Qatar, how do you concentrate on trying to build resiliency and a long-term sustainable strategy inside Qatar, inside Qatar's health system in particular?
Thank you, Stephen. This is a very challenging question, as you can imagine. Well, let me tell you first that I'm very pleased to be here today, also because after many years in which we have been talking, and David knows very well, I mean, about climate change and health and so forth, we start seeing now systematically this issue addressed within the health sector, which is something new and very important, because in the past, I remember the participation of 2000 UNFCCC conferences years ago, the health representatives were just children of a lesser god, in a sense. I mean, this type of presence was not so much considered. But having said that, I think you mentioned some of the very most important challenges that the countries in the Gulf are actually facing. Climate change is going to be affecting temperature. We are going to expect extreme heat, further drought, and the risk of flooding for increased episodes of intense rain in a short time. Air pollution will actually be an important issue with the interaction between temperature and the existing emissions. And all of these in a framework within which some research in the past have questioned the possibility that this part of the world will actually be adapted to human beings around the end of the 21st century. So this is a very, very big challenge. And of course, I mean, everything depends, many things depends very much by the mitigation efforts which will be made at the global level. But there is a lot to do in manage the unavoidable, which is the consequence of climate change that will happen anyway in this part of the world. And I think here we have to realize that one of the issues that was mentioned in the document that David has introduced earlier, the document on climate change, is the issue number 9, is quite an important one when it's talked about addressing cross-sector collaboration. I think that all these challenges that we mentioned actually require an intersectoral collaboration. And but starting with the health sector, I think we need also here, and once again, learning from the COVID experience, strengthen the system for emergency preparedness and early warning. This is a very important part, particularly for the extreme heat. But also we need to make sure that the system, the health system, is equipped in a proper way to respond to these different type of challenges. In the document, there was also another analogy, which I liked very much. I mean, the climate change is like a chronic disease. You don't see it, but eventually, it explodes with all the consequences. And since we know that this is going to happen, we need to be very well prepared. And the COVID experience in this respect has learned us how to make an effective use of scenarios for planning health services, how to integrate response across different sectors of the health system, from the primary health care to the tertiary care. So this type of lessons we have learned will be very useful when we supporting and strengthening the system to respond to the challenge of climate change. I mentioned the other sectors. This is a very important part, I believe, in all the climate agenda, but particularly also in the health impacts agenda. Here, we have a great opportunity in Qatar because there is a massive investment program to redesign the urban landscape here. And this is an opportunity that should not be missed. And I would say that some steps which have been taken are going in the right direction. For instance, I mean, there is a lot of efforts to build bike lanes, and we need to go for a sustainable transport policy, bike lanes with shade. There are also some rebuilding of areas of the city in which, I mean, the buildings are made in such a way to allow for a better indoor air quality, for using traditional architecture together with the new materials, the orientation of the building being done in such a way that the wind favors some cooling during the day when the heat is higher. So, and also the building up of several green spaces which are being built around the city just to improve the possibility for people to enjoy. And again, mental health aspects will be also addressed in this way. There is also something to be done in terms of organization of the society in order to meet the challenges. And here, once again, the COVID is giving a lesson. I mean, we have to probably to change the timing of the work when the heat will be too intense, and be able to leave the hotter times of the day in which people will not be working outdoors, for instance, And the smart working, which has been very much applied during the COVID pandemic, might be interesting and also useful also in this respect for those professions where this can actually be implemented. So in summary, Stephen, and I think a number of actions can be undertaken to enhance resilience to the health impacts of climate change, but this implies and requires innovation, building of coalitions, innovative thinking, and more than everything else, I would say, something which I faced in my experience throughout the years, the importance of coherence of policies. We need to have coherent policies across the different sectors because, this is a very fundamental issue to allow with commitment and determination to address this challenge.
Okay, Roberto, thank you very much indeed. A very strong final thought there from Roberto about the need for cross-sector coordination and collaboration, and I guess that would also go for cross-national collaboration, not something that's always easy to achieve, as we've seen during the COVID crisis. Everybody around the world, I do want you to remember that now is your opportunity to put questions to our panel, because having led the debate myself for some time, I'm now going to officially declare that we are going to swiftly move to this phase of the debate where your questions are put to our panelists. So please do come up with your own questions and thoughts right now. And David, now that I'm sort of the conduit for thoughts and questions coming from people right around the world who are part of the WISH family, let me come back to you straight away, because we've got a big thought here, and it relates to a lot of what we've already been discussing. It's a question which says, how do we balance the need to reduce each country's emissions, carbon emissions, greenhouse gas emissions, in a way that is going to allow for future development and investment in the healthcare sector? And I'm also mindful that so much of the healthcare infrastructure in so many countries was constructed quite a long time ago and doesn't necessarily represent the sort of the most smart development in terms of reducing emissions and being sustainable. And that's something surely that has to be factored into this question of how to use buildings and infrastructure in the future in the healthcare sector. So the question really is, how do you balance out the need to improve healthcare, to build more infrastructure, and at the same time reduce emissions? What are your thoughts on that?
Thank you, Stephen. First of all, just really lovely to have this panel here and to hear the great comments from everybody. Thank you all. Also, I'd really like to acknowledge the Qatar Foundation, the WISH team, and everybody who helped put together our report, which is quite short and it's an easy read. And that brings me, Stephen, to the real point you're making. And I just want to say something which I hope will appear to be pretty straightforward, but it may sound surprising. If you want to go green and to be climate compatible in your development strategy, that does not mean that you have to have any reduction in economic growth or any delay in achieving equity. We have so much evidence now that says you can be green and you can be prosperous. And that then brings me to the key thing that every health actor must do, which is to work for sustainability in health systems for exactly the reason you just said. And secondly, to be stepping up and leading for sustainability and climate compatibility in every activity. Go green, value nature, and most of all, reduce your emissions while improving adaptation, and we can pull through this. But if we don't do it, we're going to have a really difficult time in the coming decades.
Thank you very much, David. Talking of difficult times, we already see around the world climate change impacts in terms of some communities that are finding life so difficult in changed climate circumstances that they are, in some cases, being forced to move. Elizabeth referred to that earlier in terms of some experiences on the Pacific Islands, but it's seen in parts of sub-Saharan Africa as well and other parts of the world. So let me ask this question, and perhaps, Paul, you can deal with this one first, if you wouldn't mind. The question is, what challenges will climate migration, perhaps significant numbers of refugees coming from extreme climate events, or perhaps longer term issues like rising sea levels, what will climate migration pose in terms of challenges for public health authorities? And is it possible to build capacity before some of these events happen to ensure that we are properly prepared? I think, Paul, if you can hear me, Paul, if you can hear me, I think your mute button is on. Could you possibly? There you go.
It's being very obedient. I think some of the accompanying the side effects of climate migration have been noted in with mental health and pandemic disease, for that matter, at the top. I would like to answer the question, though, Stephen, in an enthusiastic and optimistic way. And even in the setting of great tragedy, such as the storms that hit Haiti in 2008 and were followed by the earthquake in 2010, and then the massive cholera epidemic that David mentioned. In the middle of all that, after Haiti's clinical teaching infrastructure was destroyed, Partners in Health and its Haitian branch rebuilt a hospital in the middle of this. As refugees were coming out, internal refugees were coming into central Haiti outside of the earthquake zone, and it made it, rebuilt it to make it completely, or to make it solar powered. I mean, this was, again, trying to seize the moment. Can we prevent some of these things from happening, to your point? And we knew that our carbon footprint was through the roof. We were running a dozen hospitals, public hospitals in central Haiti, and so we rebuilt them. And we were doing that already. So I'm just saying this was part of an exercise that a fairly small NGO charity, Partners in Health, took on in order to participate more fully in the effort to go green. It was to do that across the world, everywhere we had a clinical facility. So I guess what I'm saying, Stephen, is I'm sure we can do more. And some of this has to do with building back the space better and safer and greener, as has been mentioned by David and Mr. Bertolini as well.
Paul, I'm mindful, Paul, of your long experience in global public health, and I believe I'm right in saying you hold the chair of global public health at Harvard Medical School. So you're very plugged into the interface between sort of what we call health leaders and political leaders. Do you think politicians around the world are sufficiently aware of the degree to which health has to be at the center of debates about how to best build societies capable of dealing with climate change?
Well, I mean, you asked me at a difficult time, since I'm an American, and our government has pulled out of the Paris Accords. So I'm a little bit embarrassed by that, and we'll say the answer to your question must then be no. They are not sufficiently aware. The same can be said, however, of the medical profession. And by medical, I mean nursing, medical, all of us together. I think Elizabeth will agree that inside our professions, we have a long way to go to educate each other, to learn more. We're just starting to include these matters in our medical textbooks. I was just allowed to help take part in drafting a chapter for a famous global and American textbook in which these matters are really only just now being addressed. So I think the politicians are not sufficiently aware, and the medical professions, broadly conceived, are not sufficiently aware. And as David said, we have a responsibility and also a symbolic capital that will allow us to help get these messages out to our patients, to our students, and to our broader community. We have a lot to do.
Yes, important thought. Thank you, Paul. Roberto, I want to bring you in on this one. The question is about, essentially, it's about inequality and how we wrestle with the reality of very deep global inequalities, because it goes like this. In low income countries in particular, rarely do they have resources that are focused on preventive actions when it comes to the implications of climate change. Resources are usually necessarily directed to the curative services. So how do we all, in a sort of international collaboration, work much harder to build in preventive capacity to the poorest countries?
Well, Stephen, I mean, this is probably one of the biggest challenges that we are facing, because, you know, I remember when some years ago, when trying to picture the impact of climate change and the, let's say, the countries or the areas where the problem was originated from, we had this strange map in which you have this big, countries like the US or China, and that is small, very small Africa, very small Southeast Asia, very tiny contribution to the actual, cause of the problem. But this is reality, this is where we are. So I think that once again, this is an issue of global solidarity, and we need to understand that either we all solve these problems or no one will solve this problem. Climate change is a global issue. So we can, yes, address something at the national level in terms of adaptation. We can decrease the impact, yes. But if we don't act at the international and global level in a consistent, systematic, and committed way to address the issue, and we achieve these goals that the conference in Paris has set, and also other agendas have also set, we are not going to be out of this challenge. So this requires a intervention and commitment from the richest countries towards the poorest countries, to export technologies, to improve their waste management. What is happening now is not exactly the opposite, but it's not too close to this. If you think about the international waste traveling, the fact that some countries are inundated by waste coming from the richer country, or other type of phenomena like this, I think this has to be understood, and it requires a very important change in the international policy. I hope that in the next years this will happen. There are some changes in the leadership in some important countries. Let's hope that this will catalyze some more active action towards this problem.
I love the diplomacy of saying there have been some changes in some important countries. Yes, that's true. At least we think it's true. But let's not go there. Let's turn to Elizabeth right now, because Elizabeth, I'm very mindful that it's easy to talk about public health policy in terms of leaders in public health and senior doctors and academic researchers, but you are an international representative of the nursing profession. And I just wonder, particularly when we're talking about practically what can be done on the ground in countries where healthcare infrastructure is challenged by resourcing, just how important the role of nurses can be in this discussion.
Well, I think, thank you for that question, Stephen. I think it's, what's a really critical role that nurses play. You'll probably find that it's the nurses and the midwives that are in these remote settings, in these remote islands, and they're probably the only ones on those, providing healthcare services. Their roles, I think, are really critical in terms of actually keeping people away from hospitals. I think that's for climate change. If we can prepare our communities, work with the communities, and utilize actually the individuals in the communities through some community public education around emergency preparedness. I think you're going to have, in these limited resource settings, you're going to have to call upon the people that are in the community, and they're not necessarily healthcare workers. So I think it's really important the role nurses and midwives play in these communities by understanding who's in the community, who are leaders in the community, whether they are in a non-government organization, in the civil society, or actually in other health sectors, whether they're in education, or whether they're in the Ministry of Infrastructure. It's really trying to harness the available resources on the ground. I think nurses and midwives are in that critical position to actually make some of these critical decisions to enable a population-wide support during the event of a crisis, or actually before the crisis, and in the event of the crisis, and also post-recovery. So I think these are really key elements that I found in small island development states, that nursing personnel are very critical. I think the COVID-19 situation is highlighted for us as well as to the role that nurses and midwives are playing, and how important it is that we take care of them. Because I think if you're not going to take care and make sure that they've got decent working conditions, that you're going to further compromise the necessary providers for the services you require.
I think that message about the absolute centrality of nurses and nursing is well taken by all of us, Elizabeth. Thank you very much for that. Christiana, I want to bring you back in. And it's a broad question again, and it keeps recurring, this question of how climate change impacts on health are going to differentiate. Some people on our planet are clearly more vulnerable than others. And the questioner says, clearly, this is going to affect women and children, the elderly, those with pre-existing conditions, people in low resource settings, indigenous communities in a disproportionate manner. In fact, you could put almost anybody on that list except healthy men in high resource settings, which I guess is true. So the questioner says, surely there needs to be a better way to prioritize the populations that are going to bear the brunt of climate change. But do you, Christiana, have any idea how one would go about that? Christiana, you're on mute. Can you hear me? Because are they?
Sorry, I thought the system would unmute me. Sorry. Yes, it's absolutely true that climate change is an accelerator of so many impacts, that forest fire, floods, droughts, natural conditions that have existed for many years, but that now are being accelerated by climate change. At the same time, climate change is a deepener of inequality. So inequality, all of that you have mentioned, plus much more, by the way. We have been irresponsibly tolerating that inequality for decades, and climate change deepens that inequality. That is the crux of the injustice that is embedded in unaddressed and unmitigated climate change. That is exactly the reason why we cannot tolerate inaction on climate change, because yes, we can use very important funds, such as from the Carter Fund, to help some vulnerable populations around the world, but there is never going to be enough support to support everyone who is vulnerable. The only way to get us out is to address climate in a timely fashion. The way to think about it is, the only way to get us out of COVID-19 is to have a vaccine for everyone on the planet, not only for, what did you call it? White men sitting in privileged areas or whatever, the way that we would have gone at this several decades ago. That just doesn't help. If you just vaccinate white men sitting in privileged areas, that doesn't help the world, because eventually they will get the virus. So we have to understand that we are sitting in a boat. And it is, if there's a hole in the boat, and there's a gaping hole in the boat right now, it is not only those that are sitting close to that hole in the boat that are going to go under. If there's a gaping hole, and there is, it's all of us that go under. That is the mentality that we have to be able to understand, This is about everyone. It's not about only the privileged or only the vulnerable. The fact is that climate change does not stop at my gate and ask me, or, you know, the forest fires do not stop at the gate to say, excuse me, what political affiliation do you have? Or what does your bank account look like? It doesn't. We are all in this together, and we have to make sure that, as the UN has been saying for years, that we leave no one behind. It's absolutely the mentality. And this is about, Stephen, this is about changing our mindset, right? This is about changing our mindset and understanding that we are all humans on one planet, and we have to be able to allow everyone to thrive, because we are as weak as the weakest link. If there's one person who's not having the well-being that they deserve as a human, that affects all of us. And that is a dark mark on all of us. So it is about understanding we are all on this boat together, and we have to be able to keep everyone afloat.
Amen.
Stirring, very stirring words, Christiana. David's giving you 2 thumbs up, and I'm now thinking to myself, there's no way that anybody during all of those complex negotiations about getting to the Paris Agreement was ever going to disagree with you, because you speak with such persuasive passion. How could anybody possibly disagree? Thank you for that. We're almost out of time, but Ali, I'm aware I haven't spoken to you for a little while, and I just want to get your thoughts on one question that's just come in. And it's an interesting one. It's a practical one. It's less about big vision. It's more about practicality. And as you invest money in health projects around the world in developing countries, I'd like your thoughts on it. The questioner says, it's interesting to note that in countries like the UK, there is now an official target to turn the National Health Service, our national health system, into a net zero, net carbon greenhouse gas emissions system by 2040. Now, is that kind of ambitious target realistic for developing countries as well as the rich world developed countries? What do you think?
Let me start with something like, as a fund, we're very quite new. We are just 6 years in operation. We have such an inspired management and board of directors. Despite that, when we started in the operation, we were in the late of MDG, the millennium. Then we updated our strategy to reflect the SDGs. As we can see, we are focusing on 3 sectors, mainly education. 50% of our fund goes to education, health, 35%, and 15% to the economic empowerment. So we are as we are moving now, a new multi-sectoral approach that we are using is the environment, the climate change. So we have taken serious measurement by the leadership and the board of directors to have the climate change and health in any program that we're considering. So we are not very sophisticated like UK, but we are working hard with the team to achieve the SDGs by 2030. And we are putting on top of our agenda health and the climate change on that regard. So setting such objective goals would be very hard to announce it now, but we are working towards that.
Ali, thank you very much indeed. We're almost out of time. I want to give the last word from the panel to David, and then I'll try to sum things up. But David, you introduced your report, your forum report at the beginning of this session. You've heard some fascinating words from our wonderful panel. I just would put it to you that in the context of a world wrestling with the COVID-19 pandemic, which you, of course, personally are grappling with at a very high level yourself, do you think there, in a way, is a danger that, as so often in healthcare, it's a question of priorities? It's almost like a triage metaphor. You have to deal with what's in front of you and make some very difficult decisions. And is the danger that always public health and climate change, because it's so long-term, it's so strategic, and it isn't necessarily for a lot of people about what is happening in our healthcare systems today, although we've heard many times today that actually it can be that, but often it isn't. Is that perhaps a reason why still today climate change isn't front and center of debates about public health in the way that it should be?
Thank you, Stephen. Thanks for your masterful moderation of this panel. Just like to really emphasize some of the points that colleagues have said in a very few words. Climate change is happening now. It's affecting people's lives all over the world. Hundreds of millions of people are being affected by it. It is unjust. It's poorer people who are most affected. And perhaps more than ever, it's time for health professionals to just do the thing, get involved. Every health organization should come together at top leadership level saying, what are we going to do about this? Every health professional should be thinking of ways in which they can talk, act, and lead on climate change. They should be doing something different each month. They should be sharing what they're doing with the website and the email address that's been set up by this forum. In 2 years' time, we want to come back and look at it again. We've done this report because we believe there is an extraordinary role that health professionals can play. We've seen what they're doing on COVID. We'd like to see them doing it on climate. And Stephen, I don't think people feel that climate has to take second position to infectious disease. I think people are realizing through COVID that the power of working together, particularly at the local level, is a power that we must build on and we must nurture and we must take it with us, because without that, we'll get not a good result. And with it, we can make a big difference.
Amen.
David, that's a great way, I think, to end your presentation. And I think everybody would like to thank you so much for chairing the forum and for presenting the report. And I know a lot of people will want to read it in greater detail after this WISH conference is over. So thank you so much for that. As a journalist, all I would like to say as a sort of my wrap on our discussion today is that what I love is the notion that healthcare leaders need to step up and can themselves be the change and can also, perhaps more than ever before, utilize their voice to influence the wider public debate. Maybe sometimes healthcare leaders are a little loath to do that. Perhaps they worry about being too political or entering sensitive political territory. I think David's message is it's far too late to worry about the niceties of that. It is time for healthcare leaders at all levels, as Elizabeth pointed out, at all levels to use your voices and be very clear about the degree to which this, just like COVID-19, is now and it's urgent and it needs to be at the top of the public debate. So that's my sort of takeaway from a fascinating debate. I'm looking at my screen. I want to thank all 6 of you so very much for being part of this. It's been my pleasure to moderate it, but it's been your thoughts that have made it so worthwhile. So thank you all very much. And I think I can now say that our climate change and health panel is now done. Thank you all very much indeed.
Thank you. Thank you. Thank you, David. Bye-bye.
Stephen, thank you.
Thanks, if you could all still hear me.
Hello, I'm Louisa Baldini, and I am delighted to be moderating this discussion on the pathway to localization, the importance of building health capacity in developing countries. And this is a discussion in partnership with the Qatar charity. As local as possible, as international as necessary. That was the vision the UN Secretary General declared for humanitarian action in 2016 at the World Humanitarian Summit. 4 years on, the localization agenda is more relevant than ever. There is an urgent need to recognise and support local communities in being the decision makers and the leaders of solutions which impact their healthcare systems. We'll be hearing from 4 experts in the field. You can see they are ready and waiting. We will be discussing the common challenges localised health capacity faces in developing countries, current good practices, any innovative approaches, and opportunities to link national healthcare strategies with broader global localisation frameworks. So let me introduce our panel of experts today. They are Dr. Robert Walters, who is chairman of Orbis, a global charity bringing people together to fight avoidable blindness. Hello, Dr. Walters. We have Ishrat Ullah, head of relief at the Qatar charity. We have Mohammed Ahmad, chair of the Humanitarian Network Pakistan, a network of NGOs in Pakistan. He's joining us from Peshawar. And we have Bashaya Al-Ali, International Programs Director at the Qatar Fund for Development, an NGO committed on behalf of the state of Qatar to improving the livelihood of communities around the world. Thank you all so much for joining us. So I wanted to kick off with a question for all of you, and that is, we know improving healthcare systems takes time and there are many areas that need to be considered, but what would you say is the biggest challenge to improving localized health systems in the regions you work? And if we could start, please, with Mr. Ahmad.
Thank you. First of all, thanks for inviting us to speak on this panel. The shortest answer is prioritization and then resource allocation. Most of the third world countries, the region we are in, are under debt servicing. So if you analyze the annual budget of these countries, so the social services portfolio is quite low as compared to the debt servicing. This is one issue. The second issue is for the available budget prioritization. Most of the budget to the health system is going for the metropolitan cities and big hospitals and tertiary care, while we are neglecting secondary and primary health. And that's why in any emergency situation, our primary health care are our basic health units. They are less equipped, not only with the doctor, but with the equipment and medicine. And there is a huge rush on the metropolitan cities, and they sometimes disrupt the whole health system, and we have seen it in the COVID situation. So my answer will be resources and then prioritization of social services and primary, especially primary and secondary health at rural and urban setting. Thank you.
Thank you very much. And what about for you, Bashaya Al-Ali, what is the biggest challenge?
For us, I believe translating local needs and drawing references to international frameworks has definitely been a challenge, especially in face of sometimes lack of local capacity. So what our approach has been in the past, considering that we are a young development actor in the field, we are very fortunate to be able to adapt and be very agile. So our focus has been varying from, so our focus has been kind of shifting towards building resilience and identifying gaps in structures and existing systems, and then using that to communicate with the local authorities or the local communities to translate the needs of the local population and address those most urgent services.
So really trying to focus on those local populations. Okay, thank you so much. And Mr. Ullah, what about for you in the areas you're dealing with?
Thank you, Louisa, for giving me this opportunity. For us, in my opinion, is Brother Ahmad and Bashir. They rightly pointed out, the biggest challenge because for organizations like us, we usually work in underdeveloped or developing countries, usually responding to emergencies and humanitarian situations. The biggest challenge is weak or poor health infrastructure, especially in the rural areas. When there is any disaster, so the already existing infrastructure is very poor and very poor quality. So this is a biggest challenge for the other challenge. I would like to say that the health guidelines and policies in those countries are usually it's not actively it's not very active. So for organizations like us, we should most focus on local communities to build their capacities, because in any emergency response, they are the first responders in any disasters. So we should more focus on building the local communities capacities, and also the capacity of the local health system, especially at rural in rural areas, so that in the future, if there is any disasters strike or happens, they respond properly.
Thank you. Thank you. And Dr. Walters, you at Orbis are not so much dealing with those emergency situations, but you are really trying to improve healthcare in those local areas, but you're dealing internationally, aren't you?
Very much so, Louisa. Thank you very much for inviting me to join this panel. This is a common problem, and it's been touched on by most people today, and that is that Orbis, for example, is an international eye charity dedicated to the treatment and prevention of blindness in the developing world. But the problems are common amongst most of us who work in these situations. And the first thing is that, as has been mentioned, the healthcare systems in place in many developing countries are very poorly funded. And that is counterbalanced adversely by the fact that the amount of disease in those countries is normally disproportionately high. So you're having a double hit here. And I think from our point of view, we find that the most important thing to do is to work very carefully with the governments, and of course to advocate for your cause and also to advocate for good health systems. But you need to work carefully with the governments at a high level and also with your partners. The power of partnership is very important. Also, the other thing that's been mentioned is the concept of the urban-rural disparity, and that's very common in the countries where we work. So I think those are the main points. Thank you.
So when it comes to Orbis, you literally, well, not you yourself, although I think you have done, you've been working with them now since 1994, I believe, but there is an aircraft that literally flies in to help give treatment that will save people's eyesight. But it's not a case of flying in and flying out. You're doing much more than that down on the ground, aren't you, to try and improve the localized health services? Can you tell us a bit about that, please?
Yes, very much so. I've got a picture of the aircraft here. I'm going to show it to you, so that's a bit of fun for you. Can you see it there? Yes, there we are. So no, the aircraft is, a great icon for Orbis and is a very important part of the work we do. But it's very important for teaching systems. It's internationally recognized eye hospital. but it only really touches the surface. It begins to that introduction into countries that we require, and but we are a capacity building organization, and so we also have in-country programs which are not involved with the plane necessarily, but can be adjunctive to the plane. But it is important if you're developing capacity, especially in training, because we are trying to train the local healthcare systems to be able to look after their own. It's wonderful if we can actually leave those countries and they can do it themselves. But it is about building capacity over a long, long period of time. And Orbis is not in many, many countries. We're in about between 15, 20, 25 countries, depending of which time of the cycle we're in. But we want to be in a small number of countries for a long period of time. You need to invest in those countries over a long period of time.
And have you seen a shift in localization since Orbis has started working in those countries? How has the work evolved?
Undoubtedly. It's a really good question. Yes, many of the countries when we started working with Orbis in 1982, during those almost 40 years, we have seen some countries grow really positively in terms of their capacity, particularly some of the Asian countries. So, you know, India, Bangladesh, Pakistan to an extent, and China, Vietnam. They've all grown enormously partly as their economy has expanded. They become emerging nations, but also we've seen that the work we have put in to train people, to support those people in their training, and also to support them so they won't leave those countries and go to richer countries, so they will support their own communities. That has really paid dividends.
Talking about training, teaching, and Mr. Ahmad in Pakistan with your network of, I think, over 170 NGOs, how can you ensure that everybody can get the training they need to cover such a wide geographical area as well, and some areas that must be very difficult to reach?
Thank you. I think there is like a misperception or a lack of understanding about the health services and health system. Health system is much more than the health services. It includes nutrition, it includes hygiene condition, and it includes the community behaviors as well. What our organizations are doing right now, we basically prioritize, we have a national plan how to strengthen our health system and how to include community and how to include private sector and be partnered with private sector in some areas. So we prioritize that we need to go for the vulnerable geographical areas, and whatever we are getting from the outside funding, we are prioritizing those areas whereby the government is like less investing, or the private sector is not investing because of the poverty ratio over there. Because the private sector, they have their own priorities. So our organization, we are supporting the government, the public health system, while we are educating community on health hygiene and nutrition, and we are working with them how to develop a partnership between the community and government, and how to take care of the health facility jointly as a team. So what our organization, we are not only equipping the duty bearer, strengthening them with the support of WHO, ensuring the global standard, but we are doing awareness raising and engaging community in all these practices so that they own the health system and they can run it themselves. Thank you.
And that community involvement, I know, is incredibly important for what you're doing, and we will come back to that. But you mentioned funding and investment, so I just wanted to ask Bashaya Al Ali from the Qatar Fund for Development. The fund has the ability to provide the resources for programs in many different countries, tackling many different health concerns. How do you see your role in the transformation of healthcare systems? Because even with what we've experienced this year, healthcare systems need to keep evolving, don't they, if they're going to be able to really help the communities that need that help?
Yes. So in the Qatar Fund, we see our role as a catalyst or as a catalyzer to bring about sustainable development that does not just meet the needs of the most vulnerable, but would continue to support, uplift, and also continue to help people prosper. And we see this achieved only through a full spectrum or a nexus approach is adopted in all of our initiatives. What this means is that as the Qatar Fund and other donors and implementers are also encouraged to do the same, we must implement, adopt, or put in place mechanisms that ensure our collective investments in these systems are, first of all, they are contextual. That means local solutions for local needs, where we account for country and regional level priorities. This is important to ensure that any gaps in the system are met and that any needs by the community are also met, and that there is no oversaturation of resources in any specific field. The second thing is that we need to ensure that our investments in these systems are sustainable. By that, we mean they have to be sustainable on the programmatic, on the financial, and on the environmental level. Programmatic through training, through investing in local capacity building, knowledge transfer and dissemination are both key priorities for the fund and the core value in this organization. Financial sustainability, we need to look for more innovative funding mechanisms that go beyond simple grants and loans and look at
Oh dear, we seem to have lost Bashaya just for a moment. As you can appreciate, this is quite a feat of technology, bringing everyone together. Oh, I think we have her back now. Sorry, we lost you momentarily, those pesky technicals. But you were talking about the need for more innovative ideas of raising funding, for example, and providing funding.
Yeah, so just to continue on our sustainability, when we talk about financial sustainability, innovative financing is something that we continue to look at. And the third one is environmental sustainability. So climate change is a real and it is a present threat and a danger. So if there are no policies and the most affected or the most vulnerable are always the most affected, the worst affected. So what we need to do is we ensure environmental sustainability as well. The third attribute that we look for in our investment in these systems is relevance, and relevance to international frameworks and global agendas. So yes, we account for the localization because localization is extremely important. We need to ensure that our interventions contribute, meet the local needs, but are also examined in relation to current priorities. That is important because it means that all of our resources can be mobilized together and they could be pulled together and we can work towards our fourth attribute when we try and invest in the system, which is collaboration. Collaboration is a core value in our fund, So in our local and international partner organizations, we work within a certain set of priorities, and those are guided by local and global strategies. So we seek partners like Qatar Charity, for example, is one of our implementing partners. We work with Orbis through the Qatar Creating Vision Initiative, the Global Fund, and Gavi. Those are some of the organizations that we partner with. And we try and identify synergies and mutual interests to help us achieve a common goal. So by working together, we try and implement and integrate and align our solutions with the government authorities and local communities at all levels. So just kind of to sum it up, what we do is what we do to transform systems is we invest in ensuring that our investments are contextual, sustainable, relevant, and collaborative to make sure that they are resilient. Thank you.
Thank you, Bashaya. A lot of really useful information there. And you mentioned towards the end of your answer there, collaboration. And to that point, Ishratullah, for the Qatar charity, I wanted to ask, as both a funder and an implementer, how do you see your role in terms of collaboration and localization and how you design the programs?
It's a good question, Louisa. In terms of collaboration and localization, we, Qatar Charity, when we go to any country or when we start our operations in any country, the first thing we think about the exit strategy, because we need to, as I mentioned before, that our role is only to fill in the gaps, but definitely will not stay there forever. So what we do, we try to build the capacities of the local community organizations. We work with the government as part of their national plan. So we don't develop a parallel system, but we work within the systems. We collaborate with the government. We collaborate with other stakeholders like international NGOs, with the local communities. So by this, our investment is safe. For example, all our interventions are sustainable, and it's the impact is visible because we are working through a system by supporting the local government, by supporting the local community organization, and working in close coordination with all the international organizations, with local organizations, with international NGOs as well.
Thank you for that. And I wanted to go back, Mohammed, to you to ask about Pakistan. You must have an effective oversight of all the different communities, or some of them, probably not all of them, that the humanitarian network is trying to help. Do those communities manage to play a large role in the development of programs and their success? Or are they very reliant on what is on offer?
Thank you. We as NHN, we are advocate of accountable humanitarian action, top down. So we are making ourselves accountable to the community, and we are trying to hold our government accountable for our community. And for that reason, it is including community engagement is included in our program design, in need assessment, and then program designing, and they are part and parcel of the implementation as well, because at the end of the day, we need them to have ownership of our program for a sustainable manner. So yes, they are playing a very, very important role, because they know what they need and they know how to fulfill those needs and how to carry that forward. So as said, we are playing the role of catalyst. We are just strengthening them, we are empowering them and giving them enabling environment and connections with the government. So this is our job. We are their voice, and we are involving them, and they are actively participating to a larger extent.
Thank you. And I also wanted to ask about the integration with local authorities and how important that is when choosing which programs to support when it comes to the Qatar Fund for Development. Bashaya Al-Ali, do you have any information on that? Any thoughts on that, please?
Certainly. The integration is extremely important to us. So we support a progressive universalism where the hardest to reach and most vulnerable populations are given the utmost priority. We follow a strictly strict principle of do no harm, in which activities that have the potential to contribute to strengthening health systems, but do not undermine them. So the better integration we have with local authorities and systems and existing structures, then the larger and more sustainable the impact is. So sustainability and resilience to us can only be achieved by investing in local capacities, whether on the government or the non-government level. We are driven by a philosophy of cooperation, and as such, health activities are integrated with the national systems to avoid fragmentation and duplication.
Thank you so much. Now, of course, all your hard work and efforts have been challenged this year by COVID. What sort of impact has that had on the work that you are doing? And I wanted to ask you actually, Dr. Walters, how Orbis has adapted and how much you've needed to innovate as a result, and has that even been possible in such a difficult year?
Yes, thank you. I mean, it has been a difficult year for everybody. Just let me touch on a previous point, which I agree very much with my co-presenters about the concept and the importance of partnership and collaboration. It really is important. You can't do everything on your own, and you need to work very carefully with all those key partners, the other NGOs, the funders, the governments, in order to achieve things, and particularly to make sure there's no duplication. So that is a very important point. Yes, COVID has impacted everybody, and it's very much on everybody's mind at the moment. Orbis has been able to adapt. We're very fortunate in that in 2003, we launched and developed an online teaching system, which is called CyberSite, and that has been invaluable during this difficult year. So those countries where we haven't been able to work, we've been able to continue our work of capacity building by doing this remotely through CyberSite. And that was a platform that was already in existence and has grown enormously during the last year. So that's been very helpful. And secondly, we've put in systems in place to support countries that don't have personal protective equipment, for example, that aren't able to carry on our programs because of lack of systems such as that. And so we have put a lot of money behind those systems in order to allow for those local healthcare interventions to still take place. An example of that is in Ethiopia, where we've done a lot of work for almost 30 years now. And we work particularly in trachoma. And every year there is what we call a mass drug administration of azithromycin amongst the population. And this year we'll be treating about 10 million people. And in order, that's been on hold, but it's going to start again at the end of this month with the support and additional finance from Orbis.
Good to hear. But has the plane actually been grounded? Is it going to be able to depart again soon then?
The plane itself is grounded, but it's not. It's working on the ground, so to speak. So we're having teaching sessions from within the plane, because the plane is able to coordinate globally. And so, for example, we have webinars, we have examples of surgery that we've been carried out previously on the plane, and we can still continue teaching from that library. So we are putting together plane-based programs, albeit the plane is not actually in the country concerned. But that's the power of current forms of communication, isn't it?
Yeah, exactly. Well, hopefully it will be flying again very soon. And Ishrat Ullah, how has the pandemic changed the way you operate at the Qatar charity? Mr. Ullah, if you could just put your microphone on, please. Thank you.
Yes, sorry. I was saying that definitely the pandemic has affected all, aspects of NGOs work, from running programs, planning, financing, and everything. Being from Qatar Charity point of view, during the pandemic, monitoring and evaluations of the programs were somehow difficult. But what we have tried to during this challenging time During the pandemic, we have supported like almost 60 countries across the globe by investing $24 million by providing them hygiene kits, personal protection material like masks, sanitizer, and these things. So we have been trying to, to avoid stopping the work or to cater the needs of the affected people. We have been trying to, and so far we have assisted 60 countries across the globe during this pandemic time.
Very interesting. Thank you. Over 60 countries. Wow. And for you, Bashar Alali, the same question then at the Qatar Fund for Development. How has COVID-19 impacted the way you view applications for funding and support? You suggested earlier that it was very much trying to reach the most needy and prioritize them. And how are the programs you currently fund, how have they had to adapt?
Yes, so with COVID, the world and especially development international actors were forced to pivot and reprioritize. So the development landscape itself has become virtually unrecognizable. And this full socioeconomic impact is yet fully to be absorbed and assessed. That being said, in the fund, we understand and we recognize that addressing systemic and addressing system vulnerabilities is what has made the biggest difference. So in projects like ESPN, the Expanded Special Project for Elimination of Neglected Tropical Diseases, and Qatar Creating Vision with Orbis, those are projects that we've witnessed where training and awareness raising, building capacity within the community and community awareness, creating wash facilities have helped as well in COVID mitigation efforts. So our priority following that has become is now focused on first relief as a first step, emergency response to save lives, and then that was followed by a restructuring or a structuring phase where the focus is on identifying and addressing gaps in existing policy frameworks and existing systems and structures on all levels, micro, meso, and macro, and then improve services to address these gaps. And then the final step or the phase is through resilient recovery. So we look at ways where we could build back better, and we build back better and stronger systems. So this has been the fund's approach and its adaptation through these trying times.
So having to pivot very quickly indeed. I wanted to ask you all, in your experience, how much of an issue is the shortage of healthcare workers? Is there a huge shortage? And with COVID-19, that must have impacted that element as well. Mr. Ahmad.
There was a shortage because initially we received a very big caseload in our hospital, and basically the basic problem was that there was few experts on this. This was new for everybody, and even the health provider, they didn't know how to respond to this situation initially. So there was a huge load on the. There was a lack of equipment, suppose ventilator and the rest of the stuff required for such type of response. And it was a big problem how to transport that from abroad. So that was another issue. So it took time. There was a misperception and misinformation and disinformation dilemma in the start as well. That few of the health workers, they stopped coming to the hospitals as well. Only the emergency wards were open and the OPD was open, but the rest of the health responder, they stopped attending clinics, if I can say it, for private sector. So there was a fear, there was a lack of understanding of the infection. So yes, initially we faced this situation, not only of the health care provider, but of the equipment required for such type of response, as such ventilator. I can say. Thank you.
And how much of an issue is the shortage of healthcare workers generally, even pre-COVID? Because one would assume that will really impact the effectiveness of really securing localized healthcare services. And that's why it's so important that people are trained, as you do at Orbis, for example, Dr. Walters.
Absolutely. No, there is a universal shortage of healthcare workers and healthcare skills in all of the developing countries we work, for the reasons I've explained earlier on, because these countries are underfunded. There are educational issues often for the obvious reasons, and they also have an enormous burden of disease, so that they are hit on both sides of it. So COVID-19 has made that worse. I mean, clearly, many healthcare workers have had to be diverted into the emergency treatment of COVID patients. Indeed, I was volunteering myself in this country to work in it. So it does take you away from your principal objectives. But nevertheless, I think that it has also brought people together. COVID has brought people together and has enabled us to see that through all these difficulties, there is a way through, and it will work out. And actually, we will end up strengthened in the end. But yes, it is a problem universally.
Thank you, Dr. Walters. And Orbis has some great partnerships I've seen. How important also is charitable giving to the long-term sustainability of all of your projects? And if we pick up with you then, Dr. Walters, briefly, how important is that charitable giving?
It's fundamental to what we do, and our partners like Qatar Fund for Development and Qatar Charity, without the contributions they make, which are huge, then we simply wouldn't be able to do the work we do. And interestingly, during COVID-19, we as an organisation have found that there has been an increase in support for the work we do, but undoubtedly, without those funds, you simply can't do the work you want to do. Equally, we try to work on the basis of matching funds if we can. So we try to engage with governments, for example, to say that if we can raise a certain amount of money amongst our individual donors, for example, will they match it? And that can be a very powerful way of raising funds.
Thank you. And what about in Pakistan then for you, Mr. Ahmad? How important is that charitable giving to the long-term sustainability of the projects that you are trying to see through there?
Very important. In this very situation right now, it was like a firefighting. So for that purpose, we raised like the global humanitarian appeal in some funding from like Qatar Charity and Qatar Development Fund, bilateral funding as well to Pakistan. Now what we are doing, that simultaneously now we are developing a nexus between humanitarian response to our development, to the development level, so that we can invest this funding for the emergency response in a way that our institution gets strengthened and developed and for a sustainable development in Pakistan. Over.
Thank you. Okay, thank you so much. We now have a few minutes just to take an audience question or two. So thank you for now for your answers. And now we will go to the audience questions. So the first question I have is from Isabel Miner, and she says, in low and middle income countries, sometimes the problem is not about lack of requisite resources, but about the inefficient use of the available resources and or setting the wrong priorities. How are your respective organizations helping such local communities to set the right priorities and be more efficient for more sustainability? Otherwise, she says, the fish is not always sustainable, but rather the fishing rod. Who would like to answer that briefly first, please? Because we only have a few minutes left. Yes, please.
I can talk about it a little if you wish. In that developing healthcare systems in developing countries is vital, because that is the basic structure you require to work efficiently. And so I think all NGOs try to work very carefully within the system that's available at the time. So you need to work with the government to work within their healthcare systems and to try to strengthen those and change those. And not only do you need to educate the healthcare workers, but you also need to educate and work very closely with the administrators, not forgetting that we can learn just as much from them as they can learn from us. So it's a great deal of mutuality involved in this.
Thank you, Dr. Walters. And Mr. Ahmad, you wanted to say something on that?
Yeah, I'm in total agreement with the lady. Governance is a big issue in the third world countries or in the developing countries, and the solution is how to make the government and the rest of the stakeholder accountable to the community so that they can set the priorities right. This is the answer.
I would like to add one thing, like the community awareness and community advocacy is most important, because the community can pressurize the local government or the government in the country to strengthen the health system and the health services, to provide the efficient health services to the local communities. So their awareness is more important as well.
Thank you very much. Bashaya, any word on that quickly before we close?
Yeah, just quickly to add to that, I think it is important to work with local governments in relation to international global agendas and health priorities. So if we look at the WHO listed 13 goals, for example, if we look at the declaration program, the Istanbul Declaration for least developed countries, those are some of the international reference frameworks that we could use to kind of create synergies between what is needed locally and what needs to be addressed globally.
Thank you so much to all of you. We are going to have to bring it to a close, but really interesting to hear from you the importance of collaboration at all levels, the importance of innovation, especially when it comes to funding, if we're really going to be able to create local solutions for local needs. So just to thank all of my panel, Dr. Robert Walters, Ishrat Ullah, Mohammed Ahmad and Bashaya Al-Ali. And thank you very much from me, Louisa Baldini, and I will be here each day this week with an in-focus session at the same time. Hope to see you tomorrow.
Thank you.
revolutionized cancer treatment and is considered to be the most promising tool to efficiently treat rare diseases. While research is still looking into its full potential, precision medicine is the star of our panel today. Welcome everyone, wherever you are. My name is Rawa Oje, and I will be your host for this panel, part of WISH 2020. My job is to talk to people, especially women, and listen to their stories. And one particular story comes to my mind today. The story of a young woman who was trying at the age of 30 to have a baby. When she gave up on the natural process and went for medical intervention, she spent 2 years of her life getting pregnant naturally and artificially, but all ending up in miscarriages at different stages of pregnancy. Then, after 6 miscarriages, her doctor decided to conduct genome sequencing and found a DNA mutation that causes miscarriages if you are taking folic acid, the very commonly used supplement by women. She got pregnant and gave birth to a healthy child just by stopping folic acid. This is a happy ending, but to a very sad story, because it makes us wonder about all these patients who do not have access to genome sequencing, whereas their treatment might be very simple. And in this case, the life of the patient was not threatened, but what about lives that could be saved? Precision medicine is no longer futuristic. It is here. So what is obstructing its full use? I will let the experts answer these questions and tell us more about the latest advances in precision medicine. I have with me a great panel. I will introduce members in alphabetic order. We have with us Dr. Lutfi Shukan, Professor of Genetic Medicine, Microbiology, and Immunology at Weill Cornell Medicine in Qatar. We have with us also from the USA, Dr. Victor Zhou, the President of the National Academy of Medicine in the USA. We have also David Humphreys, the Global Head of Health Policy at the Economist Intelligence Unit. And we have with us in the studio, Dr. Saeed Ismail, the Director of Qatar Genome Program. We also have with us Dr. Walid Qurunfle, the Director of Healthcare Research and Policy at WISH. Feel free throughout the panel to send us your questions and to whom you would like to address it. We will try to make this conversation as interactive as possible. Each member will answer my first round of questions in 3 minutes. Then we will move to your Q&As. So make sure you send us your question as soon as they come to your mind so we can have them ready in time. And we will wrap up in the end with the concrete recommendations and actions to be taken to move forward. So let's start with the WISH report this year about precision medicine. My question goes first to you, Dr. Walid Qurunfle, the Director of Healthcare Research and Policy at WISH. Can you give us a brief overview of the report and outline its key messages?
Yes, thank you, Rawa. I'll be glad to do so. So let me do just 2 things. First, I'm going to take 30 seconds to bring context to this report, and then I will detail the report. So WISH has produced a forum report back in 2016 that was led by Dr. Victor Zhou that put a framework for how precision medicine should be sustainable. And from there, we know in the next 4 or 5 years, there has been a tremendous progress in the healthcare system, as well as in precision medicine technologies and tools. This promised that there will be a transformation in the healthcare. And this has been and there are many bright spots. You mentioned a couple of them, cancer and rare diseases. And this has been enabled largely by big data, as well as other analytical tools like AI and machine learning. The big data sort of has been seen a growth and an expansion in terms of volume, with issues around storage and security, in terms of variety, the types of data, in terms of velocity, which is the need to be in a real time so that we can assess the situation of the patient or the situation. And certainly precision medicines have contributed tremendously to the COVID situation. In that regard, when we looked at the policy brief that we have drafted, we wanted to make sure that this is a precision medicine that addresses strategies as well as processes. And one aspect of that is really to harmonize the activities among the different players. And one aspect of that, of course, is the integration into primary health care. So what we sought is to provide really pragmatic and practical key recommendations that are not only applicable to Qatar, but also applicable internationally. So the overview really illustrates the role of precision medicine in healthcare and what are the challenges. It talks a little bit about some of the Qatar initiatives, like the Qatar Biobank, the Qatar Genome Project, and the vision to create the Qatar Precision Medicine Institute. And then it talks about where this field is headed in terms of the future. It talks about the requirements to establish precision medicine. An example of that would be the infrastructure. It talks about the barriers. What are the barriers really to implementation? We've been focused largely on implementation. And it talks about really the principles of integration, because without integration into the primary healthcare system, then precision medicine is largely theoretical. It also highlights some of the programs that the primary healthcare system here in Qatar has initiated, which is a population-based cancer screening that have screened for breast cancer 50% of the population. This is tremendous. And this dovetails with the other policy brief that will be presented tomorrow on cancer. And it talks specifically about building capacity, because it's important within the healthcare system that there's a capacity, and within Qatar, of course. So some of the key recommendations that are applicable, as I said, within Qatar and outside Qatar, is how to communicate value, especially if you have a system that relies on insurance and payers. That would be key. What type of sort of information management system? You can have the structure, but the information management system is extremely important because you are dealing with a tremendous amount of data. And then it talks about, as I mentioned, one of the key points, which is the integration to primary health care system. Equally important, we haven't forgot about patient centricity, because we talk about patient engagement and empowerment. Without patient engagement and empowerment as an equal in the conversation of precision medicine, then I think we will face a bit of a challenge in terms of the implementation and the realization of the dream or the vision of precision medicine. Last but not least, it's important to communicate to the community and make them aware of precision medicine and its potential. And I think our ability to communicate in a layman terms to the public is very important. And I always say that culture and tradition play an important role. What you see in the Middle East, you might not see in Western Europe or North America. And as a result, you need to adapt your message and adapt your type or method of engagement. And equally important, I think there is a tremendous stress in the healthcare system. And so specialized type educational program for professionals would be key. So briefly, this was the intent of this policy brief, and these were the key recommendations. And I get back to you, Rawa, so that you can carry on with the rest of the panelists. Thank you.
Thank you, Dr. Walid. We will definitely get back to you with many questions regarding your short briefing. Now to David Humphreys, Global Head of Health Policy at the Economist Intelligence Unit. Today, the Economist Innovation Unit has also launched a report on precision medicine, to which many of your fellow panel members contributed. Might you be able to share some of the key insights from this report, please?
Well, thank you for the introduction and certainly the opportunity to participate in this wonderful forum, and certainly to the Qatar Foundation for their support in allowing us to to do one of the most comprehensive reviews of precision medicine. And our focus with the study was really looking at that long talked about promise of better, more targeted care for patients and ongoing basis barriers that face. As we get into the work and I talk about some of the key highlights around those challenges and opportunities for application, it's important that we have a clear sense around definition. Precision medicine is like many top-level phrases in healthcare that can be blurred with other terms that have narrow or broad definitions that may lead to confusion and misinterpretation. But at its heart, it offers the opportunity to move from a trial and error approach to more tailored interventions. And with that in mind and that principle, our work really looked at underpinning 4 interwoven data-related enablers, increasing use of volume of data, growth in types of data that are relevant to health systems, a greater capacity to store data, and certainly the gains in analytical technology that facilitate better and more actionable insights. Now, as part of that process, there certainly are ongoing barriers that disable or certainly hold back the development of precision medicine. Some of those are quite typical. The usability of the data, weaknesses in underlying infrastructure from laboratories to each EHR platforms, the stakeholder expertise and their buy-in, and being able to change the way we operate within health systems. Our study really focused on 2 critical aspects that we consider to be important to overcome. The first is really around the precision medicine integration into this patient centricity movement. Certainly the broader patient-centered trends of activated patients and shared decision-making are good steps. But when inserting precision medicine into this discussion, it's clear that further education is required, starting with the fact that patient-centric care and precision medicine aren't necessarily the same. They can reinforce each other. Patient centricity provides holistic insights that are valuable. Precision medicine offers a mechanism to make those actionable. The questions do remain if the current system facilitates that interaction. Questions also exist about ethical behavior and trust models that balance privacy, needs of individuals, and greater population health and societal good are certainly a work in progress. The second piece that our study focuses on is the concept of return on investment and value demonstration. Much has been said about precision medicine generating savings, and there's certainly great examples of what that looks like. But there are also evidence, one particular study that we looked at, a global review of precision intervention, demonstrated that nearly 30% of those initiatives were either inconclusive or found the intervention not to be cost effective. It's also a clear lack of definition about what does ROI mean, different measures, time frame, impact, a holistic view. And so having more clarity around that ROI and impact in health system is really very critical. The flip side from those challenges is there are numerous examples on even comparing studies that we have done in the past in cancer care and rare diseases demonstrate that there are more examples of real impact from Japan's initiative on rare disease and undiagnosed diseases, connecting patients with genetic conditions to clinical centers and multidisciplinary diagnostic committees, better treatment alignment, like the case of NHS in England, using whole genome sequencing to test bacteria in new cases of tuberculosis, to preventative measures, even to patient integration to drug development. All these are positive examples and roadmaps of how we can apply precision medicine within the health systems that we have today. One particular aspect that we centered on was the role and integration of precision medicine into public health, and looking at as the application of the tools and technology approaches that precision medicine offer to long-standing tasks and goals that public health has. And you see a variety of applications and research that explore elements as genomics could be applied to public health tasks like screening and infectious disease surveillance in the case of HIV or Zika. But it's still unclear around those definitions and some confusion around how precision medicine really incorporates into public health as expressed by our experts. But again, maybe this is a bit of a terminology as part of the issue. As one of our experts stated, today's work is just public health with better data. I'll conclude with kind of the conclusions that we reached within the study, and many of the same things that have been talked about for some time, resolving key practical challenges, access to usable data, getting stakeholder alignment, seeing where you integrate into public health, or as Dr. Rohrlich mentioned, into primary care, focusing on what problems to solve with precision medicine, where to invest. The likely will evolve over time as underlying infrastructure and expertise, culture, and value models evolve. The last piece that I will leave you is the definition of value itself. And I think that the broader context of the pandemic is more relevant than ever, that health has an impact not just on health outcomes and population health, but on societal value. And those new models being developed that incorporate the impact initiatives on health, but other aspects that drive success, productivity, and social needs and quality of life. And taking that holistic view and having new definitions and a time frame for precision medicine, I think is really very critical for its uptake. With that, I look forward to hearing any questions about the study. You can find it on our site, eiu.com, and I will pass it back over to you, Ron. Thank you so much.
We'll see what the audience sent, but I definitely myself have a lot of questions that I will keep for the Q&A. Dr. Victor Dzau, President of the National Academy of Medicine. Yourself, you chaired the 2016 WISH Forum on Precision Medicine. How has the field changed since then? Dr. Dzau, I'm sorry, could you unmute your mic?
Thank you very much. You know, I followed instructions so well.
Now we can hear you better.
I turned my mic off. Yes, thank you very much. I followed instructions so well, I turned it off, but forgot to turn it on. So I'm very pleased to be participating again in WISH, which has always highlighted precision medicine from the very beginning. As you said, in 2016, WISH had a major policy session, which I chaired, where we released our report on precision medicine. And I'm so glad to hear Dr. Validz's report this time. I want to take a minute to tell the audience of the leadership of CATA in precision medicine, because even back in 2013, Her Highness Sheikh Moza announced the launch of CATA Genome. And I was privileged to be involved at the very beginning of her vision when she asked me to develop a plan for Genome CATA. Our report, called A Roadmap for Personalized and Precision Health, led to establishment of CATA Genome Project, which you'll hear, I'm sure, from Dr. Saeed later. It did bring together all the key leaders, stakeholders, if you will, from the CATA Biobank to, in fact, the CATA Biomedical Research, Computing Research, Harvard Medical Center, University, and Weill Cornell to work together. So the first 5 years have been extremely productive, thanks to the leadership of Dr. Saeed Ismail and, of course, Dr. Asma, in building the infrastructure, the foundation of PM with genome sequencing, Q-chip, bioinformatics, ethics policy, patient engagement, and you'll hear a lot more about this. A little bit over 2 years ago, Her Highness asked me to lead a 5-year review of the CATA Genome program. And the Scientific Advisory Council, which I chair, recommended the creation of a CATA Precision Medicine Institute in order to, as you heard from the other speakers, integrate and bring these pieces together to move into the clinical arena. So QPMI, in fact, was launched exactly 2 years ago by Her Highness at the opening of Sidra Hospital just before WISH 2018. And currently, I'm leading the development of a strategic plan for the next 5 years, particularly in trying to move all these great advances to patient care. And this will be presented to Her Highness on November 22nd to the board as well. So you can see a lot has happened to 2016. First of all, genome sequencing technologies has improved and costs have dropped dramatically. Now you can sequence the entire genome for $400 or less. Importantly, as you heard from the previous speakers, the field has been expanded far beyond genomic and sequencing to incorporate new technologies, the omics, but clinical information, electronic health record, and data from many sources, wearables, lifestyle, social, environmental data. All this requires data, computation, information, and analytic capabilities. The idea at the end of the day is to tailor individual diagnosis and treatment, and it will be implemented in healthcare systems, in primary care, as well as you heard at the population level to advance this concept of precision public health. So, since 2016, we've seen many large-scale national initiatives. The US have the Precision Medicine Initiative called All of Us. China has launched a Precision Medicine Initiative to sequence 10 million individuals, Singapore, and many others, too many for me to cite. So everybody is now realizing this is the future of health, if not the present. Also, as you heard from yourself and the other speakers, precision medicine is being practiced clinically. In 2016, we talk about newborn rare disease cancer genomics. And certainly in cancer genomics, we've seen a lot of advances in targeted cancer therapy. Everybody knows about the non-small cell cancer, carrying the activating EGF receptor mutation, which now you can get targeted effective therapy. Pharmacogenomics, another area we've seen great progress. You talked about that in the folic acid example. Certainly for the practitioners, we think about the use of warfarin. In patients with gene variants of CYP2C9, you have to adjust the doses to reduce the risk of prolonged prothrombin time, the risk of bleeding. Patients with mutation of TPMT, if you receive azathioprine, a immunosuppressive medication, you have high risk of developing severe neutropenia. So we are clearly moving these things into practice, but not systematically. We need a lot more. And as you heard from my previous two speakers, primary care and public health. So more and more people are trying to move into primary care, but not quite there yet. As far as public health, there is in fact now in many countries in US, newborn screening routine, the largest established precision medicine public health program. Fragile X syndrome, severe combined immune deficiency. And also at the population level, looking at common genetic conditions that are associated with preventable premature death from cancer, heart disease. For example, breast and ovarian cancer syndrome, familial hypercholesterolemia, you can screen for BRCA gene mutation, LDL receptor. So it is the foundation, the beginning of moving these genomic concepts into the population, just like cholesterol 60 years ago, first by Framingham study, which is now used routinely for screening and prevention of cardiovascular disease. Another big advance you hear from Dr. Saeed will be the microarray gene chip technology, because now you can use the large-scale genome information from sequencing, but reduce quickly into practice into these microarray chips that can be, in fact, carry hundreds of thousands of gene variants and disease-associated mutations to be used clinically in research and diagnosis. So that's very exciting. And of course, as we're looking forward, the emerging area of use of AI, machine learning, can be applied, as you heard from Dr. Valid. But as you heard from David Humphreys, there are really many outstanding issues. Number one is integration to practice. This remains a barrier because people have to learn a new skill. They also have to do the testing. They have to interpret. It also takes time. So we still have a fundamental challenge in interpretation and clinical practice. As David Humphreys said, we still need a lot more data. The outcomes are not as clear. You need a lot more, and of course, the economics, the cost regulation, economic impact, patient engagement, empowerment, education, workforce. So I'm going to finish by saying the QPMI strategic plan, which I'm leading, will address many of these elements to move precision medicine to clinical care and public health to improve the health of Qatar. The plan is to move from pilots to scale, from specialty to primary care, and from healthcare to public health. And I want to thank Her Excellency Hanan Al-Kuyari, Minister of Public Health, for her support in moving the clinical piece to move along with the genome piece and the precision medicine piece. So I think in 2020, the world is better prepared, aligned for precision medicine, but we still have ways to go. Thank you.
You gave us a great introduction to Dr. Smaid. Unfortunately, he's not next. Next, we have Dr. Lotfi Shoukan, the professor of genetic medicine, microbiology, and immunology at the Weill Cornell Medicine, Qatar. Dr. Shoukan, why do you think the implementation of a precision medicine program is likely to succeed in Qatar? Where do you see the most impact?
Thank you for the introduction. Just to correct my name is Lotfi Shoukan, not Shoukan. Okay. I see at least 5 factors which could make the implementation of precision medicine program is likely to succeed in Qatar. As mentioned by the previous speakers, the leadership of the country is committed to provide the resources and accessible healthcare services to the entire population, but also to deliver precision medicine managed according to the world-class standards. This is the first factor. The second is the world-class healthcare and biomedical research facilities are already available in Qatar. The third one, and Qatar has successfully dedicated through a number of different initiatives and projects to attract world-class physicians and researchers who are investing heavily in local capacity building. In this regard, we do have 2 main programs, academic program, PhD program launched by the Hamad Ibn Khalifa University entitled Genomic and Precision Medicine, which is in terms of capacity building, it will provide the manpower for precision medicine in Qatar. The other program is the genetic counseling, master in genetic counseling in Qatar University. The fourth factors supporting that the implementation of precision medicine is likely to succeed in Qatar is that there is a relative ease in implementing a precision medicine program in a population with the size of the Qatari population. Last but not least, I think with the launch of the QPRI, or the integration of Qatar Genome Program and Qatar Biobank, the new avenues could be opened by for the biotech and pharmaceutical industries. The effective application of precision medicine in Qatar could improve not only population health, but also the development of knowledge-based economy. Seeing Qatar as a potential hub to GCC and other markets, biotechs and pharmaceutical companies from the US and Europe could be attracted to set up a joint business venture in Qatar. So in terms of impact, I think as mentioned by other speakers, precision oncology, which is cancer, is really a very attractive field for precision medicine, which could have an impact not only in Qatar but worldwide. But I see, specifically for Qatar, could be as a potential precision medicine hub for rare diseases, and this is for many reasons. As we know, rare genetic disorders represent a significant source of morbidity and mortality in population with high rates of consanguinity, including in Arab populations. And they are estimated to be the second leading cause of mortality, of infant mortality in Qatar. So many of the genetic diseases that plague Arab population are not greatly shared with other populations, which means that genetic testing developed for other populations are of very limited value for the Arab communities. For this reason, I strongly believe that Qatar could play a major role, not only implementing precision medicine in Qatar, but also to be a hub for rare diseases in the Arab world. And I'm going to stop here, and I would be happy to answer any question you might have.
We will get back to you for sure. Thank you, Dr. Shoshan. And now to Dr. Saeed Ismail. Apparently, you're the star, according to your colleagues here. You've been heading the Qatar Genome Project for the past years. What have you learned so far, and what was going to happen in the coming 2 to 3 years?
What we've learned during the past 5 years is that the decision that was taken 5 years ago, and I have no credit in that, by the QF leadership, when they decided to launch a national program to lead the national efforts to prepare Qatar to become a leader in precision medicine, was the right way to do it. Having scattered projects here and there in hospitals and research centers in universities was not going to put Qatar at the forefront of implementation of precision medicine. Having a small group of people under the title of a national project like Qatar Genome Project, and then try to sort of coordinate all the and spearhead all these national efforts. Again, the universities, the healthcare providers, Hamad, Sidra, even the Ministry of Public Health, the legislation bodies, and everybody around a common vision was the way forward. It's not an easy task to coordinate all these efforts, but this is the only way to do it. What we've also learned is that as it is the case with any sort of learning process, the beginnings are slow, the beginnings are difficult, and then your curve will start to shoot up. You will start to see things speed up, and then you will start to see things happening at a faster rate, and you will see the outcome of your investment. The past 5 years, we spent a lot of time and effort in producing data, in making it available to researchers to mine it, in working with the universities to establish the right programs that will generate local human capacity. We spent a lot of time working with the Ministry of Public Health on preparing some guidelines and policies. We've worked with all sorts of stakeholders to sort of pave the way, as we always say. This is the cliche we use. We pave the way towards precision medicine. Now we are at a stage where we think it is the right time, as Professor Zhao indicated, to sort of harness what we've done and achieved and produce over the past 5 years and try to basically shift gears from research, producing data, getting the researchers to work on the data, and try to implement as these outcomes at the clinical side and basically show the patients that this can impact their life or the healthcare they are receiving. And even that's not going to be as straightforward. And as Professor Zhao again indicated, you have to choose your models where you want to start to show the impact. Pharmacogenomics is one place. The Q-chip, which we produce, is another example. Basically, this Q-chip is a summary of variants that we've discovered or sort of studied in the Qatari population. And we think that they are related to a wide array of diseases. And so we've put all those hundreds of thousands of variants on a very small chip, which will be able to offer diagnosis to dozens of, or even more, of rare diseases and other diseases that were undiagnosed or require a lot of different single assays in parallel to basically reach a diagnosis, and will hopefully basically shorten what they call the diagnostic odyssey. Mm-hmm. Basically, experts know that a family with a child born with a rare disease might take 5 to 6 years to come up with a diagnosis. With the new solutions we and other large-scale genome projects are providing, this diagnostic odyssey could be cut into a much shorter time, and we are all aware of how important it is to reach an early diagnosis in order to become with an effective treatment. Mm-hmm. And it's not just on the diagnostic side, it's also on the preventive side. We are now more aware of the genetic mutations or variants that make the Qatari population or individuals in this population more prone or more at risk of this or that disease, and thus we can provide better advice to healthcare providers and the people who put strategies for healthcare in Qatar in the next decade or two about where to shift their sort of campaigns, awareness, what are the basically more important things to tackle and try basically to prevent disease, not only diagnose it in a better way or treat it in a better way. So I think we are now at a stage where we can actually harness, as I said, the hard work and the huge amount of data that has been produced in the past 5 years.
Thank you, Dr. Ismail, and thank you everyone for sending your questions. I hope we will have the time to get to go through all of them now with the Q&As. So I have a first question going to Dr. Zhou. In countries with higher populations like the US, what does it take to build the infrastructure for precision medicine?
Well,
don't forget to
thank you
unmute
for
your
asking
mic.
that question. I think it is unmuted, is it not?
It's working.
Yes.
Yeah, it's working.
Thank you.
It's working.
Thank you for asking the question. I think just like in Qatar, every country has to build that infrastructure over time, starting, in fact, you heard from both the technology of the omics to the computation capability to collection of data and the integration of this and move into practice. One area I do want to emphasize is community engagement. So what we've learned very importantly is that getting people involved and empowered is really important. In US, all of us spent initially a lot of time making sure that we get the average individual involved, volunteer to be part of a study, and importantly, that it represents the diversity of the population. So I think in every country, all these technologies has to be built, brought up, but importantly, has to be, in fact, begin to pilot into practice. So let's not forget education, genetic counseling, all this work. So there's a fair amount of work ahead of all of us. But the good news is many, many countries are getting ready, if not already on the way towards precision medicine. Thank you.
Thank you, Dr. Zhou. Speaking of infrastructure, this will take me to a question addressed to Mr. Humphreys. I'm sorry for the people who asked the questions. You did not put your name. Mr. Humphreys, financially, the immediate cost of building infrastructure for precision medicine might look substantial to governments, but on the long term, researchers assure that its implementation would reduce cost on health systems. How do governments weigh this equation?
You bring up an interesting point in that time frame, the time dimension of being able to realize those investments and see the return of those investments is really very critical. I'm struck by the examples mentioned here today, particularly in Qatar, that one of the keys to success is leadership and political will, to set up the infrastructure required in data and understanding and culture and integration and the like. And so that time frame for investment, and I think today in the situation that we're living in many countries of the world, emphasizes the here and now and the challenges that we face, but we have to work towards making long-term investments in people, in infrastructure that enable the science that we don't even know is possible, but is to come. And so the countries that are more successful in generating better outcomes, being more efficient, have actually had that political will and leadership to make the investments necessary. It's also could be a strategic advantage for countries in different regions in the world to make these investments, the building blocks for future health systems and for future innovative industries. And so that is the best answer that I can give, and staying out of the trap of being just focused on the here and now is really very critical, in expanding the view of impact beyond just health, that a healthy population has an impact on productivity, has an impact on educational team, it has an impact on a variety of things. And so that measure of value is really very critical in how that is framed.
Dr. Koronfle, what would you say to those who would argue that we haven't even gotten the basics right in terms of providing routine care, such as vaccinations? So why should we be investing our limited resources in precision medicine?
Thank you, and thank you for this question. I mean, it's always a struggle in terms of how you measure the return on the investment for the healthcare system. Part of it, we said, it's leadership and political will. But the other part of that is that you have to look at your population as a healthy population, you know, because there is a return on investment in that, as David has said, in terms of economic productivity. But at the end of the day, I think there are a series of educational and professional programs that need to be implemented. And one aspect of that, which I mentioned even for the Economist report, is really the need for a reform in medical education. And I think that's really key in order to prepare the next generation of physicians, because the next generation of physicians has to deal with different kind of technology and different ways of sort of diagnosis. I mean, a physician that needs to speak the language of AI, machine learning, omic tools, ability to look at the data, analyze it, digest it, and they even present it to the patient. So that's one aspect. But in the interim, I think there has to be a widespread reform in the healthcare system itself in terms of how you train your professionals. I think the healthcare system, and COVID has sort of showed that, is a bit stressed. And then you're asking physicians, nurses, physician assistants to perform this sort of an extra level of productivity and knowledge. And I think preparing a workforce is really key. So in Qatar, of course, Dr. Lutfi mentioned a variety of capacity building programs, but Qatar is not isolated from the global arena. And I think that's pretty much the case, whether it's in Western Europe or North America, and the importance of preparing the workforce and the importance of preparing professionals in the healthcare for this new wave, what we call future medicine. And I think Dr. Zhao wants to do a follow-up comment on perhaps what I said.
May I? Yes. Well, I do want
Yes, sure, go ahead.
Yes, I hear very much the question, perhaps in countries that have less resources, how do you build up the building blocks, and how much, resources will you need while we have already other needs? I just want to point out that, if an average patient that comes to see a physician or provider have to achieve a diagnosis and treatment, and the trial and error is a big problem. We have released a report at National Academy that 40 to 50% of diagnosis and treatment in the global sense, particularly in low-income countries, are in error. And so you can imagine the amount of resources needed, in fact, and not yielding good result. Precision medicine allows you to cut all those corners, if you will, and go straight to the right diagnosis and the right treatment. So that certainly is an argument for investing in this area. Perhaps for low-income countries, the best is to start in steps. That is, begin think about genetic history, doing the testing that are in fact more routine and obvious, and then move up to a larger investment when there's more information emerging from the research and the application for the from other countries. I think that may be the way to go. Thank you.
I think there's a great example of that.
By building a data pool. Yes.
I was going to say there's a great example,
yes,
just as Dr. Zhao said, that if you look at Genome Africa, where the Sanger Institute, Wellcome Trust, where is the NIH in the US, and precisely is to help less developed countries, but there is a value in that in terms of the information, the knowledge, and the diversity actually of the genome and the data that will be available, that all can benefit from it. So yes, small steps can go a long way.
So from what I hear from everyone here in this panel is that you have to have in parallel steps, building data, preparing the right personnel, and investing financially, and also patient awareness also of, because a lot of people are not really opened up to share this much data. A lot of people are afraid for their privacy, and they're not really happy when they hear words like having a chip or microchip with all the fake news about it, and that people will control us and so on. So I guess there's a lot of ways to go to move forward. But as Dr. Karanfli said, the first is to prepare the physicians, which takes us to Dr. Shushan. Is the new curriculum really helping future physicians and healthcare providers be up to the task?
Yes, indeed. Actually, even on our medical program, curriculum is adjusting some principles related to precision medicine. For instance, when we talk about genetic medicine, now we are talking about genomic medicine because there is evolution from genetic to genomics. And as I said earlier, even for the context for Qatar, we are launching and setting a program dedicated specifically for precision medicine, such as the genomics and precision medicine at the HBKU. So yes, indeed. So in that determined at the level of the medical education, but other programs, we are taking in account when we set precision medicine as a goal. We have to adjust our curriculum according to the new avenues and the new formats of such as precision medicine.
This takes us to Dr. Ismail. By 2025, the Qatar Genome Program is expected to have a genome mapping of the entire population of Qatar. How will this change, and do Qataris are open to sharing this much data and getting their genome sequenced?
Let me just go back quickly to a point before I answer your question, which is how we can help low-income countries. And let me just shed light on one of our latest projects. We've just very recently started sequencing the genomes for thousands of Arabs living we call them long-term residents in Qatar. Mm-hmm. And that will give all Arab countries, and even countries beyond the Arab world, in the greater Middle East, a chance to make use of the huge data we're producing here in Qatar for those individuals. And we are about we are contemplating basically, even eventually, when we get this data, to make use of it and incorporate it in this chip. And this chip is not very scary, by the way. It will be used in diagnosis. Going back to your question, after 2025 and whether the Qatari population is welcoming this, 2 years ago, we've conducted a national survey. And we've asked basically healthcare professionals how important is it for them to go into precision medicine, but we've asked also the Qatari population, a representative sample of them. How much are you intrigued by your genetic makeup? Do you want to know about your risk of disease? Do you want, eventually, this last question, are you willing to donate a sample to a national Qatar Genome Project? And the answer was very, very welcomed by Qatar Genome. Over 71% of those surveyed said not only that they are willing to want to know about the genetic makeup, they are willing to donate a sample for Qatar Genome Project and for research purposes, not only to get something in return. And this is among the highest you can get in other countries like Estonia, genomics in England and other countries. So the Qatari population is supportive of this initiative. And in 2025, if you ask me what would we love to see, I will give you just this example. Someone goes to a clinic and then he's suffering from this or that heart disease, and the doctor is prescribing an anticoagulant, say warfarin. And we all know that warfarin, you need to adjust the dose up and down, so you don't want the blood to be too thin, or you don't want to give a dose that is not very effective. And patients do go in this trial and adjustment.
Yeah.
the ideal situation after many years is that you go there, the doctor prescribes warfarin, the genome of this guy could be in the electronic healthcare record. The system will tell the physician that you put this man on 3 milligrams per day or 5 or even higher. This is the one example that brings up the importance and the beauty of precision medicine.
I have a question that will go to everyone in the panel coming from the viewers. COVID-19 is understandably dominating much of the conversation around healthcare at the moment. Some early studies have identified certain high-risk genes as risk factors for poor COVID-19 outcomes. What role might precision medicine play in helping us to tackle the pandemic or other pandemics maybe in the future?
Absolutely. I mean, we're all seeing that some people get the virus asymptomatic, others need intensive care. And this is largely due to the genetic makeup of those infected. Qatar Genome Project has joined the international efforts. We're part of this largest consortium in the world studying host genomics related to disease severity, COVID-19's disease severity. And the whole world is coming together because you need a lot of samples, a lot of patients. And we are the only representative in that consortium from the Middle East. And we are now with our international partners studying what genes actually are affecting the severity. And again, the outcome of that, if I want to be optimistic and tell you what could be the case, who knows? You could, if you discover those genetic determinants, you could stratify patients and you could know and tell who are at higher risk, so you keep an eye on them. And that's the beauty of again, of precision medicine, that you can predict disease rather than just deal with it after it's the onset.
Maybe we'll find a gene that causes some people to be more reckless than others also in dealing with the pandemic. Dr. Zhou, I address you the same question about COVID-19, but also about how can we deal psychologically with patients who have other concerns than their health. They have concerns about their privacy. They have concerns about they don't really like this technology. They like traditional medicine.
Yeah. On the COVID, I think Dr. Saeed is absolutely correct. Qatar is playing a major role. And I'm aware of course, as you heard, the international consortium that comes together, bringing large amount of data, look at what they call host genomics and viral genomics. On the virus side, you can see how it's mutating and whether it's changing its characteristic, whether it's more transmittable. And on the host side, you can see who are more susceptible. So this is going to be really important, not only creating a public health strategy, but possibly even therapeutics. With regards to the concern of individuals, I think it's absolutely important that we have patient engagement and empowerment, as the report says. That is, the patients have to be well educated, feel comfortable, have trust in the government on the use of their data. I also think that it could be optional. In other words, at the beginning, we certainly cannot enforce everybody to say every single my information, therefore, is controlled by somebody else. But that being said, I think in the long run, when people get a lot more trustworthy and also confident, this could be very effective. So the engagement of patient population, the community, the education is critically important.
Thank you, Dr. Zhou. And last but not least, Dr. Koronfle, we've accomplished so far. Where do we go next? Where should be our area of focus?
I think for precision medicine, I think the future is bright. And I always remember what Lee Hood said. It's one of the early papers where he sort of put the vision for precision medicine when he said, there will be a time where precision medicine is going to be precise, predictive, preventative, and participatory, and he referred to that as the P4 or the 4 Ps. So the future, particularly in Qatar, is extremely bright, as Dr. Zhou and Dr. Saeed has explained, especially with the creation of an umbrella or an entity like QPMI, the participation in different genomic projects and the participation on the international stage, like with the COVID. And I think there is a really strong leadership and a political will that is driving implementation into the primary healthcare system here in Qatar. And similarly, you can see it in small countries. I mean, countries like Iceland, Estonia, the Faroe Island, those sort of types of projects that have demonstrated and have been successful in terms of showing the return on the investment in terms of precision medicine, and also what I call the next public health, which is precision public health. And you're gonna see a tremendous evolution in the area of computational power in terms of AI machine learning. And I think that information age for medicine is here, is very here, and it's real. It's not theoretical anymore.
Yes,
Thank you.
it is absolutely here. Dr. Ismail, we have the time for one last question. So with the QPMI now being the bigger umbrella for Qatar Genome Project and many other projects in precision medicine, what do we expect in the coming years?
We expect translation, as I said, of the research outcomes in the past 5 years into impactful measures at the healthcare providing sort of level. We expect to be more closer to Hamad Medical Corporation, Sidra Medicine, those who do deliver this service to the patients. And we also expect that we could have more awareness campaigns. As I said, a lot of precision medicine is about prevention, and patient empowerment that Walid mentioned is a very nice way to describe this. People, patients, or they're not patients yet, they have to become more aware of what their genes are making them susceptible to, and what are the measures that they should take to listen or live with this risk and deal with it.
Thank you. We're looking very much to it. Thank you, everyone, for joining us online. And thank you to my distinguished guest, Dr. Lutfi Shoshan, Professor of Genetic Medicine, Microbiology and Immunology at Weill Cornell Medicine in Qatar, Dr. Victor Zhao, President of the National Academy of Medicine in the USA, and David Humphreys from who is the Global Head of Health Policy at the Economist Intelligence Unit, and Dr. Saeed Ismail with me, Director of Qatar Genome Program, Dr. Walid Koronfle, Director of Healthcare Research and Policy, which will be with us tomorrow as well for the panel about cancer care. So don't forget to tune in tomorrow at the same time for our next panel. Stay safe and healthy, and see you soon.
Amid our focus on climate change, time now to look at how it is likely to exacerbate the spread of infectious disease as global temperatures and extreme weather events increase. That has been explored by the WISH Climate Change and Communicable Diseases report and this forum panel discussion.
Hello, everybody. It's another welcome from me, Stephen Sackur. I'm in London, and I'm delighted to say I am hosting another WISH forum, this one on climate change and communicable diseases. Now, you may earlier have seen me chairing a fantastic discussion on climate change and health. It was a broader discussion of the general challenges being posed to health leaders at every level by climate change. This time around, we're going to be much more specific. We are looking at climate change and communicable disease. Now, in a funny sort of way, despite the reality of a world wrestling with COVID-19, we ought to just spend a moment celebrating the fact that in the last few years, the world as a whole has achieved quite a lot in terms of reducing the impacts of communicable disease in various parts of the world. Of course, COVID-19 and what we're facing right now sometimes makes it hard to remember that. But even in that more positive context that I'm trying to provide, the reality is that climate change does pose a real challenge. Warming temperatures are spreading the reach of certain infectious diseases, and I'm thinking of dengue fever. Also, malaria is exploiting, or malaria is, as a result of warming temperatures in certain parts of the world, becoming more prevalent, and that is a real challenge. We also see the impacts of population migrations as a result of climate change. That too, population movement, making it harder to control some infectious diseases. And of course, we have the extreme weather events and the dislocations caused by them, which again has real impacts on our ability to control communicable diseases. So that is the context in which we are going to have this discussion. I should say, of course, a big thank you to the whole WISH team and to the Qatar Foundation for having me back to stage this discussion. But I also want to give a special thanks to specific partners we have on this forum. So a great deal of thanks to our partners in Qatar's Ministry of Public Health, the Hamad Medical Corporation as well, and the Primary Healthcare Corporation, all important sponsors and supporters of this particular forum. As in the first forum, we have a format here. There is a forum report which has been prepared by a bunch of experts who've been looking at this challenge over the last few months. We're going to hear a presentation on that report in just a moment. But before we do, let me introduce you to all 5 members of my panel. And panel, I can see you all. It's great to see you all on my screen here in London. Please just give me a wave when I introduce you specifically so everybody around the world can get a handle on who is who. So we have on our panel Dr. Abdul Latif Farkhal, who is Deputy Chief Medical Officer and Director of the Department of Medical Education at Hamad Medical Corporation. Very good to see you, Doctor. Thank you for joining us. We have Professor Jeremy Hess, who is Professor in Emergency Medicine, Environmental and Occupational Health Sciences and Global Health at the University of Washington. Now, Jeremy is one of the co-chairs of this forum. So Jeremy, very, very heavily involved in the production of this report. And his co-chair, please give us a wave, is Professor Rachel Lowe, Associate Professor and Royal Society Dorothy Hodgkin Fellow at the London School of Hygiene and Tropical Medicine. So Rachel, welcome to you. And Rachel, in just a moment, is going to present the outline of this particular report, and I'm looking forward to hearing that. Two more members of our panel, Dr. Michael Ryan, Executive Director of the World Health Organization Health Emergencies Program. Welcome to you. And Ambassador Stephanie Seydoux, Ambassador for Global Health for France, for the French government. So it's great to see you all. Thank you for joining me. The first thing we must do before we begin our discussion is hear from Rachel. But Rachel, even before I introduce your presentation of the key elements of the report, let me just say to everybody watching, this is going to be as interactive as possible. It is a very important subject, so I'm going to lead the debate for a short while after Rachel's introduction, and then we want you to send us your questions, maybe your insights and experiences on the WISH platform, the WISH 2020 platform. So do not be shy. Send us your questions or observations, and I will put them to the panel. But first off, let us hear from the co-chair of this particular forum, Rachel Lowe.
Hi there, I'm Dr. Rachel Lowe, an Associate Professor and Royal Society Dorothy Hodgkin Fellow from the London School of Hygiene and Tropical Medicine. With Professor Jeremy Hess, I have co-chaired this special collection on climate change and communicable diseases. Climate change has been recognised as the greatest health challenge of the 21st century. Climate change is causing the emergence and re-emergence of many infectious diseases of public health importance. And warnings that have been issued over recent decades have been mostly ignored by governments, and climate change is generally low priority for most funders. Climate change impacts infectious diseases in many different ways, through ecosystem changes or through disruption of disease control efforts. We've seen increases in malaria in tropical highlands in Colombia and Ethiopia. We've seen the expansion of arboviral diseases, including dengue and chikungunya, which are extending into more temperate regions, and also an increase in tick-borne diseases and also West Nile virus in Europe. There are many gaps in the evidence base linking climate change to infectious disease. For example, there are parts of the globe experiencing significant shifts in climate, including parts of Africa and the Middle East, which are underrepresented in the evidence base. There is a limited amount of research on the role of interannual variability as opposed to long-term climate change projections related to disease risk. And our understanding of how climate variability impacts diseases with a strong seasonal cycle is understudied, and this is really important for developing early warning systems. We also need to improve our understanding of how extreme weather events such as floods, droughts, and tropical storms impact both the timing and intensity of disease outbreaks and hinder response efforts. Our report outlines 6 strategies to build resilience and mitigate the impacts of climate change on infectious diseases. These include leading by example and reducing the carbon footprint of the health sector, increasing funding for climate and health research, and framing the problem with a transdisciplinary lens to increase our chances of developing the most innovative solutions. Incorporating environmental information, including Earth's observations and seasonal climate forecasts into public health practice, will give us the opportunity to improve decision-making processes. We need to invest in decision support modelling tools and communication strategies with a focus on community engagement. And importantly, we need to build human capacity in data management, integrated surveillance and leadership, with equity, diversity and inclusion at the heart of this endeavour. The COVID-19 pandemic has showed us the consequences of unheeded warnings. Years of inaction on climate and health are likely to result in even more dire consequences. A wait-and-see approach is short-sighted and invites unnecessary risk. The global health community must align with the WHO and IPCC in their calls for action on climate and health. Time is short and options are increasingly limited. Strong action must be taken now. I look forward to welcoming you to our panel discussion at WISH. Thank you.
Well, there you have it. Rachel's opening remarks really do emphasize just how serious an issue this is. In some ways, one could get rather depressed about the impacts that climate change is likely to have on communicable diseases. I want to begin the panel discussion by just getting from the broad brush to very specific. And Michael Ryan, I'm going to start with you. Michael, how much data is there on the degree to which climate change is already exacerbating problems with certain infectious diseases in certain parts of the world? I'd like a little more detail, if possible, if you can provide it. And also, Rachel, interestingly, she said in the course of that presentation that it's clear there are problems, but it's also clear that governments over years have ignored warnings. So I'd like you to give me a sense of how sort of aware and woken up, if I can put it that way, governments and public bodies around the world are to this long-term impact of climate change on infectious disease. Michael, if you can hear me, you need to put your... Yeah, Michael, you need to unmute yourself. There you go.
I'm muted, yeah. For me, it's almost like 10 18-wheeler trucks heading down different roads to a central point. The climate change, the weather events, population density, movement, inequity, human rights, everything is converging. And in a sense, the infectious diseases, the epidemics are an outcome of those forces, both forces in the environment, forces in socioeconomic development, globalization, and many other things. But the reality, going to your first part of your question, is we are definitely seeing increases in weather-related epidemics. Rachel has laid out many of the issues that are affecting climate. Tends to drive the range of infectious diseases. Weather tends to drive their intensity and their seasonality. And then it's really social factors. We're packing more and more people into peri-urban slums. So even as you said, if dengue is a problem, it's not just a problem of climate, it's a problem of where people are living at risk from those climate-mediated changes. So it's very complex, but the reality is there. We're seeing huge cholera outbreaks, for example, in Mozambique in the aftermath of flooding. Again, seeing even diseases like Rift Valley fever, Ebola, many of the epidemic diseases. In a sense, we're the fire brigade, we're the fire service in what we do. The reality is we're in effect trying to mitigate and control the impacts of these diseases. The conditions that drive these epidemics are often set up years and decades before in the natural environment and in the way we inhabit this planet. Sick nature is going to lead to a lot more sick people, and infectious diseases will be one of the main ways in which that is mediated.
And the second part of my question, Michael, was about the degree to which we know a lot of this is happening. And as you say, we know that these juggernauts are heading down the highway and are going to crash. But are we doing enough to prevent? What are we doing right now?
Well, everyone speaks to the cost of health, the cost of infectious disease control, the cost of climate change. We see it as a cost model. So our very thinking on how we address the problem is wrong, because when you see things as a cost center, it's a drain on revenue, it's a drain on resources. That we have to turn the way we think about this around. This has to become an investment-mediated model. We need to invest in mitigating the impacts of climate change, invest in reducing that change. We need to invest in health systems. And when you start to look at that model, then it's not a trade-off off at the moment in COVID is a very good example. We're spending hundreds of times less on the COVID response than we are mitigating its economic impacts. We're struggling to raise money to get vaccines for everyone in the world, yet we're pouring trillions of dollars into income support. So every time we approach this problem, we put health and we put addressing the underlying issues to the back of the bus, and the financial issues come to the fore, the economic issues. And I believe it's the wrong equation. The algebra is completely the wrong way around.
Well, that's a very powerful statement, and the best thing for me to do is put it straight to Stephanie Sédou, if I may. Stephanie, you're the ambassador for global health for France. Are you getting the balance wrong in terms of the way you look at the challenge of healthcare, but particularly infectious diseases? And do you need to recalibrate the equation when it comes to the assistance and investment you make around the world?
Well, thank you very much for the question and for giving me the opportunity to answer that. Indeed, very powerful comment by Dr. Ryan. Well, we can't say that the international community, and it's not the experience of France in particular, has not been immediate and strong as soon as the COVID outbreak came up. And I think what we've seen are really rather unprecedented levels of collaboration, capacity to actually gather together beyond the, let's say, traditional setup of governments, although it's been a government-led response through the G7, the G20 as well. Very strong leadership by WHO, which is a multilateral organization. And beyond that, also private sector, private foundations, civil society, or trying through, in particular, initiatives such as the Access to COVID Tools Accelerator, rise up to the challenge, which was to really gather as much, indeed, attention, financial support, and capacity to get us to finding the vaccine, the treatment, the diagnosis, and the health system responses that were needed in accelerated time. Now, obviously, if we balance out the amount of financing which is needed for that and what has been gathered so far and compare it to other expenses, which, or rather investments, to take up Dr. Ryan's terminology, which were poured into the also very much needed economic response, yes, there is a gap. However, I believe that the way that that's been approached has indeed been one of an investment model within the ACTA initiative. What's been put forward is an investment case. So I'm not saying we're there yet at all, but and that was really my main point, is that we've had to, in a really accelerated crisis mode, find new ways of addressing the issue of COVID and address it in a way which remained as much as possible coherent with strong commitments to other priorities such as climate, of course, and other SDG-related priorities such as education and gender, for instance, and tackling inequalities. So that's definitely at least been the focus of my government. I'm not saying we are, everything is perfect, not at all, but it's certainly been a concern to act as fast as possible in a collaborative, multilateral, and efficient way, and do so without putting one emergency, the health emergency, at the top of our priorities to the detriment of others. And maybe just to finish on this point, say that there's been a big event last week, the Paris Peace Forum, and the focus was indeed on health, how to escape that issue, and took the opportunity to, I hope, relaunch interest and advocacy to gather enough financing for that response, the one to accelerate access to COVID tools. But the focus was much wider, and indeed was on refocusing as well on the environment, on the necessity to address the climate challenge. And one last word to say that one action which was announced during that event was the launch of the One Health high-level expert panel, so promoting the One Health vision of a multidisciplinary approach to health and environment challenges, and doing so at a level, and the objective of that council is to raise awareness and provide reliable and visible information to, at the same time, well, hopefully advise governments and fight the infodemics, which we've seen, unfortunately, too often at play, pretty much on the model of the International Panel on Climate Change, the IPCC. So a few elements of response. Indeed, this is the time to transform the approach to health into an investment case rather than a cost-driven narrative. I agree.
Yeah, well, I don't think anybody would quarrel with the need for a greater investment focus on this challenge of communicable disease in an era of climate change. Having got sort of a global overview there from Michael and Stephanie, I want to get more local now. Abdul Latif Al-Khal is Director of the Department of Medical Education at Hamad Medical Corporation. So your focus is regional and Qatari, obviously. I just wonder if you can tell me about the linkage you see where you are between climate change and communicable disease. And I'm thinking the region, not just Qatar, but the Gulf and the wider Middle East region. Do you see clear linkage?
Yes, sure. Thank you. We always, thought that given that we are an arid, mostly desert region, that probably will not be affected by climatic change that much. But actually, we are seeing it already. In our region, we are already experiencing the effect of climate change with longer summers, milder winters, floods, and more frequent sandstorms. Here in Qatar, particularly in Doha city, we are highly susceptible to uncertain, chaotic, and extreme weather events as a result of climate change. Cities in Qatar are particularly at risk because of their complexity and dense urban ecosystems. Our country has witnessed a rapid population growth, as you probably know, with rapid urbanization and increasing complexity of its cities. Doha, the capital of Qatar, faces climate change risks as we experienced during the past few years, with unusually intense and frequent rain followed by flooding, where the streets flood with water. And the population of Qatar grew very quickly from around 670,000 back in 2002 to 2.5 million in 2018. This is a growth of about 245% in just 16 years. The rapid growth is mainly because of influx of people who are coming for work. Many of those come from countries where vector and waterborne diseases are highly endemic. The ongoing industrial development and mega infrastructure projects, which reflect the economic growth in the country, have resulted in a significant pressure on our local ecosystems and consequently increasing our exposure and vulnerability. This is in addition to the fact that we are a coastal country and with coastal cities, which puts us at higher risk for climatic change and increasing sea levels. While some of the climate changes impacts will have a gradual pressure over time, such as the increasing temperature and the average sea levels, the increased likelihood and frequency of extreme weather variations, like the increasing intensity of heat waves and flooding, will require an immediate attention, and this should be a priority. While there are no reported indigenous cases of vector-borne diseases in Qatar in recent years, Qatar falls on the same latitude and as the rest of the region fall in the same latitude where malaria and dengue fever vectors are spreading. Therefore, there is a need for a robust surveillance and preparedness system to address any potential outbreaks, to assess the magnitude of malaria, yellow fever, dengue fever, chikungunya, Rift Valley fever, and West Nile infections that Qatar will be facing in the future. I think we should be investing more in this field. We should be doing more research that's peculiar to the region. I think there should be cross-governmental collaboration in the region because we share common demographics and geography. We need to direct more resources into research, into interdisciplinary training. We need to have more multi-sectoral approach and interdisciplinary approach to research, training, and policy making. We need to build more human capacity, and all of those things were very nicely reflected in the report. Recently, an assessment was done to look for mosquito vectors in Qatar, using morphological and molecular tools in collaboration with WHO and with our academic partners in Qatar, like Qatar University and Weill Cornell. And this provided some initial data, which shows that we mostly have the Culex and Anopheles mosquitoes in Qatar. So far, we don't have the Aedes and Albopictus, but probably it's a matter of time before we see them here. So there is so much that need to be done. Back to you. Thank you.
Yeah, no, that's very interesting. So what you're saying to me is you believe that it is a very real danger that climate change is going to expand the range of some infectious disease into Qatar in a way that Qatar hasn't seen it before. So the question is are preventive measures already being put in place? Is capacity being built to cope with that reality now, as opposed to sort of waiting for it to happen later and then reacting to it?
I think more needs to be done. I don't think we are ready to deal with a spread of the vectors of malaria and dengue and other viruses in Qatar and the region. Those vectors are already there in some of the countries in the region. We are worried that it's a matter of time before it makes it to Qatar. And I think much more needs to be done. I think much more preparation. And the first steps towards this have started, which is surveying the vectors in Qatar and seeing or coming up with a baseline. But there is so much more work now that needs to be done. At this point in Qatar, the region, only insecticides are used, or mainly insecticides are used to control vectors. These can be dangerous and they are not really adequate. So I think there should be more careful planning. There should be programs, initiatives, and there should be a multi-sectoral approach that involves public health, environmental sector, animal sector, agriculture, as well as academia. And I think that countries should not really work alone. They should be working together. So a country like ours should be working with all of its neighbors and maybe beyond that to try to leverage each other's experience and come up with a collective strategy.
All right. Great. Well, Dr. Alkal, that's really interesting. And thank you very much for that perspective from Qatar on the challenges that you expect to come your way as a result of climate change. Now, I've saved Jeremy and Rachel till last in a funny sort of way, because you both have been intimately involved with the writing of this report. So we've had perspectives from the other three. We now want your perspectives. And Jeremy, I'll start with you. In my earlier panel discussion about the broader issue of climate change and health, there was a great deal of focus on the different vulnerabilities of different groups across the world, both within nations and across nations. So I'm thinking of the different vulnerabilities of the poor, whether it be poor nations or poorer people within richer nations, if you see what I mean. And then the differential vulnerability of children, of women, of indigenous peoples, of peoples who have been forced to move because of economic or political circumstance. Can you, as you reflect on your own report, give me a sense of where you see the greatest vulnerabilities as we discuss this issue of climate change and communicable disease?
Thank you for the question and for the opportunity to present our report to the world. The burden of infectious disease globally is principally borne by children and adolescents, but it's distributed across the age, across the population in terms of age. We've been making pretty steady progress over the last 2 decades in reducing the burden of infectious diseases in children in particular. And overall, the burden has gone down, but it's largely because of the inroads we've made with that subgroup, which is very important. However, climate change may threaten that progress going forward. And so I think one of the main groups that we need to continue to be worried about are children and adolescents. But as you said, it's we've got a wide collection of different diseases here under consideration. They all have different dynamics, different ecologies, if you will, and they affect different populations in different locations based on social vulnerabilities, as Dr. Ryan pointed out so eloquently. And so as climate change begins to exert its impacts along with other stresses that we see, globalization, population migration, inequities, poverty, and ecosystem stress, we will see impacts on different populations in different locations as a result. And you listed many of them, and you're hearing already, as Dr. Alcal said, stresses on particular groups, locations, cities, areas that are growing rapidly and aren't able to keep up in terms of infrastructure and training for health systems and health personnel. And of course, as you mentioned, indigenous people, which in many locations are being impacted already by substantial environmental change and may not have access to some of the protective structures that are available to other groups. So unfortunately, the answer to your question is it depends. It's a very place-specific and path-dependent question.
Do you think the responses you're seeing from the international community, whether it be state-sponsored or from the big philanthropic organizations who focus on control, limitation, and ultimately aiming for elimination of infectious disease, do you think that they, in their approaches, have a sufficiently nuanced approach to make sense of just what you've said, that actually it's a very complex picture of how climate change can impact the spread of infectious disease? Do they factor that nuance in, do you think?
I would say yes and no. That in fact, I think there's already an understanding that infectious disease ecology is quite complex, and there are a number of different factors that influence it. I think there is a decided underappreciation of the influence of climate and climate change on infectious disease dynamics. And part of that is born of the complexity of climate change impacts on disease ecology. It can be tough to pull out and discern influences from a whole range of different drivers that are changing all at once. And we noted that in our report that up until recently, probably the protective efforts of the global health system have obscured some of the impacts of climate change. But in recent years, as several other panelists have already already attested to, we are now seeing the impacts of climate change in a more clear way. And I would say the global community has not appreciated these influences in the sense that it really has not invested very heavily in incorporating the information that it needs to discern these things earlier and with more certainty. It certainly hasn't invested in the kind of training that's needed for medical professionals and public health professionals to incorporate and use this information effectively. And it really hasn't invested in some of the tools that climate and health brings to the fore related to forecasting and scenario-based projections of disease burden that really can facilitate management and early intervention and reduce impacts going forward. So I think that thankfully, the underlying stance is we understand these diseases are complex. They have a lot of different drivers. We can build off of that, but to do so, we have to recognize that climate change is ascendant and an important driver that needs to be addressed, and we need to bring the tools that we have in our toolbox to bear on the problem.
All right, thanks, Jeremy. Rachel, I want to sort of build on that answer a little bit. Jeremy just said climate change is in the ascendant. So I want to have you give me a sense of whether you think the real progress that Jeremy just alluded to, that there's been in the last, let's say, 2 or 3 decades in various efforts to reduce the impacts of infectious disease in many parts of the world, whether climate change, in your view, is of such a scale of problem that it threatens to roll back much of the progress that has been made in recent decades, or is that a silly way of looking at it? Try and make sense of it for me.
Well, climate change is very important for destabilizing elimination and elimination efforts. For example, we often see a scenario where we may be close to elimination of, say, malaria in a certain place, and then once that appears to be eliminated, efforts stop. And then you have the combination of warming temperatures, migration. We're seeing a situation in Ecuador, for example, where we're seeing migration from Venezuela combined with warming temperatures, which is extending the transmission season of malaria. And if efforts to control these diseases stop, then we're really at danger of having a big resurgence. So I think that climate change is just one of the very important factors which needs to be understood. It needs to be addressed. We need to be mitigating climate change so that we can prevent seeing such devastating outbreaks of these infectious diseases. And climate change combined with globalization and the increased level of travel that's happening, it's really something that has to be addressed by governments and in collaboration with local communities.
Do you think, picking up on that point, that the potential impacts that climate change can have on the fight against communicable diseases should be used as part of the messaging to get, governments and corporations and others to really engage with the emissions reduction agenda? In other words, is this so important, and does it strike, do you think, such a chord with the public that there should be more messaging about the correlation between climate change and danger of infectious disease spread?
Absolutely. I think climate change should be at the forefront of all public health policy. It's not just an issue of, the melting ice caps. It's really an issue which will, of course, be very dramatic as well in terms of losing coastline. But we need to think about this in a holistic way. All aspects of a warming climate is going to impact our health. So we will see displacements of population. We'll see the expansion of vectors which will allow diseases to be spread. We're going to see an increase in temperature-related mortality, so a combination of both communicable and non-communicable diseases, and all this together can completely destabilize public health services. So really, climate change and these harmful emissions of greenhouse gases needs to be mitigated before it's too late.
Just one slightly counterintuitive question, and anybody can answer this. Rachel, you've got the floor, but anybody else, if they've got a strong feeling about it. Are there any infectious diseases or any parts of the world where climate change actually promises to help the fight against infectious disease? Because, you know, we're being pretty unrelentingly sort of gloomy about the possible impacts of climate change, but are there any places or any diseases where climate change might actually yield some positive impacts?
I think there will be, you know, there will be some areas. For example, you may see less cold snaps and less mortality related to cold weather in certain places, but that's going to be far more outweighed by the areas where, for example, if we're thinking about infectious diseases where temperatures are warming, particularly, for example, in tropical highlands, and if we're exposing communities that previously had no immunity to diseases like malaria, I think that the overall burden will be negative impacts will be outweighed by any gains.
Thanks, Rachel. All right, panel, we're going to pause just for a moment because we're going to change tack. Obviously, I've been sort of guiding the questions myself thus far, but right now, as I've said from the beginning of this panel, it's time to draw in some of the questions, the observations and insights that have come from you, the audience. So let's get to some questions from all of you watching this panel. Okay, panel. Well, I dare say you're going to get much more searching and intelligent questions now because they're not coming from me, they're coming from the audience. So let's see what we've got. I'm just getting them here on my smartphone from people who are watching around the world. Okay, let's start with the first one. And again, actually, Michael, we haven't heard from you for a bit, so you take this one on. Question, do we have the capability to predict the next pandemic, or pandemics, plural, to enable the global community to either prepare better or to avert them? And that's come from Taufik Ashiru.
Taufik asked a great question. No, we don't. We have some elements of predictive capacity for certain diseases like Rift Valley fever and others. We've had projects of looking at satellite imagery and vegetative indexes, rainfall, and being able to predict some vector-borne diseases. Certainly, cholera epidemics are predictable in only that where cholera is endemic, you will see outbreaks in the aftermath of waterborne events or big weather events. We are working ever more closely. We've set up a global system with many agencies to look at epidemic intelligence from open sources, bringing together all the epidemic surveillance community together. At the moment, we're building another ecosystem called EpiBrain, within which we have a project called EpiCast. And that's really our big problem in predicting real-time predictive analytics is pulling all of that data together. You know, with the current weather system around the world, all of the satellites, all of the buoys around the world of the sea, all of that data is collected and integrated and shared. And then that data is available to scientists to do weather forecasting, to do long-range weather forecasting and climate forecasting. We don't have that same integration on the infectious disease side. So we're working with a whole lot of institutions around the world, academic, the IT sector, building this, what we would call a new ecosystem for both collecting data, developing the artificial intelligence tools to drive the analysis of that data, and making that data available to researchers around the world. One of the biggest barriers for researchers in infectious diseases is not the knowledge of how to manipulate the data, it's actually accessing that data in a way that doesn't cost the earth. So we're trying to solve the three things at the same time, and we'll be reaching out to many people on this webinar, and our two colleagues, Jeremy and Rachel London School and others have been involved in initial discussions. We have to get better at predictive analytics for epidemics. But like weather, the more data you have and the better your analysis, the more accurate your forecast is. And therefore, we need to get much better at doing that. But that's going to require a significant investment. The reason we've invested so much in weather forecasting, because weather drives agriculture, it drives travel, it drives planning, it drives so many core elements of our economy. We've got to see that predicting epidemics and infectious diseases has got to get that same level of attention. And then when we do have that predictive capacity, we have got to prepare both to prevent and to respond to those. It's one thing knowing something is coming. It's another thing being able to do something about it. We have that chance of doing something about it, both from the bottom up side and the top down. Sometimes we're too technological. Our systems are saying, let's make the vaccine. Let's find the golden bullet, the silver bullet. And we tend to look for the unicorns that will solve all our problems. A lot of infectious disease preparedness and mitigation is at communities. Dengue can be averted as a major health problem if we give people living in slums the basic resources to clean up breeding sites. It's a community process. We've seen in COVID, countries like Thailand and others have used community-based approaches to really crush this curve of COVID. So I think we have to both look at this as a bottom-up initiative and a top-down. From the top down, we can bring the analytics and the prediction, but we must invest from the bottom up in our communities.
Well, I dare say in a horrible, grim sort of way, COVID-19 has served a purpose in that surely it's focused the minds of governments and other key actors in putting the investment in that you say is required to fully integrate these systems to make the predictive capacity so much stronger. But Jeremy or Rachel, who clearly you do work around this, how long is it going to take, do you think, to get the integration that Michael's just talked about, to truly tap into all the capacities of AI and other data analysis and collection to get this integrated system going? Is it months, years, many years? What is it?
Well, I think, it's a big challenge, and as Michael points out, in the weather community have been doing this for decades and have so much data at their fingertips, and that's a real challenge for infectious disease, being able to collate all that data and have it at your fingertips to be able to make accurate predictions. And it's a very challenging area as well, because when you forecast the weather, a different outcome can mean, a rainfall event could be good news for one user, but bad news for another. But, an infectious disease outbreak is always going to be bad news. So it's going to be a real challenge to figure out how we can, manage an EPICAST project that it has many different connotations, and we'll have to think about, there's also ethics involved in collating infectious disease data. And it's going to be a big challenge, but it's absolutely something we have to do to be able to be ready for the next pandemic.
And I would argue that
absolutely,
it's not necessarily it's more than months away, certainly, but it's not decades away. With the right intentions and the right agreements and the right investments, the data is already being collected in many health systems around the world, and it's a matter of addressing the ethical issues and privacy issues and making sure that we can aggregate that data and access it safely. And we've seen, as we've referred to earlier, pretty substantial improvements in global health over the last 2 to 3 decades. And a lot of that is because of very focused, refined, intentional investment in reducing risk factors. And we can do the same here. One thing that I would argue is perhaps a challenge that we didn't fully appreciate until COVID came around is the importance of governance and the importance of protecting perceptions of science. That goes hand in hand with building networks and building analytics and building forecasting capacity. If there isn't strong public faith in science and in governance of these issues, then whatever efforts we assemble are likely to falter. And unfortunately, we've seen that in my country with COVID and some others. And that's a challenge with climate change generally, and certainly something that the global health community is attending to and really needs the help of other sectors to build.
Yeah, but I mean, that's an interesting point, because there are, we know as a result of what we've seen in COVID, there are many people who are skeptical about what scientists tell them about the nature of the disease, and in particular the safety of a vaccine. We know there are substantial numbers of people who are wired to be skeptical, and there are also, frankly, a lot of people who are wired still, it seems, to be skeptical about climate change. So if you put the two together, and you possibly are beginning to see a wall of skepticism, which you guys are going to have to figure out how to overcome.
I think transparency
Anybody
is key,
want to take that
do...
on? Michael, you're looking. Go on, Rachel. Sorry, Rachel.
No,
yeah,
I'm smiling, Riley, because I think you're exactly right. But I wouldn't like us to walk away from a conversation like this with a sense of despair. We've seen the most incredible. There's 2,051 therapeutic trials for COVID going on around the world. Unprecedented multinational cooperation, and scientists have continued to collaborate regardless of the political differences or the ideologic differences. We've seen hundreds of vaccines in various forms of clinical evaluation. There are thousands of scientific papers literally coming out each day on every aspect of how we deal with this and how we move forward from this. We've seen a massive outpouring of solidarity amongst communities. We've seen the greatest acts of kindness. We've seen massive courage by communities and frontline health workers in the face of a devastating disease. I've witnessed that for 25 years. I've seen frontline doctors and nurses, deal with Ebola. I've seen untrained staff have to bury bodies. We've seen people fight malaria. We've seen people in cholera camps treating thousands of cholera cases per day. We've seen local communities take action to protect themselves and protect their communities. I think we need to tap in. We live in a sensitive biome. We're in a biologic dome here in the planet, and it is highly sensitive to everything we do, both positively and negatively. It's not really, in some senses, the corollary of we're screwing up the climate is we can actually, if we change our actions, we can go in the opposite direction in terms of our society, in terms of social justice. So I actually see great hope. I see a massive evidence that we as a civilization can turn this around. And if many of the same behaviors around data and science and preparedness and mitigation are very similar for communicable diseases as they are for climate. And I can see new hope amongst young people. Young people want to disrupt our current systems. Our systems are not delivering for the next generation. And we need a disruptive influence to change that. If disruption without division, divisiveness is what's killing us right now. Disruption is a positive force if it leads to positive change. And we need everyone to be disruptors, politicians, scientists, communities, and we can handle it. And we can handle the infodemics that come with that. I just would like us to make sure that we take a positive view on what we're learning right now and what we can do in the future.
Yeah, very well said. Thank you very much for that, Michael. Here's a question, and we haven't heard from Stephanie, from you for a bit, or Dr. Alcal. So I don't know if either of you could address this, because I'm going to read you the question. You tell me whether you feel you can respond to it. The question is this. Despite government statements on their commitment to financial support, the so-called COVAX program is not fully funded. And why is this the case, given the declared priorities of governments around the world? Now, COVAX, I have to admit, this is jargon that is, or an acronym that I'm not familiar with myself, but apparently it's the vaccines pillar of the Access to COVID-19 Tools Accelerator Initiative. Now, I don't know how many of you are familiar with that, but the bottom line to this question is quite simple. Governments around the world say they're utterly committed to funding this COVAX program, but it turns out that it isn't fully funded. So, Stephanie, as you speak on this sort of issue for France, can you explain to me why the gap between rhetoric and reality?
Well, the gap is certainly there, but it's reducing. As I said last week, there was renewed commitment by some governments, including France, and so an additional pledge for over $50 million was announced, and I hope more will come. And when I say I hope, this isn't just simply being wishful. The notion here is that obviously governments have to give more financing beyond the usual development aid, probably. But governments are not the only source, maybe, of financing. A vaccine would benefit the world at large, would benefit, obviously, the private sector. So we have to see how, maybe through innovative finance, we can ensure that we tap into more resource. Also, not to say that the investment case is wrong or anything, but maybe there are other ways to actually reduce the bill. Maybe we can ensure that through mechanisms looking at, voluntary licenses, for instance, some of the costs can be reduced. So there's a lot that can be done, and that's indeed what our government wants to keep the conversation very focused on through a charter which has been put forward for this ACT Accelerator mechanism, to see how we can indeed really get to the objective, which is equitable access for all these tools, and go through the entire range of actions which are interesting and have potential beyond governments coming up with the entire bill, which is of $35 billion, which, of course, they must rise to their responsibility. And again, many have, particularly Europeans, but there's still a long way to go. And so we really have to keep the mobilization at high level, and envisage all possible paths and alleyways in order to get to that, to the target.
Right, but as we look at the news of the first hopeful signs of a vaccine that might be rolled out late this year, early next year, and I'm obviously talking about the Pfizer-BioNTech initiative. As we look at that, I wonder if you as a panel are still fearing what was called earlier in the COVID crisis, the danger of vaccine nationalism, where governments would frankly bring a sort of nationalist perspective to the race to find a vaccine, and then the distribution of a vaccine. They'd be sort of looking after their own interests, their own people's interests, rather than taking a truly collective, communal, global interest. Is that still a real danger, or do you think that has dissipated?
I want to take this on, but I'm sure Dr. Ryan will have very valuable input to say that I don't think that attitude can be sustainable for responsible governments, and that's certainly the feeling the French government has, that there's no way that we can, or that it is an option for our government to go the way of so-called vaccine nationalism, if that means not caring about everyone accessing the vaccine. Now we look to WHO in this charter that we are proposing for others to join as widely as possible. One of the principles is for the allocation process to be definitely driven by the principles of WHO, and to follow WHO's directives as long as, and it will be the case, capacity and quantities are still reduced as the production capacity gets to full speed. Well, where should the first doses go in terms of where will they be more efficient? And we completely believe that regardless of who pre-bought doses, well, they can keep some for themselves. And after all, Europe is currently very much at risk. It's one of the most affected, or Europe or the United States or some other countries have indeed a very intense pandemic going on right now. But then those doses can also be redistributed to others. And that's certainly a direction which our president said would be an option that France would definitely want to consider. So this is at least the point of view that I can put forward on this issue.
Yeah, if I could just add,
I'll tell you what, Stephanie, I've just got...
yeah. Oh, sorry.
Yes, I'll tell you what, Michael, I don't want to get too stuck on COVID because I do really want, I've got some good questions here that we should squeeze in before the end of the session, and it very much is about climate change. And
yeah, but 20 seconds, please.
Go on, say what you want to say, Michael, and we'll...
Yeah, no, but we want to vaccinate some people in all countries, not all people in some countries, and then we get to all people. That day goes back, actually, Stephanie knows this, to earliest conversations on this were actually between President Macron and with Dr. Tedros way back in April. And France has shown tremendous leadership right through the WAIT process, as has the European Union, Germany and others. So we are seeing tremendous leadership. It's getting everybody to get on board the bus and move this forward quickly. Over.
No, thanks, Michael. That's important. Thank you very much. Okay, I do want to now go back to Qatar, if I may, and Dr. Abdellatif. So here's a question for you, because it's very germane to your professional life. How can young medical education advocates fight for the implementation of climate change and health as a sort of correlated set of studies into their respective medical curricula? There's a question from Thomas Petras. So he wants to know if that direct linkage between climate change and health, and in our case of this discussion, communicable diseases, whether that is now being put on the curriculums or curricula of medical schools to ensure that, you know, young medics, young public health people are now taking this very seriously.
Yes, I thank Thomas for his question. I don't think enough is being done to inculcate this kind of those principles into the whether the undergraduate or postgraduate medical education curricula. I think this may be an opportunity to do that. Perhaps this should be taken at a global level, not at a country level, that there should be a call for early education, introducing this concept of climate change and the impact on health into the curricula, changing the attitude very early on among the health practitioners. And this is not only for medical education, but I think that should go beyond that. I think it should be included in public health programs, nursing programs, other health programs, and even in school curricula. I think it's important that community members grow up learning that they are going to live in a more hostile environment in the future with more severe climate conditions. So I think there should be more emphasis including this into the basic curricula for both undergraduate and postgraduate education for physicians and other health practitioners, but also I think should be included in school curricula.
Yeah, good. Well, thanks for that thought. Here's a question, and I'm just going to ask you all to listen to it, and anybody who's prepared to respond to it, raise a hand. It's a bit like an auction. The first person to raise their hand will get the opportunity to answer it. And the question goes like this. I don't know if any of you were able to watch a panel I did earlier, which was the broader panel about climate change and health. David Nabarro, who was chairing the forum on that particular topic, he made a very passionate call for healthcare providers to come together, use their voices to influence policy in a much more direct way than perhaps they've done in the past. He said they shouldn't shy away from what might in the past have been seen as being too political. So the question is, does the panel agree with this when it comes to the communicable disease community? And if you do, how could this message of amplifying voices, how could it actually be made real? So who wants to raise a hand and tackle that? don't all act like your hands have been glued to the chair. Yeah, go on, Jeremy.
Well, I'm happy to set the stage for whoever else would like to contribute. I certainly think that advocacy around this issue is important, which is not to say that we abandon our allegiance to evidence-based practice, but in this case, I think advocacy is evidence-based practice. And we're already seeing this. I think the community has come together through initiatives like the Lancet Countdown, which Rachel and I are a part of, and our engagement with institutions like the IPCC and advocacy at various levels. But I think it could be more strenuous, it could be more coordinated. Our professional societies are taking this issue up and making statements, but it needs to become a more reflexive part of what we do. And one thing I would argue, we mentioned this in our report, and I think it bears mention here, that we need to think about the health sector's carbon footprint, that there's real harm associated with the emissions that come from the health sector. Of course, we do a lot of good, but there are very few analyses that actually look at net good related from or coming from the health sector, because we have substantial emissions. Our emissions are actually larger than the aviation sector. And we shouldn't turn a blind eye to that. We need to clean up our own house. That certainly shouldn't be the only focus of our advocacy work. Our advocacy work needs to be around highlighting the dangers and also all the potential that we have if we work together around these issues. So, but I welcome others' perspectives on this.
Yeah, I think, Stephanie, I may be wrong, but I think your hand was twitching. So do you want to give us your contribution?
Yes, I raised my hand on the panel and not as I should have done like this. No, a very quick one to say, and that's going back to Dr. Ryan's initial very powerful comment about how health ought to be an investment and be presented as such and not as a cost. One aspect of that is giving health workers and care workers in general the right value, their right value in terms of salaries, benefits, place in society, and in many cases that really amounts to actually ensuring that health workers or community health workers, which we've mentioned before as being absolutely key, actually do get paid. And it's unfortunately not the case in all situations. And this is something which, well, I see as definitely as something to be worked on. There ought to be strong commitments towards ending unpaid work in that sector. Also, we know that a lot of these unpaid health or care workers are women. So we ought to be striving to getting this triple benefit of paying health workers correctly and ensuring that they work in right conditions, free from violence, for instance, or free from unnecessary risk. And this yields treble benefits: better health, better equality, and also, well, a better and better economic benefits. So that's one suggestion. Thank you.
Yeah. Yeah, thanks, Stephanie. I've looked at the clock and we're running short of time, so I'm just going to squeeze in one more question. Michael, I'm going to ask you to respond to this one, but I want your pithy, concise response, because we're almost out of time. And the question is, it's a very big one, and it's an important one to end on, I think. Basically, will the Paris Agreement, that is the climate change accord struck in Paris, and we had Christiana Figueres on earlier, who was instrumental in reaching that accord. The question is, will that Paris Agreement make things better for health and in particular prevention of communicable diseases? It's a kind of simple question. I want a fairly simple answer, and it's from Sophie Albert.
I'll give Sophie a very simple answer. Yes. Unquestionably.
Right.
That's as pithy as it gets, Stephen.
That's so short, you've taken me by surprise. Yeah, well, look, I'll tell you what, let's end on the word yes, because so often these panels end with something a bit bleak and depressing. So let us end with that wonderful word yes. And if indeed the Paris Agreement can be followed through on, the message from here is that it will undoubtedly help in the fight against communicable diseases across the world. So let's end with that thought. We are almost out of time. I always like just to have a little bit of a summation at the end, which involves, first of all, thanking my terrific panel. I can still see you all sort of smiling, mostly smiling at me from your various locations. It's been a real pleasure having you with me on this panel. I wish we could have done this in the flesh, because it's always so much easier without all those nasty time delays and what have you. But thank you so much. Jeremy and Rachel, congratulations on getting this forum report out there. It is very important, and I think over the last hour or so, we've managed to get at least a little bit of a flavor of both what's in the report and why it matters so much and how it fits into the wider climate change and health debate. So I thank all five of you so very much for that. I should also just note that the report is part of a wider collection with the BMJ. And if you go to the BMJ's website, go online, you'll find that there is much more material there that is relevant to the discussion we've had today. The only one thing that I will say in final summary is that I thought what Michael and others said about the importance going forward of integration of knowledge, of data, of international bodies, whether they be governmental or non-governmental, the more coordination, collaboration, sharing of data and knowledge that can take place, the more the fight against communicable diseases is going to be a winnable fight across the world. So I wish all five of you the very best of luck in doing what you can to keep that coordination and integration going. But from this particular panel, I'll say a final thanks to all of you for watching and leave it at that. Thank you very much indeed.
Hello, I'm Michelle Hussein. Welcome to the first keynote address of Virtual Wish 2020. It's from a man who is the only surgeon for more than 1 million people who live in the war-ravaged Nuba Mountains of South Kordofan in Sudan. He is known to his patients simply as Dr. Tom. And in 20 years in Africa, he has worked through conflicts, faced chronic shortages of equipment and medicine, and battled epidemics. His base is the hospital he helped establish in the mountains 12 years ago, which remains the only major provider of medical care in a vast region. Given his location, what you're about to see has been put together through a series of WhatsApp messages that he sent us when he was able to get a mobile signal. You may find some of it upsetting. It is the story of Dr. Tom and those he cares for.
Hello, my name is Dr. Tom Katina, and I have lived and worked in the Nuba Mountains of Sudan for the past 13 years. More specifically, I'm in a rebel-held territory, which is a population of roughly 1.5 million people and is around the size of Austria. It is a region which has known civil war, starvation, and genocide ever since the founding of the Sudan Republic in 1956. Despite a history marked by severe hardship, things are starting to look up these days. The former regime of Omar al-Bashir has been deposed, the ceasefire is holding, and the rebels have started peace negotiations with the transitional government. The effect of these 60-plus years of neglect are readily obvious. No paved roads, electricity, or running water in the entire rebel-held region. There are primary schools, a few trained teachers, clinics, but only a handful of trained medical personnel. Literacy rates are very low, and most of our patients, including some of our staff, still hold traditional beliefs as to the cause of illness. For instance, wasting illnesses and malnutrition are caused by a malevolent spirit sent by someone with a vendetta against the sick person. When people here fall sick, their initial impulse will take them to the Kujur, who is the local shaman, who will then communicate with the ancestors to find the cause of the sickness. The shaman will then delineate the multiple steps needed to free the person from the illness, and the family will then embark on a series of rituals to please the ancestors with the belief that this will cure their patient.
This is the local treatment. So if a person's sick, what they do in the village, they burn. It looks like cigarette burns, but they get a hot thing and they burn the arm. These are the typical spots, here, 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 sometimes in the back of the neck. These are the typical places they burn. Nara wentani, nahina wa nahina bas. Da bisaida, da ma dawa. Lo ayan teji mustashfa. Okay?
It was in this environment that we opened our hospital in March 2008, initially designed to have 80 beds and offer basic services. At that time, there was not a single high school graduate in the rebel-held area. Our initial staff consisted of 8 expatriates from Kenya and Uganda, and 15 local Nuba staff, with primary 8 being their highest level of education. I was the only doctor. Due to great demand, we quickly expanded to a 435-bed hospital, offering everything from pediatric surgery to chemotherapy for cancer patients.
Let's start the rounds. Very fast today, okay, with a lot of people to see.
Our small expatriate staff work continuously to train our growing on-the-job trained staff. All of the on-the-job training paid off. civil war broke out again in June 2011. At 5 a.m. on June 16th, 2011, all the expatriates, including our only anesthetist, laboratory technician, pharmacist, and midwife, were evacuated. 3 hours later, at 8 a.m. that same morning, a truckload of civilians hit by an aerial bombardment arrived at our doorstep with an assortment of injuries ranging from severed limbs to sharp abdominal trauma.
George, okay, George. All right. Now, hopefully it's not bad, we'll see. So this is a typical case here for the Antonov bomber. His nose is completely missing. It'll heal, you know, to wait for it to heal over, but to try to get the nose back, that's something beyond what I can do. It was just the way the shrapnel was, the way he was. Inte mashi kandak wala win?
Teaching.
Huh?
Teaching.
Teacher.
He was teaching.
He was teaching. As he was getting down, the bomb hit you.
Yeah.
Were the children okay?
All the children are okay.
How many children were there?
75.
75. Was the school destroyed?
Yeah.
I need a light. Have to catch me. Doesn't make any sense. None of that stuff makes any sense. It's all completely pointless. All this stuff is ridiculous. Right. Well.
Our staff didn't miss a beat, and all those patients received excellent care and survived their extensive trauma. Even though our on-the-job trained staff performed heroically, we realized we needed a fully trained staff in all the medical disciplines in order to reach our full potential. We started by sending staff out of NUBA for professional training, and thus far have received back over 20 nurses, 5 midwives, 7 clinical officers, 2 pharmacists, and 1 medical doctor. We have several more nurses and midwives and 2 more medical doctors in training. This has been a tremendous upgrade in our NUBA medical capacity over these past 13 years. But despite these efforts, there remains a huge deficit in medical personnel in NUBA. We now believe that the only way to address that huge shortfall is to open a training school here and train our own nurses, midwives, and clinical officers. We are now in the early planning stages of this school and hope to have it up and running within the next year. Mind you that all of the funds to run the hospital and to start and run this training school come from individual donors and well-wishers. Except for a donation of food, vaccines, and TB drugs, we don't receive anything from the international donor community. However, since we cannot rely on the big donors to support us, we have become rather frugal in our operating expenses. For example, to run our 435-bed hospital and school for a year will cost around $800,000 US, and we feel that we can provide a good number of services at this very low cost. Good healthcare and education do not need to be prohibitively expensive. By way of comparison, a similar sized hospital in my home area in the US would have an annual operating budget 400 times ours. In other words, if we had their budget, we could run our hospital and school for the next 400 years. Another comparison, a US Senate campaign in one of our smaller states to elect 1 senator is $200 million. Perhaps the problem isn't lack of money, but just a gross maldistribution of resources. Life here in NUBA has recently improved due to a cessation of hostilities in the most recent civil war. However, the NUBA are a people deeply traumatized due to centuries of oppression and marginalization at the hands of the Khartoum elite. These people have experienced the humiliation and degradation of slavery in their own lifetimes, and have grown accustomed to being treated as second-class citizens in their own country. They have little hope that they will be treated as the equals of the Northerners, and this feeling has been one of the main reasons for the protracted civil wars.
His leg was blown off and his arm was blown off. So he had to amputate his leg at the hip joint. So he's totally gone. He doesn't have enough left to do a prosthesis. So you can't get a prosthetic leg. The arm is not enough left for a prosthetic arm. So I don't know what to do with the guy.
The Nuba have proven themselves as very tough and fierce warriors, but we fear that war will never bring lasting peace, nor will it bring the respect and dignity that the Nuba deserve as members of the human family. We encourage our staff that the only way to get respect will be by using their intellect and skill to show their detractors that they are the equal of anyone. It is our sincere hope that our initiatives to train our staff will put them on an equal footing with health practitioners anywhere in the world. We are already receiving patients from as far as Khartoum who come to our remote location seeking care. We hope that with our clinical school, we will become a training center for all of Sudan, and both students and patients will come to us seeking care. It is much more difficult to despise someone if he or she is the one performing your surgery or diagnosing your complex medical problem. It is our dream that one of the dividends of a first-rate hospital and training program will be peace in our troubled region. Thank you.
The extraordinary Tom Katena. Thank you, Dr. Tom, and thank you also Kenneth Carlson, the producer of The Heart of Nuba, for providing the footage that accompanied Dr. Tom's words. And that concludes the sessions today in the Al Tabari Theatre. There is more right now, however, in the Ibn Sina Theatre, a masterclass by Henry Timms from the Lincoln Center for the Performing Arts on the topic of new power. Thank you. The first masterclass of this year's Wish is New Power, using our hyper-connected societies to build a healthier world. Henry Timms is president and CEO of New York's Lincoln Center for the Performing Arts. He's won critical acclaim from the worlds of business and academia for his insights on power and influence. His international bestseller, New Power, co-authored with Jeremy Heimans, combines original research with their decades of experience as movement builders and leaders of cutting-edge organizations. Over now to Henry Timms for his masterclass.
Good afternoon, good morning here. It's a great pleasure to be with you. I want to start today by sharing with you 3 stories about how our world is changing. Story number 1, we all have seen around the world the extraordinary impact of the Me Too movement, which begins with the activist Tarana Burke here. But I want us all to think for a moment. Think how the way the Me Too movement used its power is very different than the way people like Harvey Weinstein, who of course was toppled by the Me Too movement, by people like that used their power. So Harvey Weinstein's power was very much top down. He could control a whole industry. He had his hands around a media world. He could completely understand how to shape things, how to shift things, how to move things. There was a survey done at one point which showed that in the last 3 years, the 2 people thanked most from the stages of the Oscars were Harvey Weinstein and God. And think how different that is to the power of the Me Too movement. The Me Too movement is not about one single individual. It's not about the power one person can control. It's about hyper-connected power. It's about the power of movement that spreads and surges all around the world. So as Me Too moves, as Me Too develops, it becomes stronger as different women add their voices. And around the world, it's able to shift and to turn in the moments it needs to. It's the difference between power as a currency, a zero sum, I've got it, you haven't, and power as a current, something that is flowing and moving and surging that you can never truly own, but if you can shape it, you can turn the world in the direction of the outcomes you want. Story number 2, we interviewed a woman who had had seizures her whole life. She had been having these dreadful seizures, and they were so bad that she was worried about her wedding day because she was worried she wouldn't make it through her wedding without having a seizure. And she went to the doctor, and time again, the doctor didn't give her the attention she needed and just kept downloading prescriptions at her, more drugs, more drugs, more drugs. Until, and she was in desperation, she came across, she was Googling, and she came across a website called Patients Like Me. Now, if you don't know Patients Like Me, Patients Like Me is I think now the biggest patient community in the world. So it's almost 900,000 people with 3,000 different conditions. And as you can see here, each of them is sharing collectively their health data. So if you had a liver transplant, you can find other people around the world who did the same thing. You can build these communities of people who aren't just providing sympathy and support, although that's critical, they're also providing data. This has now become one of the many peer-reviewed papers have come out of this community, and it allows patients to have a great deal more agency in their own care. So the lady we spoke to who was worried about her wedding, she went on to Patients Like Me, and she saw a poll which had been done by other patients. And the poll was suggesting there was a certain type of surgery that had been very helpful to people with conditions like hers. She found a new doctor, she had that surgery, and many years have passed since then, and she hasn't had a recurrence. Interestingly, too, she's become an ambassador on Patients Like Me, helping other patients navigate the journey she has taken. Now, think how different that kind of power is from the power of the traditional doctor. So we think about the traditional doctor who has his power on high, who has all the expertise, who famously writes these illegible prescriptions that nobody can read and nobody can decipher, who uses all of these Latin phrases that make their world impenetrable. And think how there is a true clash between a profession who has been taught to think in one model, who are being faced now by generations of people who are expecting to have a bigger say in their own health care. And to go a step further on our topic, think for a moment about the challenges and battles we have coming around vaccination. So if you think if 2020 is the year of the virus, then let us hope that 2021 becomes the year of the vaccine. And think back 12 months, and many of you will know this already, but if you looked at the WHO's 12 months ago, if you looked at their 10 risks they laid out each year, the 10 biggest risks they saw to global health, roll it back a year to 2019, and here were 2 of the 10 risks that they suggested. One was a global pandemic, and another was vaccine hesitancy. Not anti-vaxxers, but vaccine hesitancy, that people would be nervous about taking vaccine in a meaningful way. So think just for a moment about the battle we have coming ahead, not the battle in getting a vaccine. Thankfully, it's looking increasingly likely that will happen, but the big battle coming in getting to people to take the vaccine. And we may have a medical profession who insists that we have experts who have decades of experience, who have white papers and peer-reviewed studies, and they have certifications at the best universities in the world. And for all of that, they are not breaking through. What's actually breaking through, and we are seeing things like measles come back here in New York. The reason that's happening in a large part is because the anti-vaccine movement is so effective. So why is the anti-vaccine movement so effective? What's going on there? And I think one of the really interesting and challenging things we have to recognize is what's going on there is it's actually a very vibrant, engaged community where everyone feels they have a part to play, where everyone has a role, where you're validated, where people are engaged around a cause that you care about. And people all around the world in the anti-vaccine community aren't looking to wait for the Secretary General of anti-vaccine to say what they should do. They're able to come to the world and add their voice on their own terms. So what do these three stories add up to, right? I've just told you three stories, one of a movement like Me Too that topples men like Harvey Weinstein around the world, one of a patient who leaves aside the advice of her doctors and finds 800,000 allies in treating her own health, and one about a battle yet to come, which is a world of medical professionals who have got the vaccine but cannot work out how to get people to vaccinate. And what those battles are about is really what's at the heart of the work I've done with my colleague Jeremy Heimans, which is to think about the difference between old power and new power. So here's our core argument. Our core argument is that the way to think about the world isn't really about technology per se. It's about how the way power is shifting. And especially as we think about health and the medical world, there is a really dramatic shift happening from a world that was built on old power to a world that increasingly has to reckon with the demands of new power. So let's just look through old power for a minute. In the old power world, and this will be very resonant for the medical profession, power was held by few. It tended to download. It was command-driven. It was leader-driven. It was closed up, right? It had a kind of almost military approach in terms of how it thought about power. And what's beginning to challenge that is the new power world, where power is not held by few but made by many, where it's not about what you download but what you upload, where it's not about the single genius doctor whose great insight changes the world, but about groups of peers who can look to outcomes together. And it's the difference between old power and new power, the difference between power as a currency, I've got it and you haven't, and power as a current that flows and surges around the world. Let me take half a step out of the medical world for a moment just to strengthen my argument. If you look at almost anything around the world now where you are seeing success, it is almost always now driven by some degree of new power. So let me give you some examples. Think about the unexpected successes of Barack Obama or Donald Trump. Very different politicians. Both came to power working out smart ways to generate the power of the crowd around their unexpected campaigns. Think too, from a new power perspective, think about the movements which have defined our times. Me Too, Black Lives Matter, March for Our Lives, Extinction Rebellion, these big social movements which have surged, the Arab Spring, these big social movements which have surged are very much driven by new power phenomenon. And think too about the biggest businesses of our times, the Facebooks, the Ubers, the Alibabas. They too are driven by the idea of new power. But wait just a moment. Here's another way of thinking about the same thing. If you know this game, this was the biggest game of the 20th century. The game is Tetris. I'm sure some of you will have wasted hours of your life playing it. So Tetris, the biggest game of the 20th century, as a game that really reflects the old power world, right? Somebody else set the rules. It was a top-down game. It was a single-player game. Your only job in this game was order, to make things fit into neat lines again and again and again, until eventually you collapsed under the weight of the game. I've certainly showed this slide to many in the healthcare profession, and they found that idea resonant. And think how different that is to this world. So this is the most popular game of the 21st century. Interestingly, like Tetris, it's a block-based game. But it's Minecraft. The game is called Minecraft, and the rules of the game are very different. This is a hospital which has been built in Minecraft, and Minecraft works. It's built from the bottom up. It's a collaborative game. It's a game without rules. The entire game is people coming together to decide to build things in ways that are on their terms. And just think for a moment about a generation of people who are not living in a world where the world and our institutions operated like Tetris, these top-down institutions where we had limited roles to play. But we have this generation of people now who are expecting to play bigger roles, who expect to shape the world in their own image. So as we started to think about this, we tried to sketch out two mindsets, which I hope can help you kind of navigate some of the challenges you're facing. One mindset is kind of the old power mindset. The other is the new power mindset. So in the old power mindset, this is a way of thinking about the world that biases certain things. It believes in managerialism. It believes a lot in confidentiality. It believes in expertise and long-term affiliation, right? So it had this real sense of the institutions, the experts had all the power. Individuals played very limited roles in very rhythmic ways over long periods of time. I'll give you an example. There's a project called Open Notes, which was a campaign to open up people's health notes so as they could see them alongside their doctors, right? You would think that would be a pretty basic request, but of course it was resisted and continues to be resisted by many doctors. And one of the fears that people had about that was actually that sense of expertise was being attacked, right? That the idea that they had all the power and all the information by opening it up, that confidentiality the old power world rested on, was being attacked. And think how different that is to the new power world. So in the new power world, people expect different things of individuals, of leaders, and of institutions. So in the new power world, people believe in things like collaboration, like crowd wisdom, like transparency, like this kind of do-it-yourself ethic where people do their own things. So think for a moment about the network Patients Like Me I talked about a moment ago. That network, that community succeeds because it's based on collaboration, it's based on transparency. People are sharing their own health data with strangers to add to the centralized pot. And it's much more governed in an informal and more self-organized kind of a way. But I want to stop right now and just underline something which is so important to the argument I want to make to you today, which is this. The argument is not old power is bad and new power is good. Right. There are many things in the old power world that could not be more critical. I'll give you an example of my own health history. I had, just before we were going to go on our book tour around the world for the book, about 2 months before that happened, I had an appendectomy. I can promise you the last thing in the world I would ever want is a new power appendectomy. I do not want my appendix taken out by a group of amateur crowd members who collaborate with some tools they've found on the internet to take out my appendix. What you want is someone with 20 years experience who has done this hundreds of times before. Now, that's obviously a light-hearted example, but let's just go back for 1 second to the point I just made about vaccines. And think for a moment about how important it is that the experts of our world are heard. Think how important it is that science and reason win out in the years ahead, and think how unlikely that is unless our old power experts learn to enter the world in new power ways and learn to shape their expertise in ways that take the crowd along with them. So as you think about all of these things, one thing we wanted to kind of frame, we first started writing about this in Harvard Business Review. And one thing we wanted to frame here was how you could start thinking about your own organizations, the organizations you work for, from an old and new power perspective. So I wanted to give you a couple of lenses to that, to be a tool, I hope, to start thinking about the organization you work with and what changes you need to make. So we're tracking two things here. One, on the vertical axis, is the model. Do you have an old power model or a new power model? So an old power model is, you like Tetris, you drop things down and people consume them. In a new power world, you're creating this kind of participatory world. And do you have old power values or new power values? Are your values very much kind of confidentiality and closed up and expertise? Or do you have values that foster the crowd and radical transparency and greater collaboration? So each one of these quadrants, I think, offers some interesting strategic questions. So let's start at the bottom left, which is what we call the castles, where old power
meets old power, right? So this is, let's take a good example, the Nobel Prize. Small group of experts behind closed doors decide who the world's greatest physicist is and hand out their prize. It's as old power as it gets. And a lot of the medical world is living in the old power in the castle section, right? A lot of the medical health community has grown up in the old power model and will need to work hard to shift out of this quadrant. But I'd also note that a company like Apple, of course, hugely successful, is still an old power company, right? It doesn't, just because you're new technology does not mean you're new power. So Apple is actually famously not very collaborative. They're very closed up as a platform. They're very closed up as a company. The way they engage with the world is actually very much about not being particularly open and collaborative, and they've been very successful. Of course, not everyone can be Apple. The bottom right-hand quadrant is the cheerleaders, where you have an old power model but new power values. So your model is pretty much the same, but you're beginning to build these values around the product. So let's take a good example here. Patagonia is a clothes company, right? They sell clothes, but they're starting to treat their consumers more like citizens. They're doing a lot of activism. They're being very open and radical about their own supply chain. They're trying to persuade people that you are more than simply a consumer. You are part of a larger movement. And I think that challenge is one that we all face now. At the top right, we see the crowds where new power meets new power. So you're seeing things like an Airbnb or a Wikipedia. You're seeing these social movements like a Black Lives Matter. And what you're seeing here is when you have an alignment between new power models and new power values, and they fit together in a similar way. And then finally, the top left is what we call the co-opters. And this is where you have an old power, a new power model, but old power values. So think about Facebook for a moment. Facebook is the best new power machine we've ever seen, right? Billions of people exist and participate on Facebook with their own ideas. However, the values of Facebook are very closed up, right? The governance is very centralized. The algorithm is very opaque. The value itself is centralized, not decentralized. So one of the really interesting questions for organizations in this quadrant is how much dissonance there is between your model and your values. So as you think about this 2x2, I encourage you to take it back to your workplace and think about your own organization. Where are you today, sitting on here? Where are you sitting? And then question number 2, where do you want to get to in the next 5 years, right? How are you going to make the shift from wherever you start and wherever you need to finish? And I'll make a prediction. My prediction is this. I suspect that over 95% of the people tuning in today, wherever you happen to be now, in 5 years' time, you're going to want to be in a different quadrant, right? Because I think what we're all recognizing is these trends that even 5 years ago could seem a bit peripheral are actually going to be fundamental to how we are all successful in the years ahead. I wanted to lead now to give you an example from a world that I think is similar to the medical world about why and how these trends can get hold up, right? So if you buy my argument that we're all going to need to get a little bit more new power, then how is it you think about making that shift and what can we learn? And so I want to take you into an organization that we know well, of course, which is NASA. So if you think about NASA as an organization, they are perhaps the best example of a great technology organization that's pretty old power, right? So obviously they're a terrific technology company. These are literally rocket scientists, but they're an organization that had been very top down, very siloed, and there had been a lot of critique at NASA that they weren't being innovative enough. I'm sure many of your own organizations will have heard that critique, right? Not enough innovation happening. So they tried an experiment. And their experiment was a new power experiment. It was with something called open innovation, which is huge in the healthcare sector. So open innovation, for those who don't know it, is the idea that you invite the crowd to help solve your problems with you. So you engage the crowd to help solve your problems. So a group of scientists at NASA, they laid out a dozen of their most significant challenges, and they invited the public to help solve the challenges they have. So this is ordinary members of the public alongside the greatest scientists in the world working out how to solve some of their problems. And what was interesting was how many responses they got, how quick the responses came, and how good the responses were. They were really surprised by the quality and quantity of the ideas that came in. And one particular solution stood out. There was a problem in heliophysics, around sunstorms. This is a sunstorm. If you're flying through space, you want to avoid sunstorms. And the best algorithm that NASA had, could predict them about an hour or two before, and they got it right about half the time. The algorithm which came in from a normal citizen could predict them 8 hours beforehand and got it right 75% of the time. So the solution which came from the outside world was even better, much better, in fact, than the solution that had come from inside the great minds at NASA. So what happened, right? What happened was they had this amazing moment and people got very excited about what might be possible in this new world, but things went wrong. For all of the excitement around open innovation, something unexpected happened, is that there was a real tension between those people who were championing this new way of doing business and those people who were holding on to an old way of doing business. And that difference is one that the academic Hila Lifshitz-Asaf, who studied this work at NYU, and she was inside NASA for 3 years doing this work. When she looked at all this, what she realized that there was a real difference between mindsets, right? The people who resisted open innovation versus the people who embraced it wasn't because some were older and some were younger. It wasn't because some were better scientists or some were worse scientists. It was simply because they saw the world differently. And she lays out these two characters, the problem solvers and the solution seekers. So for the problem solvers, the way they saw the world was, look, experts are always the answer. They had a great belief in organizational process, and they had a great belief in high control. Whenever she would interview any of these scientists, she would ask them about open innovation. And as soon as she started asking them about open innovation, they'd immediately respond by talking about how many degrees they had or their professorship at MIT. And she noted the fact that she'd never asked them about their qualifications, but their immediate reaction to this idea of all this unexpected amateur existence coming in was to defend their territory. And it's very different than the group of people she called the solution seekers, who actually changed their jobs, created new departments, created new ways of working to get value from the crowd. And what they believed in was that anyone could be the answer. They believed in a much more distributed process. They believed in much lower control. And the difference between these two groups really was crystallized for Hila in a moment that she oversaw when one of the chief scientists was arguing with the others. And she was saying to them, you have to stop thinking the lab is my world and start thinking the world is lab. And in a way, it seems to me that's a perfect way to think about the mindset shift we need to think about inside the health and medical profession. I want to add one last note on this, which is when people see this, and there'll be those watching now who will be resistant to this idea, we must not cast this as one of two options, right? You can either have complete control or you can have complete anarchy, right? That is a false binary. The interesting space for us to explore is the middle, right? Which is how can we create meaningful ways that create participation that actually do capture value, right? That isn't as easy as just opening up the gates and assuming the right answer is going to arrive. There is a true science to the middle. There is a great science and a great skill for those people who are able to work out how to take advantage of this huge appetite for participation and turn that into meaningful and empirical results. And in fact, that whole category of science in the years ahead is one I think we expect to be very meaningful and could be greatly impactful. Okay, so I want to talk now for a moment about some implications of all this for the wider world. Right, what does this mean for all of you? And I want to kind of finish my talk and then get into the new power section of this is, of course, is to answer your questions. But let me give you, I think, three implications for what I think this means for all of us and for the medical profession, the health profession. The first is this, that we in general now are very much challenged by a reality of the new power world, that intensity is greater than favorability. Now, what do I mean by that? What I mean by that is that for a long time, everyone wanted to kind of have as many customers as they could, as many voters as they could, as many friends as they could. And that logic lasted for a long time. But increasingly today, if you want to stand out, and this will certainly be true of the vaccination campaign which is coming, how do you create not just favorability, everyone thinks it's a good idea, but intensity? How do you really make people think this is important right now and they have a part to play? What so often good institutions fail to do well is give people a meaningful role to play, invite people to play a part in shifting outcomes. And as we think, to give you a frame for that, as we think about the vaccination challenge coming, the idea which is we're just going to tell people they have to vaccinate, we all know that's not going to work. So here's the question. How do we get people to be ambassadors of vaccines? How do we get the networks that we all have more enthusiastic and more meaningful in terms of building intensity around this cause? Number two, the most effective actors blend old power and new power, right? So this is, again, I've said this twice, but it's so important that I land this message. It particularly as we think about healthcare, old power matters enormously. The capacity of expertise and wisdom and experience and science and data could not be more important. But the reason those things are under siege is because they are not doing enough with truth alone. It used to be the case that we could say, truth would win the day, but truth today is on the back foot because it's so much easier to mobilize and to encourage people around falsehoods. So the great institutions of our world need to work out how they can blend old power and new power together. And then finally, and I think most importantly, the way to think about the future is it's a battle for mobilization, right? Who mobilizes best is going to win. And whether that's in politics, the people who can mobilize the most people to fight for their campaigns, to fight for their policies, whether it's in business, right? The companies who can make people feel not that they're just buying products, but they're part of a bigger movement, a bigger idea, a bigger world. And of course, in the healthcare profession, the fact we have all of these people out there, if we can work out some ways to meaningfully engage people in their own health, the health of their communities and the health of our world, that is a huge opportunity. And I do think we've done a lot of work around different sectors. I do think that from the start of this work, the thing we've been most optimistic about is the capacities as we think about health and new power. Because there are a couple of things which we really have in our favor. The first is that there is a true collegiality and community around healthcare, right? You look at people who get sick and you all know that one thing they often feel is alone, right? The isolation compounds the illness. So there's a real opportunity to build support and evidence and science around health outcomes in a very meaningful way. And that's very good from a mobilization perspective. And the second thing is, on a good day, health is not zero sum, right? We all win when health outcomes can improve. And so one of the things I think we have coming is the things that can work in one city can work everywhere. So the global collaboration that we so often actually don't see in fields like health, the global collaboration that is increasingly looking like the only way we are going to be able to deal with things like the pandemic, working out ways for that to become a standard in healthcare so that the silos are broken up and we are open sourcing much more of our work, I think will be a very meaningful way. So with all that said, I want to, in a new power way, give you my email address and my Twitter handle, so you have that in case you want to get in touch. And then I'm going to stop sharing my screen. And I have now been sent by WhatsApp some questions, which I'm going to answer. So question number one, and I'll go through these in order so as to be a good, transparent new power leader. Your book is successful and what you say makes sense. That's a very good start. Thank you. But are the right people, those who have new power, listening? No. The right people, I think, are not listening. So I think one of the real challenges we have is that people, particularly people in the old power world, are resistant to these kinds of changes. Even some of the good ones kind of say, oh, this sounds great. It's a good idea. I like the idea of new power, but actually don't make structural changes in their organizations. So the biggest hope I think that we have when we think about new power, the biggest hope we have is how do we get organizations not simply to say the right thing, but also to shift their structures? So how do you get organizations to start meaningfully changing the way power dynamics work so that you lead to better outcomes? And so I'll give you an example of that. In the UK, there is a group in the National Health Service, which I think is the biggest health service in the world, called the School for Healthcare Radicals. And it's a group that's been set up internally inside the NHS, essentially to foster new power outcomes. What they're trying to do is work out ways of making the world more new power in meaningful ways. And it's essentially like a laboratory inside the NHS to take good ideas and then scale them across the system. So I'll give you an example. There was a New Power campaign called End PJ Paralysis. And PJs, I don't know whether PJs is what you wear when you're in bed in hospital, right? So your pajamas. And as you know, as many of you will know, one of the dangers of people long-term stays in hospital is people get bed sores and don't get up enough, and that has all sorts of negative outcomes. So the idea of ending PJ paralysis, the idea was a hashtag campaign. The idea was to get people all around the country coming together to find innovative and creative ways to get people up and about more. And what was so interesting is that campaign was not led in a centralized way, but actually was a decentralized campaign. And people all around the country, in fact, people all around the world have now taken part in ending PJ paralysis. And the reason that campaign works so well is because it gives everyone a role to play, right? So the different hospitals could all work out their own ways of how they can impact PJ paralysis. And so there was one who set up a radio station led by the patients to think about how they could do that. There was another who did a race, I think. They did a race with walkers of the various patients to get them out of bed. And it became this really sort of fun and creative and dynamic campaign that encouraged people to do things in new ways. And I think that's something else we've learned from the New Power world, is that too often the outcomes are not rewarding and not enjoyable, right? We just tell people they have to do the right things, eat your vegetables, don't smoke cigarettes, run 3 times a week. Those kinds of prescriptions, they don't really give people a chance to feel validated, to feel successful. And for right or wrong, more and more people are being motivated by the idea they're being validated by different groups. So for New Power leaders, I think in particular, one of the reasons we wrote this book was to engage with communities just like this one, and to think about the people in your world who ought to be thinking more about New Power, but aren't, and how we can help support them. And actually, one thing we've seen working very well time and time again is people inside organizations, especially people who are kind of middle management, middle to senior management, who get interested in this kind of work and start to lobby their own bosses around how they can start to think about New Power more. Because I think once people recognize the ways in which you can start to shift organizations, they can get very excited about how New Power works. All right, my next question. Question number 2, where does fake news fit into my New Power model? And how can the likes of the WHO use New Power to get an accurate, healthy message out? Really great question. So fake news, if you cast your mind back, even when I was growing up, so I grew up in England 30 years ago. And when I was a teenager, if I wanted to participate in the world, I had very limited options, right? There were 3 television stations. There were 4 newspapers. I guess I could try and write a letter to the newspaper, or I could try and call up my local radio station and see if I could go on a phone in. But I actually had very limited means of engaging with the world. And the news, as was then, was controlled by a very small number of people, right? The news was the BBC and then independent television at that time. And then, the radio stations you could get to really controlled the news. Now, that didn't mean there weren't fake things in the world, right? So fake news is not a new idea. There are plenty of governments for decades, for centuries, who have controlled enough of the media to control the news narrative and say things that are completely false. But there is something new today that wasn't true when I was a teenager. And that every teenager today, all of us today, have the capacity to share and disseminate information in ways we previously didn't, right? So all I could do previously when I was a teenager, talk to my friends, maybe write a letter to the local radio station. All of you now have communities online that you can meaningfully influence. All of you now can actually shift the thinking of people close to you. Many of the people tuning into this will be very significant people in your worlds, and people listen to what you say in a way that was just completely untrue even 20 years ago, even 10 years ago. So one of the dangers with that is that we all can start to share things that are not the most reasonable or the most engaged, right? Fake news is often something we all get drawn into, right? We all just share something because it seems like it's provocative or it's outrageous or we're upset about it. And we don't take the time to think, okay, is this true? Is this not true? Is this something I should be sharing or not be sharing? And so I think one of the ways to think about fake news is, A, all of us have a responsibility to think about what we share. Here's an idea which might resonate with this group. What is the Hippocratic oath for social media for all of us? What is it we should be promising not to do and do no harm would be a good place to start. But secondly, recognizing the power of the medical and the health profession, how is it we can start propagating true news, right? What is our responsibility now to start sharing interesting and meaningful information in ways that do resonate? So the organization Purpose, Jeremy, my co-author, runs it, and I'm a senior advisor there. We're doing a campaign right now working with doctors and scientists around the world around vaccination. And that campaign is not getting them to appear on, TV adverts saying, "Hi, I'm Dr. James and take your vaccine." It's using platforms like TikTok and using platforms like Instagram to create very compelling content which shares reason and truth and evidence-based science in a way that engages people at scale. So I think one of the ways of thinking about fake news is not to focus on the fake news, although we should, but to focus on how we as a group of people working on similar causes can start to better propagate true news. Next question, can old power evolve to become new power? And what advice do you have for people breaking out of the old power model? It's a great question. And the answer is yes. Yes, but it's very hard. So old power models tend to be pretty sticky, and it's hard for them to shift until it's such crisis that it's almost too late. But we've seen some things work very well. One of the most effective things we've seen working is thinking about who the people in your organization are who represent new power. Now, the danger is what often happens with organizations is they hire someone who's like 24 years old, who understands all of the new digital things and comes in and makes everyone feel like a dinosaur. And it's like the disruptor who comes in and says, "This is no good, we have to do it differently, you people all should be put out to pasture." And that archetype is very rarely successful, right? The more successful archetype inside old power organizations is a figure we call the shapeshifter. And a shapeshifter is someone who has a lot of old power credibility, but actually starts to shift the organization in a new power way. So to go back to that NASA story I told you earlier, one of the reasons new power got strong at NASA was because some of the most respected scientists there became champions of new power. No one was going to be able to persuade anybody that they were not taking the science seriously or that they weren't respected, but they used their old power to strengthen new power. And I think particularly as you think about the healthcare world, that's a very good frame to think about that question. Next question, how does Biden's win affect the balance of power? Will his presidency actually mark a return to old power values, or is he tuned in to the success of new power? Really interesting question. So I think one of the concerns I think I certainly had about the Biden campaign was ended up being well-founded, which is, did it have enough intensity? Right, for all of the polling, which was saying this was going to be a landslide, had Biden actually managed to drive up enough of the grassroots enthusiasm around his agenda to turn it into the kind of victory many anticipated? And of course he didn't. And I think one of the great dangers actually for the Biden administration is that it will become a return to a set of norms that are very important for democracy around respect for institutions, around traditions, and around engagement. But if new power is left on the sideline, if that doesn't actually come with a concerted effort to find ways to offer people bigger roles to play, I think that plays into the hands of the Republican Party, who will be ready, anticipating 2024, to resurge back in with a greater level of participation. So the closing argument I left you with earlier, that the future is a battle for mobilization, I think that's particularly true of politics. And I think it's something that the Biden administration, I hope, will make a great priority. And the cautionary tale for them, of course, is the Obama administration. So one of the great triumphs of the Obama administration was the way that he used new power to get into office. But he didn't use new power much when he was in office. He used it to campaign, but not to govern. And so at the end of 8 years, Barack Obama was hugely personally popular, of course, but he handed the keys to Donald Trump because he hadn't managed to actually mobilize his constituency as a governing function. And I think that's one of the big challenges for governments and governors all around the world. Next question, my favorite example of a business practicing new power. I can give you an answer to that, although the health professional may not have this. It's a brewery. It's a brewery in England called Brewdog, and they set up essentially a new power beer company. And the way that Brewdogs works is they had equity. They had equity for their crowd, so the people who supported them, their drinkers, became equity sharers in their product. They had these amazing big annual conferences that were more like rock concerts and conventions than they were annual general shareholders meetings. And they've done a lot of really meaningful work to start to transform the governance functions of a company to make it more participatory and to make people more engaged in their product beyond simply buying a beer. And of course, it's actually a very good pint of beer as well. So I think that BrewDog would be my example. But just to flag a trend that I think BrewDog was ahead of, what I think you're increasingly going to start seeing is individuals and organizations finding ways to give their consumers bigger stakes in their product. So if you look at the company KKR right now, the investment company, a lot of the deals they're doing now with corporations, they're doing something very interesting, which is they are giving the workers of companies a real stake in their success. So you're not just getting your hourly wage, you're also getting a meaningful equity stake in the organization. And I think those companies who work out ways how to truly make people feel like they are owners of the organization, both in actual terms and in metaphorical terms, that ownership stake is going to be one of the superpowers for businesses going ahead. And truthfully, I think also for medical professionals going ahead. You know, you all know this data, but if we can increase patient activation by, you know, tenths of a percentage point, right? If we can do that kind of work, it has a huge impact in terms of outcomes of all sorts of medical interventions. We spend so much time on the things which are prescribed, but if we could add to prescription mobilization, if that was the 1-2 punch of healthcare, that could be very, very meaningful. I have 2 minutes left, so I'm going to answer 2 more questions. Can the new power, I just touched on this, how can the new power model help improve patient outcomes and reduce medical errors? So I think that the new power, the patient outcomes is to give the patients themselves more to do. I think there's no question of that, which is the part of the way that we ought to be even thinking about how we train people as they become health professionals, is they ought to be trained in new power. They ought to be trained in working out the best ways to meaningfully mobilize people around their health, because if we could do that, we could lead to some huge outcomes. And then finally, thank you for a most practical presentation. My pleasure. How does one change the closed shop and cartel mentality of medical regulatory bodies globally by encouraging the new power ethos? Look, that's a terrific question, and there'll be people on this call who have much better answers than I do. But I do think it's the right place to end, which is to remember that for all of the power of new power, if we don't change the superstructures to allow this kind of work, it's very hard to break through. So particularly as we think about the way that regulation works and the importance of regulation, I think the same question remains, which is how do we redesign regulation so we lead to good health and scientific outcomes, but we open up the gate for much more participation. And we mustn't let people fake us with the idea that it's one or the other. It's either control or chaos, because the future for all of this work, I think, is in that middle space where we find ways of making sure that the great superpower of our age, which is participation, to make sure that is pushing us all in the right direction. I'm really grateful for the opportunity to engage with all of you today. I wish you luck in your critical work, and thank you for the invitation.
Hello, everyone, and welcome to the second In Focus session of this day of WISH conferencing. For those of you who have just joined us, these In Focus sessions are special sessions delivered in collaboration with our partners on important healthcare issues being faced across the world today. Now, our first one earlier today focused on the idea of localization and empowerment of local communities to drive change and reform healthcare systems. And if you're interested to watch back that session, see a link to the recorded session. It is now available on the WISH website. But let us turn our focus to this session. I'm proud to say it is being presented in collaboration with the Carter Center in the United States, and it's titled Pathways to Disease Eradication, Lessons Learned. And today we hope to shed light on and celebrate, really celebrate, the 40th anniversary of the eradication of smallpox, alongside the global health experts who led that very campaign, which of course resulted in the eradication of smallpox. And of course, experts now working to replicate this success against guinea worm and other devastating afflictions. So this is a crucially important debate. The lessons to be learned are so very important, and I'm delighted to say that to tease out some of the lessons and look forward as well, we have three wonderful guests. So in short order, let me invite you to meet them. And gentlemen, we can see you on our screens. I wish we could all be together in the flesh, but of course this year things are different, so we've got you on screens. So when I introduce you, if you could just give a wave so everybody across the world watching this knows exactly who is who. So Donald, let me start with you. Dr. Donald Hopkins. Now, he brings vast experience to this discussion. He directed the smallpox eradication program in Sierra Leone, get this, back in the late 1960s. He was acting director of the Center for Disease Control in the mid-80s, and he has long been at the center of the Carter Center's efforts to eradicate guinea worm disease and river blindness. So, Donald, a very warm welcome to you. On the top screen alongside Donald is Adam Weiss. Now, Adam has had very long experience in the field, mostly in Ghana and Ethiopia, but across different countries, combating guinea worm. And he is now the director of the Guinea Worm Eradication Program at the Carter Center. And then on the bottom screen, we have another giant of this worldwide effort to eradicate disease. He is Dr. William Fagey. Now, he is Senior Fellow Health Policy at the Carter Center. He is an epidemiologist. He's got a long record of achievement. He was chief of the smallpox eradication program at the Centers for Disease Control. He was director of the CDC. He became executive director of the Carter Center. And the list goes on. I'm trying to read the rest of this. He served as medical advisor to Bill and Melinda Gates for several years. He is also professor of international health at the Rollins School of Public Health at Emory University. So we have got fabulous experience on this panel. We want to learn the lessons of what happened in the triumphant battle to eradicate smallpox, and we want to look forward. We're obviously going to have to reflect on the realities of COVID-19 a little bit, but also on the other diseases which have the potential to be eradicated. Let us start, though, for those who are not absolutely familiar with the different terms here when it comes to combating disease. Don, I want you to start by telling me what exactly eradication involves and how big a challenge it is to get all the way to eradication of a disease.
Eradication means ending a disease worldwide. So the disease no longer exists anywhere on the planet, and the control measures, therefore, don't need to be applied at all any longer. When you get down to the last few cases, however, it gets to be increasingly difficult, as I like to say, because the last cases are always self-selected, almost by definition, in the most difficult areas to work. And so it gets increasingly difficult as you approach zero, and proportionately also more expensive.
So the hardest yards of all are those final yards. When you, as you just said, when you're down to the final few cases, what has to be different in the nature of the campaign, the eradication campaign, when you reach that final stage? How does it have to be adapted to move from almost eradication to complete eradication?
It requires intense focus, because when you think of it, as you get down closer and closer to zero, the stakes grow proportionately much greater, so that when you have several hundred or even thousands of cases, missing one case is less important than when you get down to, say, 5 or 6 cases. In that instance, when you miss one case, you make your problem much greater. And in the case of guinea worm disease, missing one case means that you won't know whether that case has propagated until a year in the future. Moreover, you won't know where it might have affected other people as well. So as an additional problem at the very end is that often political leaders become anxious to turn their attention and funding elsewhere as cases get fewer. And so almost paradoxically, the importance of maintaining political support for the program also becomes increasingly difficult often as you approach zero.
That is a very interesting point. And at the beginning of this session, and I should say, by the way, I maybe should have said it earlier, that this session is all about interactivity, as all of our sessions at WISH try to be. So as we listen to the great expertise on our panel today, I do want you, all of you watching, to be thinking of questions, observations you might have if you work in this field, or you have any connection to this field, or if you're just like me, an interested layman. Do put forward a question on the WISH platform, and after 30 minutes or so of conversation, I'm going to make sure that I get your questions put to these three gentlemen. So please do use the WISH platform for that. But now I want to turn from you, Don, to William, or Bill. I think most people call you Bill, so I'm going to take the risk and do that too, Bill. Again, on this question of learning the lessons of smallpox, what was, it is, as I understand it, the only disease in the world that has ever been truly eradicated. So what made the effort to wipe out smallpox throughout the world successful, and why has it not been replicated in the fight against other diseases?
It is the first human disease to have been eradicated. There's one animal disease, rinderpest, in cattle that has also been eradicated. I became interested in smallpox eradication 55 years ago. And as you mentioned, we've now gone over 40 years without a case of smallpox any place in the world. And people wonder, why was smallpox selected for eradication? Well, there were a number of reasons. It was a very ugly disease. Voltaire got smallpox and began studying it. He came to the conclusion that 60% of children in Europe at that time would have smallpox sometime during their life. And he said of the 60%, 20% would die, 20% would be scarred for life, and only 20% would get through this scot-free. So it was a bad disease. And it continued, even though Edward Jenner in 1796 showed you could prevent it by giving cowpox to people, it continued, so that in the 20th century, there were still 300 million deaths in the world. But yet a third reason, I think, for selecting this disease is we borrow so much from our grandchildren. We leave them with debts that they will have to pay off. Disease eradication is one situation where we actually do something for our grandchildren so that they never have to be bothered by this problem again. So what are some of the big lessons? Well, number one is to trust the science. Science is not always certain, but it's as close as we get to certainty. And so science is not always correct. It's not the gold standard in the sense of always being right, but it is a pathway to finding truth. So number two is know the truth. You can't actually get rid of a disease unless you know what is causing it, who's getting it, what you could do to interrupt that. Knowing the truth turns out to be absolutely essential. And that's why we have surveillance systems, to get denominators and numerators, know who's having the problem. The third thing is you need to form coalitions. It requires lots of people and lots of groups. With smallpox, you start with WHO and over 190 ministries of health. You look at all of the countries that were involved in producing products, vaccines, contributing people. You look at the countries with smallpox, and their health departments were involved, their schools were involved, and hundreds of thousands of people involved on the ground, actually finding cases, finding contacts, vaccinating, doing a million different tasks. So it required a coalition. The last lesson I'll mention, there are many of them, the last one I'll mention is we found out again that the best decisions, the best policies are based on best science, but the best results are based on the best management. And so the question is how to bring the science and management together. It's often been said that an ounce of prevention is worth a pound of cure, and that's true. But as someone has said, it's a ton of work. And it was a ton of work, but everyone is so pleased that we actually did the job and now have gone over 40 years without a single case any place in the world.
Well, I think that idea that we as a species are so pleased is, if anything, an understatement, because if we think about the impact COVID is having on the human population around the world today, imagine how much worse it would be if smallpox was still rife, a disease that is so much more damaging to people than COVID, albeit COVID has caused tragically so many deaths, but smallpox so many degrees worse. What you two have said about the disease and about your recollections. Sorry, were you going to say something, Bill? Go on.
I was just going to say that with smallpox, it's so important that we seize the moment, because once HIV came on the scene, we would have had a great deal of difficulty doing smallpox eradication because of the immune system and the complications with HIV and vaccine. So you have to seize the moment.
Right. Right. Well, that thought then I'm going to put to Adam, because Adam, you're sitting alongside, albeit on a screen, you're sitting alongside two of the greats of the fight against smallpox. You, of course, are dedicated to the fight against guinea worm. And, you know, I think people have told me there are basically about 8 diseases around the world which have the potential, should we invest right and do the right things over the next several years, have the potential to be eradicated. And clearly, guinea worm is one of them. So you tell me, as you listen to these two with their great experience, does it give you confidence that you have the tools, that the international community is giving you and others the resources to complete another a successful eradication program?
Without a shadow of doubt, eradication of guinea worm is within hand, and it's in great dedication of Drs. Faggy and Hopkins for laying the pathway for that to even be possible. Not only did they lay the framework for eradicating guinea worm for the entire world to pursue, but also in building coalitions like the International Task Force for Disease Eradication that actually deliberates the science, the management, and all of the component parts that are required to pursue something as kind of paramount as eradication is. And the guinea worm eradication program, like polio has faced setbacks. And oftentimes we talk about how difficult the last mile is, and in our case, globally, thinking about the last kilometer. It's not an easy fight when you get to the tail end of it. But what it requires is a continued investment in innovating, not only from the top down and thinking about what technology can provide, but also in innovating from the bottom up. And I think you had a session earlier on the importance of community engagement and community involvement, and what Drs. Faggi and Hopkins really built into the design of the guinea worm eradication program was to maintain a constant feedback loop with communities. And so it's not being driven only top down. Of course, you need the political will that Dr. Hopkins mentioned earlier, but you also need the buy-in from communities, from local leadership. And that's really where the last kilometer or the last mile is going to be won, by making sure that they're engaged and involved every step of the way.
Well, that's a great point, and I'm mindful that as we live in this era of COVID, and when public trust in the science is such a real issue in all parts of the world, developed world, developing world, there are many skeptics out there when they are confronted with the science, whether it be the nature of the disease or the discussion of a vaccine or whatever. There is a lot of skepticism out there. So, Don Hopkins, let me come back to you. You did a lot of work in Sierra Leone on smallpox. So just give us some more sense of how, as Adam says, you have to engage with local communities. What are the key elements to successful engagement? How did you make it work, and how, going forward, whether it be with guinea worm or efforts to eradicate other diseases, what do we need to put as our priorities in terms of this bottom-up engagement?
An important element of the smallpox program was that the disease itself was horrible. It was horrible to look at. It was frightening. And in Sierra Leone, when I went there, Sierra Leone was reporting more cases of smallpox per capita to the World Health Organization than any other country on Earth. And so people in the country knew what this disease was, they feared it, and therefore they were very receptive to the idea of making themselves available to be immunized. And in that instance, we didn't have to persuade people to accept this help. However, we did have to still approach people with respect, which was very important. Explain to them that we understand this disease is terrible, that there is this vaccine that's available to help protect them and their families from it, that there were no side effects specifically to worry about with this vaccine, and help them understand that we, the people from the health department, were there to help them take care of their problem in their community. We then, in working with the leaders of the community, got the communities to agree, when we were using mass vaccination, to agree on the time and place when the communities would get together, assemble themselves for the mass vaccination program, the mass vaccination teams to come and immunize them. And then as individual communities experience this mass vaccination, experience being vaccinated, seeing that there were not terrible effects from the vaccine, and realizing that they were now immune, other communities becoming aware of that were more and more receptive to the idea of receiving this vaccine as soon as possible. In the case of guinea worm disease, in contrast, you have a problem which people also fear, which is also very, very visible, but it is much more difficult to get people to understand that they are getting this disease by actions taken a year before in drinking contaminated water. And so the challenge there, again, approach the community with respect, explain to them what's happening in a way that they can understand it, and then, having gained their trust, teach them the interventions that are available, let them see and hear testimony from other communities so that they then begin to trust people from the health department and implement the measures. But unlike a simple vaccine, in the case of intervening against guinea worm disease, we're encouraging communities to do things which must be sustained over a period of time. And so that is another element of difficulty in the case of guinea worm prevention that did not apply for smallpox.
Right. Adam, let me ask you a pretty blunt question of economics. I mean, you're still totally engaged in the eradication effort for guinea worm, working in I think, a very small number of countries now in Africa. Now, you still need the support of the international community in terms of serious financial backing. I guess you still need, you and others involved in the effort, you need tens of millions, maybe hundreds of millions of dollars, I don't know. But right now, we're in a world where, frankly, public attention right across the world is much more focused on what is perceived to be the mass threat of ill health due to COVID-19. How can you persuade political leaders, leaders of the biggest international, NGOs committed to global health, how can you persuade them to continue giving you significant financial backing when, frankly, there are only a few hundred cases left of guinea worm in the whole world at a time when they might think, you know what, the dollars that I could give to Adam would be much better spent adding to the international effort on COVID or on a host of other diseases, maybe malaria. Why does your effort still justify significant expense?
Well, I think some of the greats in public health that are with us here today, Drs. Foege and Hopkins, have said many times, it's not an investment in one thing or the other. That in fact, the investments that are made into the guinea worm eradication program have not only immediate term impact on other diseases, but also long-term impacts on the human resources that are available to fight things like COVID-19. The basic tools of epidemiology that are instilled upon community-based volunteers, instilled in staff of the ministries of health of the respective countries. Those are resources that can be tapped into not only for guinea worm, but for COVID-19, for polio, and other diseases that really devastate communities around the world. And so I would say to the world, an investment in guinea worm to see eradication through not only instills hope and inspiration to coming public health leaders and supporting healthy, viable populations that can pursue their own individual aspirations, but also in terms of providing key investments into building sustainable, long-term public health structures that we now know, based on COVID-19, we need more than ever. The contact tracing that is required for COVID-19, that's what guinea worm workers in remaining endemic countries do every single day, following up on guinea worm cases. And so that's really where this becomes a key investment for the world to continue to pursue.
Right, so there's a whole pot of collective and important knowledge there. We've skirted around this sort of the tying of this debate we're having about eradication and the lessons learned from smallpox. We've skirted around the issue of COVID-19, but I'm just going to ask you, and maybe Bill, you could take this on with your experience. When you look at the way the world has responded to COVID-19, and of course now the focus and the excitement is all about the possibility of a vaccine that might be rolled out at the end of this year and through the course of next year, which Pfizer and BioNTech are telling us should, they think, be very effective against COVID-19. Is the word eradication relevant to our efforts against COVID-19, or is it much more a question of just tight control thanks to the vaccine, but we are not looking at eradication? Or is eradication something that should be on the agenda for COVID-19?
The word eradication for COVID-19 is premature. And let me go back just for a moment to the economics. When the US became involved in smallpox eradication, we had not had a case of smallpox for over 15 years. And so it took some doing to convince our government that this was worth the investment. But we now save that investment every 3 months because of eradication. And we save more money in the US because of smallpox eradication than our dues to WHO. So there's the economic argument. The second thing on culture, I learned a long time ago, if you tangle with culture, culture always wins. And we have to remember that with COVID-19. With these new vaccines that are about to appear in the marketplace, this is a great step forward, but it doesn't substitute for what we've learned about masks and hand washing and distance, because 50% of people in the United States say they would not take the vaccine. And so here we have a cultural problem, because even if it's 90% effective and 50% of the people take it, that still leaves 10% of those having taken it who are not protected, but you don't know which 10%. So they have to continue using masks. And it also means 55% of the total population is unprotected. Nonetheless, the vaccines will be a very good step forward in controlling this disease, and culture will appear, because the people most reluctant to take the vaccine in the United States are people in the minority population who would benefit most. And so we have to find, who do they trust in order to get the message across that the vaccine is actually useful. My hope is that with the first vaccine doses given, we will see the results of a reduced incidence in those people, and that even the reluctant people will then be willing to take the vaccine. But all of these problems are very complicated, and to even think about eradication right now is very premature.
That's very helpful. That's a great, simple way of explaining to us we shouldn't run before we can walk, if I can put it that way. Thank you very much, Bill. Everybody watching around the world, I did say at the beginning that we wanted your questions and insights and observations to put to our panel here, and now's the time. I'm just going to flip from me driving the conversation with my own questions to what I'm sure will be much better questions coming from you guys. So let's formally declare now that the focus here on this panel is going to switch to your questions coming from around the world. Okay, so that little pause gave me time to just look at the questions that are coming in, and there are plenty coming in already. So why don't I just, because Don, you haven't spoken for just a little while, I'm going to put this one to you, and it builds on what Bill was just saying about trying to persuade people to trust what science is saying about the vaccine, and for people essentially to take the science at face value, take it seriously. This question basically says, clearly behavior change is hard, and right now we have some political leaders who in many ways are spreading anti-science messages. How worried are you about this, and how do you overcome disinformation and political apathy when it comes to really getting momentum behind a public health program, including an eradication program?
Well, I should say up front that I'm by nature an optimist, but I think that the most important thing, again, is to recognize that each individual will act in what they perceive to be their own interest. And so the challenge for us in public health is to, A, convince them to trust us, convince them that we are there to help them, and then to explain in a way that they understand and accept whatever intervention it is that we are recommending to them. As I like to say, most people are rational, and if approached respectfully and given the information in a way that they understand it, they will act. I mentioned earlier the difficulty in getting people to understand the fact that they were getting guinea worm disease from actions they did a year ago. Going into communities, going down to the pond where people are drinking contaminated water, filtering that water, backwashing it, and holding up a jar of the water so that people could see little things swimming around in the water, helps them to understand, make the connection between guinea worm in the drinking water in a form that you usually cannot see, and their infection. And in that instance, then people begin to understand. Additional testimony then from other communities and individuals who have gone through this experience, having seen guinea worm prevalent in their community, and then taken the actions that were recommended, and then seeing the guinea worm disappear, that becomes very powerful testimony as well, and convincing testimony in a way that people are then moved to act and protect themselves.
Thank you very much, Don. Adam, I think this one's for you. The questioner just wants to know, how has COVID-19 and all that has been brought with it affected your eradication efforts, and I guess other programs like polio eradication? Has there been a knock-on effect from this sort of preoccupation we see around the world right now with COVID-19?
That's a great question. There have been some impacts for obvious reasons related to COVID-19 in limiting the movement of some of the international technical advisors that provide support to the program in the field. There's been some impacts on research that we're engaged in to better understand the ecology, the biology of the disease, and look at potential therapeutics. Not that we have a vaccine, which we certainly would like, but it has reduced our ability to do some additional work. But we're very blessed and fortunate that the National Ministries of Health saw guinea worm and the surveillance for guinea worm as a key priority. And because we do not do what a lot of other neglected tropical disease programs do based on mass drug administrations, since we don't have a vaccine to provide to people, that has allowed us to continue to operate. And so we're about 95% operational throughout the duration of the pandemic. And we look forward to the fruits of that come next year as we expect continued reductions in the incidence of guinea worm. But again, I would also note that COVID-19 has other impacts psychologically for staff, their families, how it's interpreted in communities across West and Central Africa and East Africa, where they may not see the same 24 news hour media cycle that we see every day, but it still takes a toll. And so we've been very sensitive and supportive of our local staff and the volunteers, and continue to prescribe all of the normal expectations that we hold to minimize and mitigate potential risk of COVID. And so we take all of that very serious. So despite there being a pandemic, we continue to be very safe and secure in how the program operates in each of the countries.
Thank you, Adam. I must say, a lot of the questions coming in are wanting to relate the experiences you guys have to COVID-19. So let me give you this one, and maybe Bill, you can take this one on. For the panel, the questioner says, it seems like you guys are talking about a marathon in terms of any idea of eradicating COVID-19. Are people unrealistically expecting a sprint? And I think you've sort of already said that that is the case. There's no way that we should be talking eradication right now. But then Bill, just talk me through from your experience with smallpox. What can we expect in terms of the timeframes for truly being able to talk about control of COVID-19, and then maybe in certain parts of the world, talk about elimination, because as I understand it, elimination is about getting rid of it from certain regions and areas, even if it still exists, beyond those spaces. And then the time frame where we might, talk about eradication, is that going to be decades away or centuries away? What is your feeling of where we're at with COVID-19?
I think we're really looking at both a sprint and a marathon. If you can think of a long distance course, but we are sprinting. I mean, you see how fast the vaccine development has been. And I think one of the things that COVID-19 has brought to the fore is the separation between public health and politics is not that great. We don't make any public health decisions that are not somehow based on a political decision. And we're learning that now. It used to be that I would get upset about a political decision that did not help public health. And then my deputy said, well, it's all your fault. You should have anticipated what they needed to know before they made a decision. So we have tried to provide more information to politicians, but it's a very timely type of thing. And I think now I try to tell public health people, go into politics, and this is much more efficient. Okay, how long will it take? I think with good vaccines, we're going to see a fair amount of control within the next year or two, because people will see that the vaccines actually work. And with smallpox, it was a mystery to many people until they saw that the vaccine worked. And I think the same thing is going to happen with COVID-19. I think it'll be very difficult at first to think about eradication, because with respiratory diseases, you look at how difficult it has been to control measles because it spreads through the respiratory tract so easily, so that it's difficult. On this, and at the same time, though, the fact that it spreads so quickly allows you to do surveillance and know where it is at all times. So we're learning about COVID-19. As we learn in the next year or two and watch the case rates go down, we may learn enough to say, yes, we could eradicate this disease. We just don't know that much right now.
Right. Thank you very much for that, Bill. That was fascinating. Here's another really interesting question. I think a lot of people around the world watching this will really appreciate having you, Don, and you, Bill, on this panel, because you bring such a weight of experience and field work and everything else to our discussion of what eradication really means of a disease. So here's one, Don, that I'd like you to take on. The question is, knowing what you know now, would you treat the eradication of smallpox differently compared to the way you treated it and the decisions you took in, say, 1980? Well, that's commenting on the 40-year anniversary. But let's take it back beyond that. Let's say 1960. You know, if you could sort of, what do they call it, Monday morning quarterback, what you were doing in, say, 1960 or the late 60s, would you do it differently? Could you have actually run the smallpox eradication program better, do you think?
Well, I think one of the most important things we learned during the smallpox eradication program, in fact, was learned by Bill Foege in Southeast Nigeria, whereas in the beginning of the smallpox eradication program, we felt that the most effective way to attack smallpox was to mass vaccinate the population. And if you could get up over 80%, 85% of the population immunized against smallpox, that would allow you to stop transmission of smallpox. Bill and his colleagues in Southeast Nigeria discovered that, in fact, even much more efficiently, if one concentrated vaccinating those communities, those families that had smallpox, and the families, the neighborhoods immediately around them, that allowed you to focus on vaccinating less than 5% of a country's population, compared to trying to get up to 80, 85%. The challenge was, however, that you needed to then find out where all the current cases of smallpox were. That was a challenge, but it was a doable challenge. And so the big difference in the smallpox eradication program at the end, that compared to the beginning, was that change in the strategy that we learned during the eradication program itself.
Right. Thank you for that, Don. We're almost out of time. I'm just going to put in one last point, and I don't know if somebody could just give me a brief comment on this. Somebody's just put in this comment. Thanks for an excellent session. May I just comment on the possibility that the big pharma companies are seeking to add to their incomes because they know that mutant strains of COVID will emerge and that the vaccines will be ineffective. I guess that's perhaps a cynical take on what's going on, but is there some truth in that we have to expect that you know, these vaccines, however excited we are today, may not be that much use because there will be mutation and they may not be that effective?
I think there are three major things that have happened in global health in the last few years. Number one is President Carter showed what would happen if you got a politician involved, meeting heads of state. Number two, the Gates family showed what happened if you put money behind global health. And number three, Merck Drug Company showed what could happen if pharmaceutical companies got involved in global health. And we tend to think that they're always looking at the bottom line, and that's very important to them. But what Merck showed and Roy Vago showed is that these companies can, in fact, improve what happens in global health. And what they're doing right now, they don't know what's going to pay off. And I think it's been quite a remarkable coalition between government and the corporations to get us where we're going right now. So I wouldn't be that cynical about the only reason they're doing this is for profit.
All right. Well, I like to end on positive notes on these discussions, so I'm gonna take that as a positive. I have to tell you that all three of you have been such brilliant panelists. You've given us real insights from your work in the field. You've given us the voice of experience, and you've also given us a sense of real positivity, given that, you know, what we must remember 40 years on is that the battle against smallpox was a wonderful success story, and it is worth remembering that today as people go through the stress and strain of dealing with COVID-19. So at this point, all three of you, I'm going to give you a very big thank you from me and the whole WISH team. Thanks for participating in this particular session. It's been a pleasure talking to you. I'm going to thank everybody else for listening and watching to this session. I always like to end with a thought, and I just think my thought to end this one is that we talked a lot here about this battle against disease and the effort to eradicate disease being all about not just top-down, not just brilliant science, but also engaging with people, the people who are suffering from these diseases at their community level, winning trust, acting in good faith. If everybody in this process, from the politicians to the public health officials, to the brilliant scientists, to the people on the ground who have to take the behavioral actions to make eradication real in their communities, if all act in a way that encourages trust and good faith, that surely is one of the absolute keys to making eradication real. So with that thought from me, and with thanks to the panel, I'm going to end this session and wish all of you a very productive WISH Conference 2020. Thank you.
So welcome back to the final session of Wish on Day One. I want to thank you for joining us. My name is Ashley McKim. I'm Director of Innovation and Improvement at the British Medical Journal, and I have the pleasure of moderating today's session. This is the Agora. If you've been to Athens, on the way up Acropolis Hill, you'll see a large stone marking the site of the ancient Agora, a site where leaders, communities, and expert witnesses would come to share their news and exchange views. Those discussions and debates continued for days. You will, however, be pleased to hear that we've condensed our discussions into just 45 minutes. We'll be considering the question, in the time of COVID-19, have all other diseases become neglected? We hope you'll also discuss this via the WISH website and in social media. We'll have a panel of 12 members of the WISH community who I'll bring into the conversation in a few minutes, but I want to first turn to Michael Byrne, who is Head of Technical Advice and Partnership at the Global Fund to Fight HIV, Tuberculosis and Malaria. Michael, I want to kick off discussions today and get your thoughts on whether it's made it harder for governments and NGOs to pledge the much needed money we need for global health initiatives because of COVID. Michael.
Thank you and good evening all. It's a pleasure to be here with you. So mobilizing resources for health takes a lot of effort, and it's more difficult in resource-constrained environments. So the negative socioeconomic and fiscal space impacts from COVID will make it even harder in the coming years for financing for health. But the imperative to invest in global health initiatives is stronger and more important to undo COVID's negative effects. Prior to COVID, Global Fund and other international organizations like Gavi secured significant pledges for our mandates. Global Fund is currently investing over $14 billion in 120 countries as a result of our 2019 replenishment. And that's thanks to the support from a large coalition of governments, foundations, civil society and private sector partners. And more importantly, based on the terrific progress we've achieved in the fight against HIV, TB and malaria, saving 38 million lives, 6 million in 2019, and cutting the mortality from the three diseases by half since the peak of the epidemics. It was our largest ever replenishment, and Qatar, one of our partners, boldly increased its pledge by 5 times. So we continue working with our partners and governments to ensure that these pledges are realised, and we're quite confident that they will be. And as part of the COVID response, Global Fund is lending its expertise to the international community in response through playing a key part in the ACTA, the Access to COVID Tools Accelerator, which is a groundbreaking coalition of global health partners to develop and deploy vaccines, treatment, diagnostics and health systems to help the fight COVID. The innovative mechanisms have made major achievements, but more is needed and funding is required. ACTA's financial ask is 38 billion, of which 10 billion has been already secured, but there's still 28 billion outstanding, including 4.6 for immediate needs. Global Fund is estimated that it needs 5 billion to support the ACTA effort to mitigate the impact of COVID on HIV, TB area programs, reinforced health systems, and support national responses, including to protect frontline health workers. So the fight against COVID, it's not just about vaccines, it's also about diagnostics and health systems for delivery, which are also critical. I think importantly too, it will be essential to mobilise resources beyond the usual official development assistance budget, as this will not be sufficient to support access for health for all. So ACTA A partners are calling on the G20 to urgently mobilise the 4.6 billion to treat the causes and not just the consequences of the pandemic. Thank you.
So Michael, thank you. It sounds like you're doing fantastic work during this period to kind of continue the work that you're doing already. I want to ask you directly, so the areas that you focus on, particularly malaria, AIDS, TB, are we at risk of undoing a lot of that work because of COVID?
So we started 2020 acutely aware that we were off track on all 3 diseases towards the 2030 disease goals. On HIV, for example, continued progress in reducing deaths has not been matched with reducing new infections, which was 1.7 million in 2019 and flat over 2018. On TB, we're making great progress in finding missing cases. We still have 3 million people on TB that remain untreated and undiagnosed, and we have about 1.5 million deaths annually. On malaria, we're also making progress on reducing deaths, and we're making little progress on reducing the actual number of cases. And we are seeing alarming increases of cases in some of the highest burden countries. The knock-on effect of COVID is catastrophic for other diseases. Deaths from HIV, TB, and malaria could double in the coming year, putting at risk decades of hard-won, hard-fought progress. We see programs significantly and severely disrupted by COVID-19. Reduced TB and HIV prevention services, leading to potential rise in new infections. We've seen HIV testing decrease by 50% in some cases. We are seeing a resurgence of human rights-related barriers to accessing health services, gender-based violence and stigma. We're also seeing a diversion of resources and equipment to the COVID response. For example, we see lab capacity being diverted from testing TB and HIV viral load towards COVID testing. We're seeing too significant pressure on primary healthcare systems and increasing reluctance to seek healthcare for fear of COVID-19. And that, for example, has undermined service and treat for malaria. Marginalized and key populations are the most vulnerable. They're the first to lose access to services when health systems become overwhelmed, and they're the first to suffer stigma and discrimination, which can resurface under the guise of public health. Now, the fight against HIV, TB, and malaria and the fight against COVID are the same fight. And all the expertise that we have in fighting the three diseases can be used for fighting other infectious diseases, COVID. And that's why Global Fund is part of the ACTA coalition. And we also, country level, that the expertise gaining and scaling up HIV, TB, and malaria programs is proving a robust foundation for how countries are adapting to the fight against COVID. To protect the hard-won gains and sustain momentum against the three diseases, Global Fund took action and mobilized $1 billion to support countries for pure COVID responses, mitigate impacts on TB, HIV, and malaria programs, and to strengthen community systems. And we're also working with countries to adapt their their disease programs to the COVID context. So, for example, changing policies for TB and HIV medicines to enable people more easily get and stay on their treatment. Changing how we organize mass campaigns for protection against malaria, moving from mass campaigns towards door-to-door distributions. And also putting more emphasis on an increased role of community health workers in providing basic healthcare services for a more people-centered approach. Thank you.
Thank you, Michael. So we'll continue these discussions over the next 30 minutes or so. I want to take a pause for a second to bring in the rest of our Agora. So we'll pause for a minute, we'll come back and we'll have those discussions afterwards. So welcome back, and pleased to have our additional members of our Agora with us on the screen, joining us from all over the world. But I'm afraid we're going to go to the old school method of raising your hand on screen. So I'm hoping we'll have a great discussion over the next 30 minutes. We want you to contribute your thoughts, your ideas, ask some questions, bring in some of the thoughts that Michael had as well. So please, if you've got a point to raise, please raise your hand and we'll come to you as we go through. I'd ask you, first of all, to introduce yourself, your name and your organisation before you speak. So please do raise your hand if you have any questions right now. One of the things I want to start off by talking about is really that first question about fatigue, that we've had COVID now for, coming up to 10 months of the year. Many of our Agora panelists are either people who run healthcare systems, they're people involved in NGO charity work that happens around the world, or delivery of service. I'd love to hear your thoughts about whether you feel that we're starting to reach fatigue in the system and the impact that will have for you in treating other diseases, mental health, cancer, neglected diseases as well. Any comments from a panel on that? Maybe I can talk to Kate first of all. I know, Kate, if you're on the call, coming from your background in Orbis, any reflections on how that might affect you and your organisation going forward?
I think it's early so far for fatigue to set in, but the one thing we are facing is just a huge backlog. And I can talk about the Rohingya project, which is funded by QFFD and has been funded by the past 3 years. And to give like a snapshot of what the backlog is that we usually treat 6,000 people for surgeries over 3 to 4 months. And while that camp was locked down, we basically were only able to treat 38 people. And so you can see how the backlog is just going to grow and grow and grow. And that will inevitably soon have a fatigue effect on staff. And today I was just talking to one of the team, and he was telling me about the bus driver. So the bus driver now has to make multiple visits in and out of the camp. And just small things, bringing it down to kind of a very personal level. So he's having to work twice as hard. The screening team's having to work twice as hard. The people, the surgical staff at the hospital are now having to work 3 or 4 times as hard in order to meet the huge backlog that is now building up due to just a 3 or 4 month lockdown. And then going forward, we don't know how long. Services are not at full capacity. They won't be at full capacity for a long time. So we're going to be working in this slower, more intensive way in terms of social distancing, use of PPE equipment, like the chap was saying earlier about working at more community level, going door to door. It's slower, more intensive, and also more costly. And I think that is a key point that needs to be examined further.
So thank you, Kate. It's really great to get that experience from on the ground from the global health perspective. I'd like to bring in some of our other panelists. I know some of you come from backgrounds working in healthcare organisations. I know in England, where we're broadcasting from today, that our waiting lists for some surgeries have now risen because we've been closing hospitals for COVID, and some of those are now back to the 2008 as far as waiting times for patients there. Any reflections from people running organisations about the impact it's having on other services, cancer, mental health? Examples like that? Yes, please go ahead.
So Jim Cleary, I'm at Indiana University, the Simon Cancer Center there, and lead supportive oncology and palliative care. Across the cancer spectrum, we're actually seeing a drop-off in services. Prevention services, so if we look at giving vaccination for HPV, screening services, people not coming for colonoscopies, not coming for mammograms because they can't do this. And we're actually seeing people not come for treatment. And that's not just in Indiana, but it's global. When you have a country shut down, how do you even get in for care? And I'll finish by saying that we're actually also seeing a drop-off in palliative care services. And across the board, we now have millions of people in the world dying alone without their families present because of COVID. So this is a dramatic impact, which I think we're not even addressing. How do we provide care for people with COVID and other diseases, given the infectivity of this virus?
Thank you, Ian. And I think we had a comment from somebody else in the panel I want to bring in.
Yes, hi. My name is Kashif Ijaz, and I'm the Vice President. Hi, my name is Kashif Ijaz, and I'm the Vice President for Health at the Carter Center. In our experience, because we are actually involved in the control and elimination and eradication of the neglected tropical diseases, for instance, in guinea worm, we have been doing pretty well even during the era of COVID. We're about 90–95% operational. And, our community event-based surveillance has been going really strong. And, as a result of that, we have seen a decline in the guinea worm cases, human cases, about 56%. They're down to about 24 from as compared to last year. And then, we've also been seeing a decline in dog infections, about 26% as well. And it's not because of lack of surveillance, but it's actually because we are still seeing a lot of good community event-based surveillance. On the other side, when you're looking at some of the other neglected tropical diseases like river blindness, as well as trachoma, and lymphatic filariasis, we've been dealing with, what I call as building back better, in terms of, trying to do the MDAs the mass drug administrations and restarting that because based on WHO's advice, we had actually stopped doing that, but now they've actually put out guidance on how to restart it. And we've been doing risk assessment and mitigation action reviews in order to restart some of those efforts in countries like Uganda, where we are actually starting the MDAs for river blindness. And in addition to that, we are also doing MDA with a triple drug for the very first time for lymphatic filariasis in Haiti. So I think yes, I mean there is a silver lining to the dark cloud, as I say, in order to sort of get back to where we need to be, which would require a lot more effort in terms of assessments, because there's also there would need to be obviously a PPE provided, as well as in addition to that integration and coordination of efforts with the ministries of health, because in order to avoid both the community fatigue who are actually going to get these MDAs, but also the community health workers and sort of coordinating with them as well. So I'll just stop there. Thank you.
Wonderful, thank you. And it's nice to hear some positive views for the future of how we come out of COVID as well. Let me invite some of our other panelists who haven't spoken yet to come in and join us. If you'd like to just come in and raise your hand, that would be fantastic. Anybody
Hi,
from
Didi
yes,
Thompson.
Please go ahead. Unfortunately, I can't see your name, but please go ahead and join us.
Sorry, this is Didi Thompson. I'm one of the research partners from WISH and an honorary fellow at Imperial College. I think one of the interesting things that we've seen from the COVID pandemic has really been the shift to a massive uptake in telemedicine and digital and data solutions. And I think that's something that could be seen as a positive for the future, but also needs to be viewed, I guess, a bit warily in terms of the digital divide. So some people are very comfortable with internet access, with accessing care that way, but we really risk kind of losing those people that may not have internet access, that may be elderly, that may not be sort of hip to the digital age. And I think that's something moving forward that we really need to think about, because I don't think that there's any going back to the pre-COVID era of not having digital consultations first. And I think that's, a bit of a mixed message, and it'll be interesting to see how that plays out. Thank you.
Thank you, Didi. And I want to bring in some of our panelists again as well. That I'd hope, and we've seen in previous pandemics, that amongst all the pain, the suffering, the deaths that we unfortunately see, there's also a lot of innovation. And we've seen in previous, from right back from smallpox, the innovation of the formation of global bodies that will help to tackle health, but also through this innovation in everything from track and trace to vaccine development. So let me bring in, I think somebody just raised their hand there to come in and make some comments on that. Let's continue that discussion on how we might be able to innovate to tackle some of those diseases that have been neglected. Yes, please go ahead.
Yes, thank you. I'm Dina Al-Asfour from Oman, and I'm glad you brought up the innovation, because from what we've seen here, there was a remarkable resilience in the system where we've seen primary health workers and other workers have done amazing things just to adapt to the situation and make sure that every child gets immunized and every patient gets seen. So we have, to talk about, for example, digitization. In cases where there is not available computers, there was always phone calls to the patients, and there were and there was some creative things, like patients were seen, were given their medicines, were asked to stay in their cars, and the doctor would or the nurse would go out and give them their medicine in the car to avoid the crowdedness of primary healthcare places. And there are many examples to that. So one thing that I wanted to raise as well is that this issue, it brings the question of resilience in health systems, for which we have been discussing for many years. But COVID showed us that resilience is an essential component of the health system, and it's an important pillar. And we should not be relying just on how strong is the health system at the times of comfort, but also at the times of crisis. Thank you.
Thank you for sharing that. And I hope that throughout the rest of this week at WISH, this is all about innovation. It's about those ideas that we're going to be improving healthcare, that we'll all be able to pick up things that we can take back into our respective organisations and help to make a sort of evidence-based approach to how we improve care for all those other conditions that, as we've discussed today, may be neglected somewhat during COVID as well. Anybody else want to come in on that? Let's maybe continue the discussion on innovation a little bit. Anybody who's not joined us yet who wants to bring their experience from their organisation to this panel? And if not, maybe I can come back to our colleague from the Carter Centre and just maybe reflect on your thoughts on that. Didi earlier mentioned about the fact that we have to be very careful of this digital divide, creeping up, and for cost-constrained economies from low-income countries who are maybe tackling those other diseases. Any thoughts from your perspective around how we can apply technologies that don't neglect those populations and don't neglect the diseases that affect those populations?
Yeah, thank you very much for the question. I think that, definitely in terms of training, we will actually have to do a distance learning and distance training, because we've actually done that for some of the laboratorians, on the diagnostic side of things, where we've actually basically gone to them and provided them with experience related to some of the methodology, and the methodological changes or advancements in terms of innovation of some of the diagnostic tests. So that is definitely an area where we can actually work together, in terms of using the learning technology in an era of COVID. But then in addition to that, like I was mentioning before, there's definitely, when you're doing the MDAs or the master administrations, you definitely have to do it, and do some field work. And that's where the policies and the SOPs really become important to make sure that the healthcare workers are, protected, and there is enough personal protective equipment available for them, whether through donations or through the Ministries of Health, and that's where the collaborations become really, really important. In addition to that, I think you mentioned a little bit about the mental health aspects as well, and Carter Center has been, our mental health program has been working, especially on the lymphatic filariasis, and that's where we have seen some good interactions between the mental health and LF related to chronic disease, self-management and intervention efforts in Haiti. And then, so in the era of COVID, we have been actually, practicing social distancing and still, helping them as much as we can in terms of mental health efforts. So I'll just stop there. Thank you.
Wonderful, thank
you. So technology has actually
we've
helped a lot.
We've got 4 new panelists with us. Thank you. For our new panelists who just joined us, again, please contribute to the discussion. This is an open discussion. Please raise your hand in the old-fashioned way. I unfortunately can't see who you are or where you are, but if you raise your hand, we'll come to you and put you on the big screen and take your question. So we've got a gentleman I can just see in the bottom of the screen with glasses, with red carpet behind him. If we can go to him, and we'll take your point.
Yes. Hello, I'm Ahmed Dalal. I'm the Dean of Georgetown University in Qatar. I'm not in the medical profession, but speaking of innovation and in terms of policy, I think there are obviously in relatively wealthy and affluent societies, there are huge challenges that the pandemic has presented. We've seen, as has been already noted, a dramatic decline in preventive screening and monitoring of chronic diseases, and for understandable reasons, for fear, number one. People were and continue to be afraid. Actually, every time I go to a regular checkup, I worry tremendously, and I think it's only not normal to do that. I think the medical systems they have developed and continue to develop, especially in affluent societies, mechanisms to deal with medical care, with regular medical care under current conditions. But there is so much more that needs to be done. There are also other challenges, even in affluent societies, challenges such as how do you collect test samples, insurance systems, and how do they apply in the conditions of the pandemic. That said, I think we also need to think of the longer-term consequences of the pandemic for poor countries with fragile health systems. I think this is so much more serious, and it has huge long-term effects. Already, the current recommended strategies to reduce transmission, isolation, the use of protective gear and protective PPE, and so on. All of these measures are extremely limited in many parts of the world, in huge parts of the world. There are limited availability of protective equipment. The high percentages of populations who live in settings where social distancing and hygiene are physically impossible in many cases, or extremely difficult. Even if the population is prepared to adhere to these measures. Medical and health staff are at very high risk. There is a shortage of medical and health staff, and then, of course, under the current conditions, they're at very high risk. So there is a shortage and depletion in medical staff. There is also a prevalence of multiple diseases, chronic diseases, immunodeficiencies, and so on and so forth, in many of these same parts of the world. And patients in need of specialist care in rural areas and rural settings are unable to access medical care, and so on. Immunization programs are severely compromised currently, and I think there are lots of indications that this will only become harder under current conditions. So I think it is important to develop strategies for these parts of the world. I mean, it's already hard enough in affluent, but in these other societies, it is potentially disastrous. Add to that camps, refugee camps, displaced populations, areas which are plagued with violence and conflict, areas which have food shortages, natural disasters. I mean, there are parts of the world which are suffering from locust swarms. I mean, swarms as if we don't have enough disasters on our hands. There are all sorts of, there are other areas, of course, where we have other pandemics, which are still, which are still there and still quite risky and dangerous. So I think it's extremely important to start thinking of these areas and develop, as some of the, as I'm sure, I'm sure some major international organizations are thinking of that, but I think this is where the real challenge lies in the long term. And I think just to conclude, I think it is important when thinking of these situations to think of measures which draw on local, customize the solutions to the specific locales in which need intervention, and mobilize the local communities in thinking about solutions. I don't think there is one solution that fits all. I think it's a luxury to think about the use of technology and so on and so forth. And maybe there is some use of technology in some of these locales, but I think it's much more important to think realistically of solutions that cater to the specific situations in which people live. As I said, I'm not in the medical. My father worked for the WHO for many years, and he worked in situations like this. He gave me a sense of the type of interventions that are workable in different. He worked in different countries in Africa, and I sort of have a sense of flavor. But coming from a school of foreign service, where we deal with policy issues, I think it's extremely important to develop policies for long-term solutions.
Yes. Wonderful, thank you. Well, as you pointed out, I think we've got lots of challenges, globally in healthcare to deal with over the next couple of years, and I know we're addressing some of those during this week at WISH as well, in the future panelists. Let me bring in some people. I know some people have just joined us. For those who haven't had a chance to speak yet. Anybody like to make a comment if you haven't spoken yet? Just please raise your hand and we'll come to you just for a quick comment before we end. Yes, is that Faraz? Faraz, please go ahead.
Yeah, that's me. So this might be slightly murky territory that I'm. Hold on, is my mic on? Let me. Okay. So I might be going to slightly murky territory. There is the obvious effect that COVID has had on the planet, tangible effect. If we're talking about how cross-cutting it is, how it's basically brought the world to its knees. But I think another thing, a bit of an elephant in the room that nobody really mentions, is it's quite politicized compared to other infectious diseases, at least in my living memory. And I feel like that might be a factor that might be considered if we're talking about diverting momentum to other infectious diseases as well. Would you say this is a valid comment or not? I defer to the jury.
Any reflections on that political aspect of how we've dealt with COVID?
It's certainly politicized here in the United States.
Your hand, but if you're raising your hand, please go ahead and jump in.
Sorry, I wonder if I could pick up. Can you hear me?
We can hear you, yes. Please go ahead.
Hi, Ian Tully. I'm the Chief Executive of the Mental Health Service at Hamad Medical Corporation here in Qatar, and the National Strategy Lead for Mental Health and Wellbeing. I wasn't going to comment on the politicization, but I wondered whether or not I could relate to some aspects of mental health and go back to the point on innovation. Now we've heard about the challenges of people who have struggled to access services, particularly those with non-communicable disease, hypertension, diabetes, cancer, etc. In a specialty like mental health that was struggling anyway, it seems to me that the challenge has only got bigger as a result of COVID. Now, I think a blessing from COVID is that it seems much more normal to talk about mental health and psychological distress as a result of COVID. We've seen a huge rise in those people who are seeking help from our services, and we opened a national helpline in Qatar, and we've seen a massive rise of people who are seeking some form of psychological support. Now, I noticed last week, for example, that NHS England published their new metrics for monitoring the impact of COVID, and of the 17 new metrics that they introduced, 14 of them related to mental health and psychological distress and the use of drugs and alcohol. And it seems to me we have got, yes, we're dealing with a pandemic, but we've got an epidemic of mental health, and the aftermath and collateral effect of COVID is going to be huge on our psychological well-being. So I think in terms of how are we going to, if we were struggling in the past, what does the future look like? So I think the benefit of people being prepared to talk about mental health is a step forward. But how do we use innovation and technology to provide much greater access to people? How do we ensure that all healthcare staff are equipped with the skills and capability to at least understand when someone is presenting with an anxiety problem or depression, etc. And I think we need to find a way of almost mass training people so that they can start to identify and respond to the needs of people with a mental health difficulty. And I do think technology plays a massive part on that. But the human effort and the human capital that we will need to invest will be far greater than we've ever done before. So I would hope that that we can start thinking around the world about how we use the human capital we've got to provide much greater access to those people who will suffer over the several years to come.
Thank you, and I think it feeds into a lot of what we talked about today at WISH, that actually a lot of the world came together to deal with the pandemic, and I think, as you're saying, that we need to all get together to deal with some of the implications and other diseases as we move forward as well. So we've only got a couple of minutes left. I want to come back. I know we had a sort of point or somebody raised. It was a lady who's on my screen I can see with some beautiful fern wallpaper behind her. If you'd like to come in and add to the conversation.
Yeah, about the misinformation, about the politicization. I think COVID came in at a time. The world is really different from the Spanish flu. We are living in a very complex world with a lot of political unrest, a lot of conflict between nations, and technology booming. So all that, I think, fed into the conspiracy theory of COVID. And made it sound political, but it's actually, today I was telling someone who sent me a message on WhatsApp, and this is one, that happens every day almost. Someone sending you a message that this is all a political thing and it is a conspiracy and so on. And I responded to her, 1 million people have died so far. That's not political at all. That's people's livelihood and survival and poverty that are suffering from. So I think the world is different now, and that's what made it look as if it is a political issue. And I'll stop here.
And my final question, I want to ask you one final question before we just end. Do you feel positive or negative towards the future of the impact on other diseases, neglected diseases going forward from COVID after the discussion today? We're getting a wave.
I would say that. I would say that we should still be optimistic about it. I mean, yes, we're dealing with a challenge, but a challenging situation certainly. But we have done this before. I mean, post SARS and H1N1, and then so there have been challenges and challenging situations before as well. So Ebola is another one, which we have actually done a lot of good work in building health systems post-Ebola in Africa, certainly. So I do think that I certainly remain optimistic about being able to, what I call as building back better. So I hope my other colleagues on the panel also feel the same way, because that's the only way you can feel in public health. Thank you.
If I may.
Anybody else? If you raise your hand, if you think we can build back better.
If I may, just a
Quite a few
quick comment.
People. Fantastic, thank you.
I think the pandemic has been a wake-up call. I mean, there has always been other diseases that are probably more deadly in terms of the amount of people that they kill, but they've been localized. This one does not distinguish between anyone. I mean, it's become a global pandemic, and it's affected everyone, and it's brought economies to a halt, and it had so it had impact on everyone. So hopefully, if we learn the lessons of this pandemic, there is hope, but there is no guarantee that. And I think it's important that we continue to be aware, to try to learn the lessons of this pandemic and the vulnerability of humanity as a whole, and the weaknesses and the gaps in our preparedness and in our social systems and in our economic systems and our ability to prepare for situations like this. If we learn the lessons of this pandemic, then there is hope, but there is no guarantee that we will. And I think we have to be diligent, and there has to be a high level of awareness if there's something good that's going to come out from this, because so far it hasn't been good. So far it's been
wonderful.
The effects of
I'm going to have to stop you there because we're going to run out of time very soon. But thank you for your comments today, and I want to thank all of our panelists. It's been fantastic to hear reflections from all over the world, from different backgrounds, from different organizations. We've got a tough couple of years ahead after COVID to make sure we don't leave these neglected diseases to get worse. But I think there's a lot of enthusiasm there, and I think on general, the positivity of us working together to solve this is there as well. We'll be covering this during the rest of the week at WISH, so please join us for the rest of the sessions. Please continue this discussion on WISH, on the website, and on social media as well. Thank you for joining us. We hope you enjoyed today, and we'll see you again tomorrow. So thank you and good night.